And so fortunately, we've been able to offer it and I guess conscript, or I don't know, but Dr. Arthur Ohlendorf from Virginia Tech has graciously agreed to succeed me in the role of the obstetrics co-chair. Dr. Ohlendorf comes recently from North Carolina, where he had similar role in the Perinatal Quality Collaborative in North Carolina. And so I'm pleased to introduce you to Dr. Ohlendorf. Arthur, do you want to introduce yourself just real quick to the group?
Yeah, no, well, thanks for that sort of introduction. Yeah, no, I'm just really excited to be part of this group. And, you know, I have done some of this work in North Carolina. We call it the Maternal Project Lead. But I think it's learning, you know, what's important for the Commonwealth and knowing some of the skills that I was able to learn in North Carolina. So excited to meet all of you over the course of time. Thanks.
And with that, Shannon, I think we can turn it over to begin the first talk of the day.
Excellent, thank you. So it is my pleasure to introduce the group to Dr. Dane De Silva. He's the lead MCH epidemiologist with the Virginia Department of Health, and he currently supervises the MCH Epi and Evaluation Unit in the Division of Population Health Data. He and his team provide epidemiology and evaluation support to the Title V Maternal and Child Health Block Grant and MCH programs at VDH. Originally from Vancouver, Canada, he worked in clinical and public health research around preterm birth and preeclampsia. Dr. De Silva is an experienced population health researcher rooted in life course framework, and his research interests include the intersection of social determinants of health with birth outcomes, reproductive health, and infant and child health. He earned his Master's of Public Health with a focus in maternal child health from the University of British Columbia and his doctoral degree in maternal and child health from the University of Maryland. Welcome, Dr. Dane De Silva.
Thank you, Shannon, and good morning, everyone. Thank you, everyone, for joining us today in our great summit. We have a lot of talks planned today, but the first thing I want to introduce to everyone is mortality in the 4th trimester with a specific focus in Virginia as well. And I apologize in advance if my cat starts meowing, but you might hear him in the background. So first off, I just want to say that I do have nothing to disclose. So to start off, I just want to tell everyone kind of where we get our data on maternal mortality in Virginia, but also as well if people are interested in at the national level as well. So really the first source that we track maternal mortality from is through vital records, which is through the death certificate. And so we use typically the indirect and direct obstetric causes, which are listed with the ICD codes there. But also specifically for those interested in the postpartum period and the 4th trimester, there's also the late maternal deaths, and there are also these ICD codes that are used as well. For other, because the first two really relate to indirect and direct obstetric causes, there is also the pregnancy checkbox on the vital records death certificate, which can help identify deaths due to other manners and circumstances as well. But I've placed an asterisk here just because sometimes this pregnancy checkbox has been shown to be a little bit inaccurate, although I know investigations through, if there have been autopsies done, they tend to be more accurate, but in general, sometimes they can be a little inaccurate, although it's still useful in identifying some pregnancy-related mortality. And second, there is a tool that the CDC uses called CDC Wonder, and this is a database and it's freely available that you can search. And it also has deaths, but you can filter it through state, you can filter it through other demographic factors as well. But this is also based on the vital records. And so what CDC does and NCHS, which is the National Center for Health Statistics, they will take state pregnancy or state death certificate data, and they will try to clean it up. And they do try and clean up that pregnancy checkbox a little bit. So you will see some numbers or counts that are a little higher than maybe what might be reported at the state level. However, this is still a very important tool that can be used as well to look at maternal mortality. And also you can look at inpatient hospitalization data for deaths occurring in a hospital setting. So each state does have an inpatient database as well that can be used. And this is also very important for tracking maternal morbidity. Which can be a precipitant of maternal mortality. So if you also want to track maternal morbidity, inpatient hospitalization data is also very useful and a rich source as well. And the last two that I want to introduce to as well, which my colleague Dr. Melanie Rouse will be touching upon, is the Maternal Mortality Review Information Application, or the MARIA system, which the Maternal Mortality Review team uses for more in-depth analysis of maternal mortality for cases that they review. And as well, the pregnancy-associated mortality surveillance system as well. I'm not going to go into detail too much, as I believe my colleague will discuss those, but I still want to talk about those as two important sources as well. Next slide. So I wanted to kind of put together some trends so far of maternal mortality in Virginia. And so this is a 10-year trend, and I just want to point out that 2021 data are still preliminary, as counts and things are still being finalized and have been submitted to CDC, but I still want to show this last year of data as well in this 10-year trend. So I've put together the deaths related to or aggravated by pregnancy, again, using those indirect obstetric causes or direct obstetric causes and occurring within 42 days within the end of a pregnancy. And so we do see that since 2011 in Virginia, deaths have been increasing. And again, these are rates per 100,000 births. So we do see in this past year, we are seeing about a rate of 50 maternal deaths per 100,000. Next slide. I further broke this down by race and ethnicity, and I think this really tells a better story, or, well, not necessarily a better story, but a stark contrast kind of to what is really driving these increases. And so we do, again, see that when breaking down by race and ethnicity, the highest rates have still fallen upon the non-Hispanic Black population. And in this past year, we see that now it's increased to about triple the rate of the non-Hispanic White, which is in red, and the non-Hispanic Black is the orange line here, with the blue indicating the Hispanic. But we do see in this past year that it shot up quite a bit, and it matches reports that we've been seeing as well on a national level, where the maternal mortality among non-Hispanic Blacks have increased more than it should really be. And so there really is a lot of work here that needs to be done to bring that down. Next slide, please. And to focus a little more on this fourth trimester, the late maternal deaths, again, using the ICD codes 096 and 97, which are obstetric causes, and this time period is 42 days to 1 year postpartum. We do see, quite a zigzag of in the rates, but it is still on the increase here as well. And I did not separate this by race and ethnicity at the state level just because of such few numbers, but And again, also this doesn't take into account other causes such as injuries or manners such as suicide, homicides, and accidents. But we still do see a large proportion of deaths in this postpartum period. And data do show us that there are significant racial disparities here as well. Next slide. So I kind of wanted to highlight this quote, which really is telling as well. This is by Dr. Allison who's in the Department of Obstetrics and Gynecology at UNC. But the baby is the candy, the mom is the wrapper. Once the candy is out of the wrapper is cast aside. So we're often not thinking, especially in this postpartum period, there's so much intervention that can be done as well, especially when deaths do occur during this period. And so we can't really forget about that once the baby is delivered. Next slide. And so there is this concept of fourth trimester, which I'm sure everyone is familiar with, but the data do show us that 1/3 of pregnancy-related deaths occur after the first week through the 1 year after delivery when they have the least interaction. And as I said, that they do have significant racial disparities. And so this concept of fourth trimester, which is the first 3 months after birth, really provide a time where there can be more increased intervention rather than just one single 6-week postpartum visit. Next slide. And this led to the ACOG really redefining that postpartum care period, of which Dr. Allison was one of the task force members. But really kind of, as we see here, this figure comes from the ACOG committee on redefining postpartum care, but really, as we see, like instead of that bottom part where we just have that 6-week visit and that traditional period of rest and recuperation, there is this recommendation for having more frequent contact in that first 3 weeks, getting those signs checked, and such as blood pressure and high risk checkups, and ongoing follow-up as needed throughout this 3-month fourth trimester period. Next slide. And so I wanted to highlight a little bit of some of what the data is showing as well around postpartum care. And this data comes from PRAMS, which is the Pregnancy Risk Assessment Monitoring Surveillance System. And it's a survey system for those who are unfamiliar that CDC implements in statewide. And there are core questions that all states have to ask, and as well as some standard questions that states can choose to include as well. And so this data from PRAMS in this last year of data that we have, which is 2020, we have about 87% of women and birthing persons that sought postpartum checkup. But this really varied by race. As we see here, 94% were non-Hispanic white, but we see 80% in non-Hispanic Black and 74% among Hispanic population. So definitely some missed opportunity there. And some top barriers to postpartum care that were identified in 2020. The majority of women seem to have felt fine. And the point I just want to also emphasize as well is this survey is done between 2 and 6 months postpartum. So again, this survey, when done, falls still in that 3-month postpartum period or the fourth trimester, but still a majority suggested that they felt fine. Too many other things going on. A lot of people selected other and wrote in that it was a COVID pandemic in the 2020. In 2020, so we do see 27% here. And then fourth, we do have a lack of health insurance as well, about 1/5. It'll be interesting to follow up and see how these barriers might change, especially with the Medicaid postpartum coverage having changed. And I know that talk is also coming up shortly. But as well, what PRAMS doesn't necessarily include, as well as some information on discrimination experienced in the postpartum care. We do have data on the prenatal care period, and we have and data do tell us that discrimination and structural racism do lead to poor birth outcomes. But we also do see other studies in that postpartum period where it is also a factor as well. And even as recently, there was a study assessing language used in medical records where they found healthcare providers more often described Black patients with negative descriptors, such as non-compliant and agitated. So really, there is so much work in this fourth trimester period to keep in mind as we're trying to address maternal mortality in this period. Next slide. And finally, I want to kind of talk about our Title V goals. And Title V is the Maternal and Child Health Block Grant that was part of the Social Security Act. And so each year, states do track maternal mortality through our national outcome measure number 3. But in Virginia specifically, we have developed our own state outcome measure to be able to reduce that Black-white maternal mortality disparity ratio to 1, so that there is no disparity between the two populations. But of course, based on everything I've said, and to address maternal mortality, we can't only just understand and prevent the clinical indications, but it's also important to understand the other causes, manners, and circumstances. And this leads to segue to my colleague, Dr. Melanie Rouse. So she was born and raised in Richmond, Virginia, received her bachelor's in biological sciences from the University of Delaware before completing her master's of science in health promotion and PhD in health services research from the University of North Carolina at Charlotte. Her research interests include social determinants of health and racial and ethnic disparity in reproductive health and maternal mortality. Dr. Rouse has been with the Virginia Department of Health since September 2015. She began a career at VDH as a maternal mortality projects coordinator and currently serves as the Virginia Maternal Mortality Projects Manager in the Office of the Chief Medical Examiner. And in this position, she manages Virginia Pregnancy-Associated Mortality Surveillance System and the Maternal Mortality Database. She also coordinates all activities for the Virginia Maternal Mortality Review Team. Dr. Rouse was instrumental in establishing a partnership between the MMRT and the Virginia Neonatal Perinatal Collaborative to support in the implementations of recommendations made by the MMRT. Dr. Rouse has been named a government expert on addressing the drivers of maternal mortality by the Alliance for Health Policy. And she is an executive committee member for the Virginia Neonatal Perinatal Collaborative and actively participates on the VMPC Data Project Subcommittee. Dr. Rouse also volunteers on the March of Dimes Virginia Maternal and Child Health Committee. And I'll turn it over to you.
Thanks, Dane. I want to start by saying I have no disclosures. I'll be discussing pregnancy-associated deaths in the 4th trimester today. So the Virginia Maternal Mortality Projects are funded through Title V grants. There are 2 primary components of the project. The first is the Pregnancy-Associated Mortality Surveillance System that Dane mentioned. This system tracks the patterns and trends in pregnancy-associated deaths in Virginia related to the cause and manner of death, the demographics of the women affected, the temporal relationship between the end of pregnancy and the death, and the outcome of the pregnancy. The Maternal Mortality Review Team performs systematic reviews of all pregnancy-associated deaths in the state in order to identify the contributors to the death and to identify prevention and intervention strategies. And data from the Maternal Mortality Review Team is tracked through the Maternal Mortality Review Information app, which comes from the CDC and is a part of their Erase Maternal Mortality initiative. When we look at the most recent 5 years of finalized data that we have for pregnancy-associated deaths in our state, we see that there's the data points tend to vary by year, and there's no clear indication of an increase or a decrease. When we look at our preliminary numbers for 2019, And particularly for 2020, we do see that there is likely going to be a significant increase in the pregnancy-associated mortality ratio for the state. Overall, about 36% of those deaths occur while the individual was pregnant or on the day of delivery, and about 41.6% of those deaths occur 43 or more days past the date of delivery. And when we look at the manner of death, about 61% are natural deaths, followed by accidental deaths at 26%. And our overall top 5 leading causes of death amongst these cases are accidental overdoses at 18.5%, followed by cardiac conditions at around 15%, and then homicide, cancers, and pulmonary embolism. When we look at deaths specific to the 4th trimester or 43 days or more past the date of delivery, the manner of death, those numbers tend to change a little bit. We got the natural death decreases to about 45%, and the accidental deaths increase to 35%. And there's also an increase in homicide deaths up to 10% of those deaths in that 4th trimester. And looking at the specific causes of death, about 25.6% of cases are from accidental overdoses, 10% are from cardiac conditions and homicides, and then about 9% from exacerbation of chronic disease or from cancers. Looking at the manner of death in the 4th trimester, Black women tend to have a higher proportion of deaths from natural causes, while white women have a higher proportion of deaths from accidental causes. Looking at the natural deaths, for Black women, 67% of those deaths were natural, 43 days or more past the end of pregnancy, while for white women, 46% of their deaths were from accidental causes. When we look at the specific cause of death categories broken down by race, we really start to see some of the differences. Among white women in the 4th trimester, the leading cause of death included 36% dying by an accidental overdose, followed by 10% dying of a homicide, and then cancer and motor vehicle accidents comprise 8% of those deaths, which is a bit different from for all the overall cases, whereas for accidental overdose, we're 28% for overall cases. Among Black women, the leading causes of death were the exacerbation of chronic disease at 22.2%, followed by cardiac disorders at 14%, and cancer at 11%. And this is a bit, one thing that's interesting about this data for our Black women in these cases is that for all our overall cases, cardiac conditions were the leading cause of death. But when we look specific to that 43 or more days past the end of pregnancy, that exacerbation of chronic disease is really where the most significant portion of those deaths came from. Many of the risk factors that are identified in the 4th trimester are similar to those that are identified for all of our pregnancy-associated cases overall. The most prevalent risk factors identified include mental illness, chronic substance abuse, and chronic medical conditions. Nearly 2/3 of all the pregnancy-associated deaths in Virginia had at least one chronic condition, and the number of chronic conditions in each case ranged from 1 to 7, with most of the cases having at least 2 chronic conditions. And this is particularly important when we remember that 22% of our deaths amongst Black women in the 43 days or more past the end of pregnancy was related to the exacerbation of a chronic condition. The most prevalent chronic conditions that we see in these cases are endocrine disorders, chronic mental illness, and chronic substance abuse. Over 25% of pregnancy-associated deaths in Virginia have been diagnosed with depression, and approximately 20% have been diagnosed with anxiety at some point during their lifetime. And nearly 25% of pregnancy-associated deaths in Virginia were also found to have chronic substance abuse. Data from the Virginia Team Reviews reveals that many of these chronic conditions, including substance abuse and mental illness, were not adequately addressed prior to pregnancy, during the pregnancy, and also during that postpartum period. The contributors to pregnancy-associated death in Virginia reflect several of the social determinants of health and factors in the healthcare system, the clinical encounter, and provider factors, as well as structural factors such as unemployment, stability of housing, poverty and wealth, and racism. Based on team reviews, we found that there are several different factors that are contributing to death in these cases. Among the first of community factors, we have a lack of community outreach and support, inadequate subsidy of care. Among the provider factors that were found to be contributors were inadequate assessment of risk, delays in or lack of diagnosis, treatment, or follow-up, failure to refer or seek consultation, a lack of communication between providers, as well as a poor provider and patient communication. Some of the patient-related factors that we found include chronic medical conditions, mental illness, substance abuse, non-compliance, failure or delay in seeking care. Many of these patient-related factors to mortality often reflect other factors, which include social and environmental factors. It also includes the mistrust in providers or the healthcare system, as well as multiple life stressors and risk factors. And it can also reflect a lack of knowledge or understanding on the importance of certain events or conditions and the appropriate treatment and follow-up that is required. And as I said, as we review these cases from the maternal mortality review team, we try to make recommendations that can help to prevent these deaths in the future. And many of these recommendations from the team center around education and awareness on the racial and ethnic health disparities, shared decision-making, cultural competency, cultural humility, and implicit bias, as well as the utilization of pregnancy and postpartum algorithms, which stresses the importance of screening women and asking whether or not they had been pregnant at any point within a year prior to their visit so that the appropriate algorithms can be utilized. Recommendations from the team also include screenings and referrals, such as screening, brief intervention, and referral to treatment for substance abuse, as well as screening for mental illness and intimate partner violence. Another important recommendation that comes from the team includes coordination of care, and specifically stressing communication between providers to ensure that the women are receiving the most appropriate care and the most coordinated care as possible. And that is all that I have for you all. Were there any questions?
Thank you very much, Melanie. And if we do have any questions, if we could please just drop them in the chat, and Melanie will be on so she can answer them throughout. I want to try to keep us as close to schedule as possible. So without further ado, I want to introduce our next speaker for our state updates. And the whole team is going to talk about postpartum coverage expansion and a couple of other programs that they have currently going on. So I want to introduce Cartier Smith, who has 10 years experience working in healthcare administration and operation with a focus on operational support, project management, project implementation, and continuous progress and process improvement initiatives aimed at creating organizational efficiencies. With a BS in computer science and a master's in executive leadership, Cartier is currently in pursuit of her doctorate of business administration. So let me welcome her, and we will get our slides up. All right, welcome, Cartier.
Good morning, everyone. Can everyone hear me?
Yes, ma'am.
Okay, well, good Monday morning to everyone. Hope you've all had your tea, coffee, drinks, or whatever your poison is this morning. We'll try to keep it brief, but we did want to thank you, Shannon, for allowing the state to provide updates, and hopefully you will learn something new. We will be making references to our contact information. Please feel free to use the chat. We do have limited time, but we will certainly follow up to any questions via the chat if you want to do that and leave your email. Okay, next slide. Okay, today's agenda, we are going to be looking at our Baby Steps Virginia program. We are going to talk about our postpartum coverage extension for our Medicaid members. We are going to have a presentation from Keyshawn Harper, who is our Art Senior Policy Specialist at DMAS, and going to talk about addiction and recovery treatment services. We are joined by Consuela Staten, who is going to present on the Doula State Certification from VDH. And she is our State Resource Mothers Program Coordinator at VDH. And then lastly, we will have a presentation from Natasha Turner to present on our Community Doula Program. She is our Doula Program Analyst at DMAS. Next slide. Okay. Cheryl Roberts, our Deputy of Program and Operations, is now our interim agency head, and she was unfortunately unable to join us today, but she does send her warmest regards. Contact information is listed here for both Cheryl and all of the presenters. If you find the need to collaborate or follow up with us, please feel free to use our contact information. Okay, next slide. And there are no disclosures to disclose at this time. Next slide. Thank you. So the Baby Steps Virginia program focuses on 5 key areas and strategies to support our Medicaid members in their access to care during pregnancy and beyond. And so these teams include various agencies, stakeholders. We are partnered with our managed care organizations and our community partners. Of the 5 steps, the 5 teams, we start with eligibility enrollment. We want to be able to streamline enrollment for both our mothers and their newborns, ensuring that there is continuous coverage, that the new babies are covered and enrolled accordingly. We know that that is critical to ensuring that not just mom, but baby is covered and has access to care post-labor and delivery. When we think about our next team, outreach and information, we engage with both our internal and external stakeholders, and we share information across the platform. It's important to us to keep everyone in the know. And so we are constantly thinking about ways to disseminate information and really leverage some of those communication tools that will really reach our targeted audiences. Our connections team focuses on collaboration with the providers, community stakeholders, our hospital and health systems, as well as other state agencies. If we can keep that continuous collaboration and feedback loop open, this only helps to enhance our program, making sure that we are really tackling some of these key issues and barriers or challenges, as I like to call them, when we think about maternal health and, of course, newborns. New and improved services and policies. We collaborate across the state with different projects to ensure that as we think of new ways to provide access to care, we're also creating policies and services that align. And so historically, some benefits are older than others and need some revamping. And so that group really focuses on how to push forward and really advance some of our state policies and services. Program oversight, we look at our data, we look at utilization, we monitor that so that we can understand how we can best improve. We look at those trends to see if we are headed in the right direction, if we need to stop and regroup. But we did recognize that program oversight is certainly a big deal, and we certainly want to continue to watch for that utilization and those trends across our different member populations. Next slide. We had some key accomplishments for Baby Steps Virginia in the calendar year 2021. We partner with VDSS and VHHA to streamline enrollment processes for mom and newborn. Again, that newborn enrollment unit that was created was done to ensure that that continuity of care is present, and that we are, we've established a process to really ensure that it is streamlined and centered on that enrollment process. We developed the Baby Steps Collaborative, which is great. It is a collaborative with the managed care organizations. They are heavily invested. They deliver services to 96% of our members to date, approximately. And so we are excited to be able to partner with them during this collaborative and really share information. Again, a continuous feedback loop between us and the MCOs. We also developed the annual report. That annual report is for our stakeholders and our community and for community awareness. That annual report it highlights everything from 2021. You are going to take a look at the different, the different speakers that join our Baby Steps collaboratives. You're going to take a look at some of the initiatives that we complete and some of the tasks that we were able to check off, but really lends positively to our member population. We developed a new maternity mom letter. And so with social media options, and it sounds small, but when you think about introducing a new mom to her pregnancy, we welcome mom, and we also introduce services that are offered to her during pregnancy and then during the postpartum period. That new mom letter has that information about wraparound services that mom can take advantage of, transportation, dental services, all of those services that are really, again, going to help the mom positively. We call attention to that in that letter. And we also have taken it a step forward to include our social media QR tag. Really big when we think about the population we serve, and just in general, we're in a technology age and where everyone has access to their phones. So with the click of a button, members are able to access specific information on Cover Virginia and other Medicaid details while they're reading up on their materials. We launched the famous prenatal coverage for uninsured pregnant women to reduce emergency delivery services. Really big, making sure that in addition to the coverage for labor and delivery for uninsured women, we're able to provide coverage during the prenatal period as well as the postpartum period. We know that access to timely care is always critical for pregnant individuals, and then of course after they deliver. And so we were excited to launch Famous Prenatal. We also developed the COVID-19 response for pregnant and postpartum members. This was a shared collaborative with our MCO partners. They did a great job in really trying to target pregnant and postpartum members and really educating them on the COVID-19 vaccine, and of course, how they could protect themselves during that public health emergency. We were awarded a Support Act grant to continue to increase substance use disorder and provider capacity. We know that substance use disorder is a big deal, of course. We do not take that lightly, and so we're excited about that extension in that grant. And then we did partner with NASHP on the PIP, also known as the Policy Innovation Program, and that's focused on the community doula program that you'll hear more about in just a moment, as well as our postpartum care. And that's that 12-month coverage extension that we're going to take a look at. Next slide. Our 2021 maternal annual report maternity annual report has been published on the DMAS website. The link is listed here. We do have our bi-monthly Baby Steps Virginia meeting that takes place every second Friday of the month for just 1 hour. We encourage you to attend. There's representation from the health plans, other providers, contractors that join that call for awareness. And we do host that and focus on key maternal topics that of course will provide insight and awareness to that. Also on the screen, you'll also see our Baby Steps email. Should you have any questions, certainly feel free to send inquiries to that email. Also, if you have questions, place them in the chat and we will follow up with you, but please also be sure to include your email. And before we go on, just want to also give a shout out to Marissa Sadler, who was unable to join us today. She leads the Baby Steps Virginia program and has done a great job in being very instrumental to ensuring that Baby Steps Virginia continues to make progress. So I just wanted to, although in her absence, still give her a shout out and make sure that we recognize her for her efforts. Next slide. We're going to take a look at the postpartum coverage extension. Next slide. Okay. Now, extended coverage of Medicaid populations during the PHE, or the public health emergency. For Medicaid pregnant and postpartum individuals, extended coverage is in effect during the public health emergency under the maintenance of effort provision of federal COVID-19 response legislation. That simply means that while the PHE is in effect, until we get word, members will have continuous coverage. What the postpartum coverage extension talks to is that extended coverage of Medicaid and famous moms populations under Virginia's new waiver. So the federal government granted approval of Virginia's Section 1115 waiver amendment to provide continuous coverage during pregnancy and through 12 months postpartum for Medicaid and famous moms. We are excited about that. Virginia is the third state in the nation to receive this approval. That means that we are going to be able to provide access to care to moms beyond beyond the traditional 60-day period. That postpartum coverage extension will be in effect as of this July 1, 2022. Next slide. So reshaping the postpartum benefit and increasing access to care during that period. Historically, Medicaid coverage for moms has ended 60 days postpartum, right? And so in an effort to promote this postpartum coverage extension for Medicaid and famous mom members, DMAS has partnered with the MCOs, NASHP, other stakeholders and collaboratives to really get out and educate our provider community, join collaboratives such as the VMPC to spread the word. We need to be able to change the way we think about the postpartum benefit. Dr. Gilliam just gave us a great presentation on postpartum metrics, and I think I recorded 41.6% of deaths occur within 43 days after labor and delivery. That is a big deal. And so we recognize that we really want to increase access to care during that postpartum period. And that is our focus, follow-ups. And so we're excited to try and spread the word, re-educate, change history in the same meaning, but also, again, just really provide these services to our members. Famous prenatal members will continue to receive coverage through the 60 days postpartum. That is that that is that group that is uninsured, that Medicaid provides access to care for during their pregnancy through the 60-day period. So they're not eligible for the for the 12 months postpartum coverage. So we did want to just call that out should you have any questions. Again, our focus to increase postpartum care during follow-up visits. Our plan of action. We want to identify and remove any barriers or challenges that we foresee during postpartum care, during trying to create access to postpartum care and support. We want to leverage our existing partnerships to increase awareness, using, again, forums such as this to spread the word. We want to shift the way that we communicate with our OBGYNs and our provider communities to ensure that we are disseminating information in a manner that is best received by you and the provider community, making sure that we are giving you the information that you are asking of us. And then lastly, we want to develop member-focused materials to re-educate our members on the new coverage services. That's going to be a humongous lift. But in conjunction with our MCOs, we're committed to really making sure that that education, the resource materials that members have access to is there and they can refer to it to really take advantage of their own health, take advantage of the care that is available to them. And again, try and change what's historically been a cutoff period of 60 days. Next slide. During the postpartum period, members are going to receive the same comprehensive coverage that they would during regular pregnancy during the postpartum period. So postpartum can include postpartum visits, lactation consultants, breast pumps, family planning services to include reproductive planning. We sometimes often forget during that postpartum period that mom is going to need or has questions about their reproductive planning choices and options. And so another great benefit that we are able to push forward for our members. We want to increase well visits for moms and pregnant members and ensuring that they again are taking advantage of that access to care. Safe sleep practices, working with baby, making sure baby is healthy and safe, and then treatment for substance use disorder to include leveraging benefits that you'll hear about in just a moment, such as ARTS, also known as our Addiction and Recovery Treatment Services. Next slide. Okay. So I did want to turn it over to Keyshawn Harper, who is going to speak to us more about our art services. Should you have any questions, again, place them in the chat and I will turn it over. Thank you so much, everyone.
Good morning, everyone. Can you hear me pretty clearly?
Yes, ma'am.
All right. So I will give an overview of our addiction and recovery treatment services. We call our service benefits for substance use disorder ARTS. My overview is going to be very brief, but in the end, I will have contact information where you can reach out if you have more information about our services and coverage. Next slide, please. I do not have any disclosures. So really the learning objectives is to give an overview of all the available services under ARTS, to then talk about coverage for pregnant and postpartum members, and to follow up with any questions and contact information. Next slide. So the ARTS benefit was implemented in 2017, and it was implemented to enhance our substance use disorder benefit that was available to all of our Medicaid members. So the ARTS benefit expands access to a comprehensive continuum of addiction treatment services for all enrolled Medicaid members, including famous moms and pregnant and postpartum individuals. Next slide. So this is the full continuum of care within the ARTS benefit. It starts from experts, which is a pre-diagnosed service, all the way until you get to our residential and office-based treatment services. Next slide, please. So here I will go into more overview and detail of each of those different levels of care within the ARTS benefit. So we do utilize ASAM, which is a evidence-based practice tool for all of our services. It is a requirement through the state of Virginia. And so beginning at ASAM level 0.5, which is your experts. This is your screening, brief intervention, and referral to treatment services. And the purpose of experts is to identify individuals who may have an alcohol and or substance use problems to using an enhanced-based screening tool, evidence-based screening tool. So the service is only available prior to actually receiving a SUD diagnosis. Next slide, please. Substance use case management. So this service assists members and their family members in accessing needed medical, psychiatric, psychological, social, educational, vocational, recovery, and other support essential to meeting the members' basic needs. So coordination of services and planning with other providers and other agencies is also a part of this service. Next slide. So ASAM level 1.0, which is our outpatient services. So within this level of care, you have medical, psychiatric, lab, toxicology, and other available on-site services through consult. Services can be provided in person or by telemedicine. Services shall be include professionally directed screenings, evaluations, treatments, and other ongoing recovery and disease management services. Next slide, please. So here we have ASIM level 2.1 and 2.5. So 2.1 is intensive outpatient services, and 2.5 are partial hospitalization services. So these level of care are structured programs of skilled treatment services, and they're offered to the individual, their families. They're offered in group settings. They offer substance use counseling, medication management, and psychoeducation services. So addiction medication management, 24-hour crisis is available. Also, when you move into the level 2.5, it offers emergency services, medical, psychological, psychiatric, labs, toxicology services, and different medical and other laboratory services as well. Next slide, please. So I combined all of the residential care services, even though they all offer a different level of care, they all have the same basis of care. So with your substance use residential treatment services, it starts at ASIM level 3.1 and it goes up to 4.0. Your 3.1 is your lower level of residential care, which tends to have a longer stay, where your 4.0 is a intensive inpatient level of care that helps stabilize individuals and has a shorter time frame for staying in that level of care. So the various levels of residential treatment do offer clinically directed program activities weekly with professionally directed treatment to stabilize and maintain substance use disorder symptoms and to develop and apply recovery skills. Activities include a variety of things to include relapse prevention, interpersonal choice exploration, cognitive and behavioral psychotherapies, physician monitoring, nursing care, observation, daily clinical services to stabilize acute addictive and psychiatric symptoms, and development of social networks in support of recovery. Direct affiliation with other levels of care, other consults, and less intensive levels of care is also provided within residential treatment. All of the residential treatment is available to pregnant and postpartum women as well. Next slide. Medication assisted treatment, also known as MAT. Now, MAT is a combination of medications and counseling offered with behavioral therapies for the treatment of substance use disorders. Medication assisted treatment is offered in two settings: your opiate treatment providers, which are licensed through DBHDS, Department of Behavioral Health and Developmental Services, and then office-based addiction treatment, which we call OBAT providers, which are offered in primary care clinics, FQHCs, and other physician offices. And in order to be an OBAT provider, you do have to go through an application process and be approved through DMASH directly. The length of treatment is based on each individual member's needs, is based on a multidimensional assessment and risk profile, and limits to the service are individualized. So it's not a one person fit all type of service for MAT. It's very individualized and it's going to vary depending on the member. Also, MAT services are available to members who are pregnant. Next slide, please. Peer support services and family support partners. Now, this service is offered by what we call peer recovery specialists. PRSs are self-identified individuals who have lived experience with mental health, substance use disorder, or co-occurring. It also includes their family members who have that lived experience with those individuals. This service is offered to help provide supports and assistance in recovery with individuals who have been through the recovery process. And it's available to all individuals, those with mental health conditions and also those with substance use disorders. And again, also to our pregnant and postpartum women. Next slide, please. If you have any additional questions regarding the substance use disorder services that are available through the arts benefit. Our contact information is here. Please contact us and we will assist you as we can. We also have supplied our website where you can find more additional information about our services. Thank you, and I will pass it along to Consuelo.
Okay, it looks like Consuelo is not with us. Natasha, can you go ahead and pick up these slides? You're muted.
Hi, Shannon. Do you want to go ahead to the community doula part, and then maybe we come back to Consuela's slides once she joins us again?
Yep, that sounds good. Let me.
And I will, this is Cartier, I will reach out to Consuelo.
Okay, thank you.
Okay.
All right, Natasha, go ahead.
Okay, good morning, everybody. My name is Natasha Turner. I'm the doula program analyst with the Department of Medical Assistance Services. And I'm going to apologize because I noticed that my screen was kind of jumping around, making me look like I'm in the matrix or something. So hopefully that won't happen during this next couple of minutes, but I'll go ahead and get started. I'm going to share a little bit of information about the community doula program. Next slide. There are no disclosures. Next slide. So first I want to share just a little bit of history of the benefit and just start there. So in 2019, an 11 locality tour comprised of public listening sessions took place and included representation from the doula community. And really the doula community really was vital and critical in helping stakeholders and lawmakers to understand the benefits and really advocate for doula services. As a result of the listening sessions, the 2020 General Assembly heard proposals on the recommendation of doula services and issued a study mandate to both the Secretary of Health and Human Resources and the Department of Medical Assistance Services to perform 2 overlapping studies. The first study for the Health and Human Resources made recommendations regarding the state regulation of doulas and establishing a community doula benefit for pregnant women covered by Medicaid. The second study, the Department of Medical Assistance Services study, evaluated the potential cost and benefits of amending the state plan. It evaluated the potential reductions in maternal and infant mortality rates. In December 2020, the report of the Virginia Medicaid Benefit for Community Doula Services Work Group, the study was published, and we've included the below there so that you can access the study for yourself. Next slide, please. See, more likely to have a healthy birth outcome and a positive birth experience. The study showed that doula support services increase the vaginal birth.
I think we're having trouble hearing. Sorry, Natasha. The background is very distorted.
Hopefully, I'm going to turn on my video.
Yeah, Natasha, can we have somebody from your team maybe pick this up?
Hey, everyone, I'm here. I am happy to jump in. Okay, And so while Natasha's getting reconnected, so our 2020 report found evidence that pregnant individuals who receive doula care are more likely to have a healthy birth outcome and a positive birthing experience. We are, the study reported that the doula support services increases the likelihood of vaginal births, the likelihood of breastfeeding initiation, of course, which is great for mom and baby, and then higher 5-minute APGAR scores for newborns, which is, we know, very, very critical to assessing babies immediately after birth. The 2020 report also documented that doula support services decreases delivery by C-section. Again, another big benefit that we are excited to find documented. The evidence is there. And then the use of epidural pain relief, that also decreases. And then instrument assisted births, forceps and other items used during labor and delivery decreases as well. Next slide.
So can everyone hear me? Is it still distorted?
It's a little static. I'm not sure about everyone else.
It's a little static.
Okay. Okay. So in 2021, the Department of Medical Assistance Services received both federal and state approval for community doula benefit as a preventative service. Virginia Medicaid is the 4th state in the nation to implement doula services for Medicaid members. And that is something we are super excited and super proud of. In January 2022, okay, I'm hearing that it's still static.
Natasha, I'm happy to continue, being that we're having a little bit of technical difficulties.
Okay.
Okay, no problem. We just jumped right in. We're a team. Okay, as Natasha was saying, we are 4th in the nation to implement doula services for Medicaid members, a very big deal. Excited to provide that new service and improved benefit for our member. In 2021, the department received both federal and state approval for the benefit as a preventive service. Effective January 2022 of this year, VDH established the minimum requirements to become a state certified community doula. And they also established core competencies for doula certification. And that's going to be used by national organizations and community-based organizations in Virginia as we move forward in the state certification of doulas at large. And once we have Consuelo on, she'll also speak about that. April 2022, Virginia approved the first state certified community doula. That is history in the making. We were excited about that. This is years of work coming to fruition. And so we were excited to see that first doula come on board. And then just this May, Virginia Medicaid did enroll that first state community certified doula as a Medicaid provider. So that is, again, history in the making for Virginia to offer this benefit to members. If you take a look at the chart below, just the pathway, quick overview, doulas will obtain their state certification, they will enroll as a Virginia Medicaid provider, and then they will contract with one or all, hopefully, of our managed care organizations. Next slide. Okay. Recommendations for doula services. So doulas will not practice under the supervision of a clinician. However, doulas must secure and retain the record of a licensed practitioner's recommendation for each member prior to initiating care. And if you take a look at the list here, I am not going to read the entire list in the interest of time, but those are the qualified practitioners or healthcare professionals that are able to make a recommendation for doula care for our members. And that, if you take a look also for the eligibility, a member, of course, must be a Virginia Medicaid member, is pregnant, or give birth within the last 6 months, 180 days. And so As long as the member has their Medicaid benefits, they will have access to that care through the date of conception through 180 days postpartum, with the exception of our famous prenatal member group. Again, their coverage only extends 60 days postpartum. So just a call out there. Next slide. Community doulas as partners to our providers. Community doulas are going to play an integral role in the member's care team during pregnancy, at labor and delivery, and again, during the postpartum period. We want to make sure that, or we do know that community doulas serve as a link between our birthing parents and the medical care team. And so doulas we're expecting doulas to promote communication between members and their care team and their medical providers. We want to help members feel empowered to ask questions and make informed decisions with the informational support that doulas will provide. And then doulas are going to help members navigate their pregnancy. And that's going to be, again, taking advantage of those services that they need. If it's wraparound, if they need transportation, if they're just having trouble or need some of that information, doulas are there to provide that additional support. We are asking that our provider community and our doulas partner together to assess the member's need and ensure members have recommendations for community doula care prior to initiating services. This is a new benefit. We know that community doulas are entering into a new space. And to make this work, we do need this to be all hands on deck. It does have to be a continuous collaboration between doulas and the member, as well as their clinical or medical providers as well. Next slide. Just taking a quick look, what's a community doula? Doulas provide continuous physical, emotional, and informational support to families during pregnancy, at labor and delivery, and then again during the postpartum period. They're going to provide or really focus on our members, which are often the underserved and under-resourced in the community. And then, of course, focus on health equity and social determinants of health. We ask that, or we are looking at things such as homelessness or food insecurities. How can we keep the doula informed about some of these additional community resources to help increase awareness for our members? Taking a look at the benefit overview, in a standard episode of care, a member is eligible to receive 9 touch points. That's going to be 4 visits prenatal, attendance at labor and delivery, and then 4 postpartum visits. And so those are the standard 9 touch points that members will receive. Again, excited about that, and it will extend through that postpartum coverage period according to their covered group. Next slide. Just another way to increase access to care during the postpartum period. We want to promote that continuity of care for women and their newborns during that time. And in recognizing that, we do know that we have an area of opportunity there. And so the program, Medicaid, has implemented 2 linkage to care incentives. It's a value-based incentive payment that can be received by the doula if an obstetrician sees the member for 1 postpartum visit. Then there is an additional value-based incentive payment if the member's newborn sees the pediatric clinician during that newborn period after labor and delivery. We recognize that, again, it is a collective effort and it is a collaboration that must continue. And so as a way to try and incentivize our providers to include doulas to really go in and promote access to care during that time, we thought that this linkage to care incentive was just a great way to do that. Next slide. Now, next steps, we are beginning to enroll doulas. We're beginning to build a state-certified Medicaid network of approved doulas. It is going to take some time, but through our efforts and collaborations with the community, such collaboratives like this, we are hopeful that we will have representation across the state to enroll. and we continue to make strides in that manner. On the screen, you will also see our Baby Steps Virginia email. Please take advantage of that should you have any follow-up questions. I know we had some technical difficulties, but use that email. We're happy to respond to your questions, and we'll certainly keep you informed.
Thank you very much,
Thank you.
Cartier and your team. I apologize, everybody. I'm trying to catch us back up to time. So we are going to go ahead and move on to our next presenter. I do want to highlight that we will have 2 upcoming webinars specifically focused on doulas and specifically focused on postpartum coverage expansion. If you see the links, I've put the information in the chat. I will be including the link here as soon as Dr. Moxley starts speaking. So you guys can go ahead and get registered. Again, I apologize, but thank you to everybody on the DMAS team. And Arthur?
Yeah, hey, everybody. I'm going to thank Dr. Moxley in advance. I just texted him. He's going to make up a little bit of time, but not change his message. But let me tell you a little bit about Dr. Moxley for those who don't know him. He is the Vice President and Chief of Diversity, Health, Equity, and Inclusion at Roper St. Francis Healthcare in Charleston. He's still a clinically and academic through Georgetown as a professor of clinical OBGYN. He chairs the APCO Committee on Diversity, Equity, and Inclusion. He is a UVA grad for both undergraduate medical school. He did his residency at Strong Memorial Hospital in Rochester, and then came back to the University of Virginia, where he was a faculty member and served as the Associate Dean for Diversity and Medical Education. He was also a participant and subsequently led UVA's Summer Medical Dental Education Program, and was one of 12 medical school preparatory programs for students historically marginalized in medicine in the US. He's also held leadership positions with Georgetown's Racial Justice Committee for Change. He possesses an incredible passion for diversity and inclusion, and is honored and excited to have the privilege to share his thoughts on health equity and respectful care. Dr. Moxley, thank you for joining us. It's all yours.
Great, Art. Thank you for the invitation, and to Dr. Dudley and to the entire cohort here to really participate and share some ideas. And I'm going to go ahead and share my screen. And can everybody see that?
Yes, sir.
Okay, great. Going to, all right. One second, please. Trying to advance the slides, and it seems to be locking up a little bit. So 1 second. Sorry about this. Oh, let's see.
So Michael, another option, if you send me your slides by email, I can run them for you. Maybe I'll have better luck and you can just keep going with your talk, which I know you can do without slides. It's up to you.
Create a culture of anti-racism in educational and clinical settings. Next slide, please. So I want to preface this by saying we're going to talk about some uncomfortable subject matter, and it's okay for people to have some sort of emotional response to it. That is really the only way we're going to be able to move forward and make changes. So again, I think if you're not uncomfortable, then my message is not getting across. So I'm going to start with that R word, racism. Okay. And really racism or any sort of ism is, you know, having a setup such that one group is having an advantage over another. In the case of healthcare in this country, we're talking about white people having an advantage over people of color. So this really applies to all aspects of society: criminal justice, housing, banking, employment, and education. There's been an increased attention and concern based on the spring awakening and inflection point of the spring of 2020. And we also have to be mindful of the fact that just because we may be primarily in healthcare, that is really only one domain in need of action. The other areas will also need to be addressed. Next slide, please. So here are some notable examples of disparities, and those of us who are in the obstetric and gynecology field can certainly speak to these, but there may be some things that you're not aware of. So in the 1800s, J. Marion Sims, who is considered by some to be the father of modern gynecology, and others experimented on enslaved women without anesthesia, as the prevailing belief was that enslaved people were thought to have higher pain tolerance. Then another example would be Henrietta Lacks, who is, many of us are calling the mother of modern gynecology. She was diagnosed with cervical cancer at Johns Hopkins. Her cells that were obtained were used to advance research and vaccine development, yet this was done without the patient's knowledge or consent. In the 70s, 25 to 50% of Indigenous women were forcibly sterilized. In 1989, a study showed that 31% of Black women without a high school diploma underwent forced sterilizations, compared with 14% of white women of the same educational status. In 2016, from another study that was done at my alma mater, University of Virginia, Blacks were perceived to have a higher pain tolerance than whites, and that was interviewing medical students and residents. And the this still persists. In 2020, there's a study that emerged that showed that infants that were taken care of by race concordant individuals, the babies of color did better, had a lower mortality, had half the mortality than they would if they had a race discordant team. Next slide. So with all these things that happen, you might say to yourself, how did we get to this point? But then more importantly, where do we go from here, and how do we change things? And so I'm going to give some hope and some examples of things that institutions have done and things that we've done on the governmental level, but also things that we can do as individuals to move forward. Next slide, please. So to give a little more background in healthcare disparities, the 2000 US Census showed that the breakdown of the country was 75% white and 25% non-white. By 2050, if not earlier, it's going to be pretty much half and half white and non-white population. So with the advent of COVID-19 and the overall morbidity and mortality, really showed that populations of color were disproportionately affected. And then, as long ago as 2002, 20 years ago, it was noted in the Institute of Medicine that racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities. Next slide, please. From the CDC, Blacks account for 41% of all AIDS cases, Hispanic 19%. And you can really pick your disease, right? Asthma, heart disease, diabetes, malignancies, breast cancer, uterine cancer. There is a disproportionate effect on our populations that have been historically marginalized in medicine. Racial and ethnic minorities are more likely to receive care from non-white physicians than white physicians. Patients are aware of the benefit of concordance between ethnicity of provider and patient. So I bring that up because if someone comes to you and you're under their care and you're race discordant, and they may ask for a teammate, a physician of color or a provider of color, it's likely because they're aware of the fact that if you have race concordance, you're going to have a better outcome. Next slide, please. So more facts. In 2000, Black and Hispanic physicians account for only 4%, 5% of physician population respectively. However, they care for 25% and 23% of Black and Hispanic patients. And you can go outside the region, in rural areas, and that is even more pronounced, that effect. So in 2013, the AAMC data shows that historically marginalized in medicine faculty, 69% white, 13% Asian, 3% Black, 4% Hispanic, and 0.1% Indigenous. And, to those of you who were kind of saying, well, I mean, that's from 2013. Why is it, hadn't he like updated his slide? And really, I looked at the 2021 AAMC data, and it's not appreciably changed. So, there's some work that needs to be done there. Midwives of color, number 2% in the country. Next slide, please. So again, talking about the disparities and the facts. So Black male physicians in 1940 was 2.6% of all physicians. And in 2020, 80 years later, still at 2.6%. So let's talk a little bit about some of the institutions, where that led to this setting. So UVA, their cultural attitudes and certainly mistrust of the medical system. Jefferson owned a couple hundred slaves who were inoculated with smallpox to test an experimental vaccine. The School of Medicine, as well as other schools, had restrictive admissions policies. Georgetown and Johns Hopkins relied upon the labor of enslaved people. And my current employer, Roper Hospital, it was segregated until 1969. Next slide, please. So, you just write this down as what you think it is, and you'll get the answer as we go through the talk. But question one, the University of Virginia paid Black students to go to out-of-state medical schools so as not to go there. True or false? Next slide, please. The percentage of underrepresented students in the Georgetown University School of Medicine class of 25 is 15, 23, or 30%. Write down your answer, we'll come back to it. Next slide, please. So again, institutions are going to do their part. I'm going to show some demonstrations about that. But we also have to examine where we are on the individual level. And so I love this diagram because it is not enough to not be racist. You have to become anti-racist. And so there are different zones of anti-racism. And as you look at this, I want you to figure out where you stand. Is it the fear zone, the learning zone, or the growth zone? And, if you're in the fear zone, you probably have not experienced enough data or heard enough to really try to be anti-racist. And there are, there are certain modules and trainings that can occur to actually help you understand what anti-racism is and how to be anti-racist. So again, as you jot these down, kind of just think about where you sit in this zone. Next slide, please. So, and then this is the third question, and then going to be done with quizzing. So are you in the fear zone, learning zone, or growth zone? Next slide, please. So going back to institutions, so UVA School of Medicine Statement on Diversity said we can correct these disparities by having practicing academics who can train and mentor those physicians who are most likely to treat the populations and perform meaningful research to improve the quality of care to all patients. Next slide, please. Georgetown very similarly said, okay, well, we want the racial and ethnic demographics of Georgetown to represent the US population. So you've got the 13% Black, 1% Indigenous, 70% Hispanic, and all students will thrive in an environment that is conducive to the provision of high quality, culturally humble healthcare. Next slide, please. So that talks about pathway programs. As I mentioned before, Black males in medicine have not really made any progress in 80 years. And while that's sort of the most stark of the realities, it really applies to all of our populations that have been historically underrepresented in medicine. And so what was formerly known as pipelines is really, we're using pathway programs. And so, and why are we switching from pipeline to pathway? Well, pipelines tend to apply that you have a linear progression, a linear road to getting to your objective. And populations that have been historically marginalized don't always have those opportunities. And so there's more than one way to get to your goal, and that's where pathways come from. So it's not completely linear. But as you can see here, you're not going to have representation in medical school unless you fix the admissions process, and then of course the college admission process all the way back to grade school. And then carrying this pathway a step even further is, what about residency and professional and attending level? Next slide, please. So briefly giving a little bit of timeline with the UVA history. Again, in 1953, the Commonwealth of Virginia paid for underrepresented students to attend medical schools outside of Virginia. From 54 to 2003, diversity was really not a part of any admissions committee discussions, although they did admit Black students in 1954 to the medical school, but really didn't do much more than that. So the percentage of students that were historically marginalized in medicine is less than 6%. Next slide, please. So in 2003, there were a number of changes that occurred, and we'll talk about that momentarily. But over this 10-year period, underrepresented students increased from less than 6% to 25.5% of the class. And the academic credentials of the matriculating students rose from the 75th percent to above the 90th percentile. Percentage of students scoring above the 90th percentile on the USMLE Step 2 rose from 40% to 69%. And so that led us to conclude and to write up that a diversity increases academic excellence in medical education. Next slide. This is just a graphic representation of the level of students who are historically marginalized in medicine at UVA. Next slide. So moving to Georgetown, really what you accelerated this was an open letter from the School of Medicine students in 2020 with the Spring Awakening. And it was really clear, not only to the students, but also to the administration, that there's a need for improvement. Now, Georgetown recognized this even prior to that and formed a task force to really increase efforts to increase people who are historically marginalized in medicine. Now, through identification of barriers and rapid implementations of interventions, Georgetown University Medical School celebrated their most diverse class in history, 30% in the class of 2025. So there's the answer to question 2. And then compared this with the national average in medical school, somewhere around 15%. Next slide, please. So again, this is just another graphic representation of what I just said. Next slide, please. So, how do you maintain the success? It's not enough just to get people in the door, but also to help people thrive, right? So we also want to have this interest in diversity that will include excellence in medical education, reducing healthcare disparities, which is why we're all here today, and achieving cultural humility to improve the quality of patient care. We need to enhance the team performance, the team effort with education and our patient care teams. And we need to enhance the appeal to potential applicants to this institution. In other words, having a work environment, a learning environment that fosters inclusion and belonging. Next slide, please. So there's a number of activities, implementation steps that were implemented, but at the bottom, you really have to have strong and unyielding support from administration. So when we look to make these changes, if we really want to be effective and send the message, and nothing sends the message more accurately than if your leadership is interested and supportive of diversity, inclusion, and belonging. And that means, of course, having your leadership represent the population that you intend to serve. Next slide, please. So again, I gave you some examples of what other institutions have done. So there's this an institutional level where things are being accomplished, but then, what can I do individually, right? So start off with listening, see where the needs are. You may think you know where the needs are, but until you hear from the people who are affected by it and taking time to listen, you really may be barking up the wrong tree. And then take a look at yourself, assess where you land on the anti-racism map, and recognize that this is not something that needs to be brought up from scratch. So you look to your professional organizations like ACOG, ACNM, APCO, CREOG, among other institutions that have actually done a lot with this work and can serve as a source of references. And then importantly, though, I think it's really looking to champions wherever you are. And if you don't think you have them in your own institution, then reach out to other individuals, people who may not necessarily be physically there at your institution, but it's resources you can reach out and get some advice about. Next slide, please. So just to give you a couple of other examples of success, UCSF, their School of Medicine is 52% historically marginalized in medicine. You can see their academic credentials there. Going back to, again, pathway programs, University of Louisville and University of Georgia, worked on Black male college graduation rates and made some increase in headway there. Next slide, please. So really, Donna Shaleo, when she was head of Health and Human Services, basically said that, the moral argument for diversity is kind of already there, but you need to really make it educational. And if we don't have a first-class education, then the health of the country is at stake. Next slide, please. So again, a picture's worth 1,000 words. Here's UVA's graduating class in 1960, and then 2017 there. Next slide, please. Georgetown's class is 66 in 2025. Next slide, please. So we're going to move from health disparities to health equity beyond nursing and medical school. Next slide, please. So you've all seen this slide before, right? And this is where the call to action comes in. Pregnancy-related mortality is on the rise in the United States. And, I'm sure you've all seen this before. Next slide, please. And here you can look in terms of pregnancy-related mortality based on race as well as overall. And you can check by your region to see how much of a disparity there is. But as you can see, it is most predominant in Black patients. Next slide, please. So in South Carolina, where I'm in Area 4 right now, you can see where the disparities lie. And then, of course, Area 3, just a few steps over, you can see the disparities as well between white and Black patients. Next slide, please. So I'm going to talk very briefly about, again, the pathways beyond medical school. And so just, again, to let people know that when we're working on resident selection, the goal is for the workforce to represent the population. Another striking number is that Black OBGYN residents in 2012 numbered about 11.3% and then dropped to 8.3% in 2020. And so, is that related to the selection factors for interviews? It's hard to decipher, but the decrease is there. Members of the AOA are less likely to be underrepresented even when accounting for clerkship grades. So again, I think it shows that we have some bias in even that process that we need to address. Next slide, please. So, and as a program director, applications have increased, more than doubled per program since 2013, but they haven't really increased the number of FTEs to kind of look at that and deal with that extra load. Step one being pass fail limits the ability for people to get a holistic picture in some folks' minds, but I would say that it probably increases the pressure to actually do holistic review. And then the virtual interview process is again somewhat of a limitation as well, potentially. Next slide, please. So, and then if I'm an applicant, there's still expenses, there's disproportionate debt burden for those who are historically marginalized in medicine. And then, what about the support once you get into residency? Next slide. So Dr. Ohlendorf is also the president of the of APGO, the Association for Professors of Gynecology and Obstetrics, and this organization expanded the diversity committee in 2019. The then president gave a committee charge, and we have spent increased attention to meeting programming and diversity and choice of presenters to our meetings. And we're aligning DEI and weaving it through the entire strategic plan. We have made some educational guidelines that uses inclusive language, and those are being submitted for publication and distribution. And expansion of resources in terms of glossary of terms. Since the time I've made this presentation, a lot of the language has changed, and so we are publishing a glossary so that we can kind of keep up with that. Next slide, please. And so this is just something that our sibling organizations are trying to, again, do more to enhance the holistic review for residency selection. Next slide, please. So we're now faced with the fact that tomorrow's today, confronted with the fierce urgency of now. There is such a thing as being too late. And this is not time to be apathetic or complacent. This is a time for vigorous and positive action by Martin Luther King Jr. Next slide, please. So change is possible. And, one of the things that I want to give hope to folks is that, again, going back to UVA, they went from paying students of color to go to other schools to now honoring the first Black students to attend with a scholarship fund. So when we ask, how did we get here? I mean, that's certainly something we need to recognize and acknowledge. But, the more important thing is, how do we turn things around? And I think this is a great example of how that has really started to manifest itself, and hopefully will manifest itself in decreasing the healthcare disparities that we're currently experiencing. Our other organization, the American College of OBGYN, has openly declared racism a public health crisis. And again, I think just saying the words, getting it out there, and actually taking action is very positive. Next slide, please. So I'm going to play about a 4 or 5 minute video that will sort of wrap everything around, and it's going to go right into it. We shouldn't be too late, too far behind. So let's go ahead and play it. Yeah, you might have to hit the speaker.
Sorry, this is where you gotta. I had to share sound. Yep. Yep, I'm working on it. Sorry, everybody. Because I'm not seeing where the share sound is. For simplicity, I will put it in the chat, the link. Sorry, everybody.
Shannon, I'm going to try to share the screen, see if I can't get to it.
Okay. All right, so I think that we're seeing that we're not able to do. So I have put the chat, or I put the link in the chat, and we will go ahead and take a break. I know it's only about 7 minutes, but if we can be back at 11 o'clock, we will resume with our next speaker. Thank you, everybody.
Caring for the terminally ill infant. And we have three great presenters today who are going to be on the panel. I'll be introducing them, so bear with me. There's no specific reason for this order, but we have Dr. Kelly Lastrapes. She is from Richmond, who did her medical school training at VCU, then traveled to Children's Hospital of New Orleans for her residency and chief residency year. She returned and completed a fellowship in pediatric, hem-onc, and hospice and palliative care medicine here at Children's Hospital of Richmond, after which she joined the faculty in 2016. In 2019, she became the medical director of Noah's Children Home-Based Hospice and Palliative Care Program, as well as the CHORE Pediatric Supportive Care Team. We also have Dr. Murray. He's a neonatologist at the University of Virginia. He completed his neonatal perinatal medicine fellowship on a biomedical ethics track at Yale University and went on to pursue an additional fellowship in biomedical ethics at Harvard. Dr. Murray has a strong interest in neonatal perinatal palliative care and the intersection of palliative care with biomedical ethics. He serves on the Ethics Consult Service and Ethics Committee at UVA and teaches APPs, RNs, medical students, fellows, and residents in the principles of biomedical ethics in both formal and informal settings. He's a tireless advocate for babies, palliative care, and sensible application of ethical reasoning that respects children of all ages. And last but not least, we have Dr. Allison Williams. She's a clinical psychologist in Virginia Commonwealth University's NICU and neonatal continuing care program. Clinically, she specializes in peripartum mental health, including treatment of perinatal mood disorders, promotion of infant-mother bonding, and coping with complex medical diagnosis and hospitalization. Dr. Williams has 20+ publications with focus on peripartum health, post-traumatic stress in medical settings, and health disparities. I would like to thank them all for joining our panel today and taking their time off their day to help us with this summit.
All right, thank you. So it looks like I'll go ahead and get started. So my name is Pete Murray. Thank you for that introduction and thank you for the invitation to talk today. Next slide, please. I have no relevant disclosures. Next slide, please. So I do have 3 just very quick objectives. So hopefully I can get us to understand a brief history of neonatal perinatal palliative care, get us to a point where we can appreciate the importance of early incorporation of palliative care services for our fetuses and our neonates who have a life-limiting condition, then also discuss some simple initiatives that we started at UVA that could be brought into other units. Next slide, please. So first, we'll just go through a quick history of neonatal and perinatal palliative care. The provision of neonatal hospice care was first introduced in the 1980s. And this time frame overall coincided with a larger movement towards the incorporation of hospice principles for folks who are nearing their end of life. And we have 2 manuscripts from 1982 by Whitfield et al. And Silverman that really represented the first publications to apply hospice principles to neonates. But we do have other publications going back as early as the 1970s that started to discuss withdrawal of life-sustaining measures as it pertains to neonates. My favorite of which was from Duff and Campbell in 1973, which in my opinion was the first paper to really join neonatology, palliative care, and biomedical ethics. Even if they didn't necessarily know that's what they were doing, that's what they did. And it also came from Yale and from their NICUs. I have a particular affiliation for that paper, but it's an excellent one to check out. Next slide, please. So what you see here is just a description of the amount of PubMed palliative care citations from the 1970s on up to about 2017. And this was from Brian Carter, who's over at Children's Mercy, and he's a neonatal perinatal palliative care specialist, neonatologist, and also a preeminent bioethicist in pediatrics. But as you can see, as time has gone on since the inception of neonatology, palliative care has kind of grown up with neonatology, as it were, kind of coming forward to the present. Next slide, please. And as neonatology has grown over the past 3 decades, I would say, especially over the past 15 years, we've seen more attention paid to newborns and young infants and how they die in the hospital, with particular attention paid to pain and symptom management, spiritual support, honoring the cultural practices of the family, understanding grief, but also implementation of bereavement practices. Next slide, please. So why is this all important? You know, why do we harp on or care so much about neonatal and perinatal palliative care for our infants with life-limiting conditions? Well, I think we can all agree that parents generally enter pregnancy with a future-oriented perspective. And once we have a life-limiting diagnosis, anticipation can become replaced with fear and apprehension. I think we'll get to more of this perhaps later on in other talks, but the pregnancy can become medicalized, with parents often developing obsessive thoughts around each clinic visit or each ultrasound, and the list goes on and on. You know, things become very medicalized and they enter a different space than they were prior to learning of that diagnosis. So the early introduction of palliative care services can help with supportive decision-making, both the perinatal, the immediate neonatal period, but also in postnatal patients who linger with acute exacerbations. So this would be your kids with severe BPD who have severe pulmonary hypertension. They go on to have acute exacerbations every few months or so. And these are kids that really ought to have a palliative care specialist following along with them. Next slide, please. So this is probably my favorite definition about palliative care, and this comes from a website and an organization from the UK called Together for Short Lives. And really it describes palliative care in the perinatal setting as palliative care for a fetus, neonate, or infant with life-limiting condition. And it's an active and total approach to care. And I think I won't labor you with me reading the entire thing, but I think it's important to understand the first part there. It's an active and total approach to care. Okay, so it's not a cessation of life prolonging or life-saving therapy. It's meant to complement. Next slide, please. And I think it's important for us to understand that this is a complement to life prolonging or life sustaining care, because the majority of neonates who die as a result of withdrawal of life-sustaining measures, and deaths within a hospital typically occur within the ICU. But we also know from some studies that ICU physicians are somewhat less inclined to consult palliative care. Next, please. And then can you hit it one more time too, please? Okay, so what we can see here, this was a study from Amy Trowbridge, and it was headed up by Dr. Feudner down, or for me down at CHOP, because I'm up in Connecticut right now, but for you all up at CHOP, up in Philly. And what they did was they looked at the amount of babies or the amount of children within their hospital who died, who had a palliative care consult. Now you'll see that in the NICU, only about 27% of the folks who died in their NICU had a palliative care consult. And since we've already know that most of the patients who die in a NICU die as a result of withdrawal of life-sustaining measures, they then went on to look at the amount of patients who died as a result of withdrawal who also had a palliative care consult, and that number was only about 36%. And I already described to you that ICU physicians tend to be less inclined to consult palliative care, and we see here that for their oncology patients at CHOP, about 90% of the kids who died with an oncologic diagnosis actually had a pediatric palliative care consult. Next slide, please. So here's another slide from that paper, and we can see two really important things. So in a children's hospital, the majority of withdrawal happens in the NICU, and in the NICU, the overwhelming majority of babies who die as a result of either withdrawal or non-escalation. But again, as we described previously, most of those patients did not have a palliative care consult performed on their behalf, and therefore might not have had the best support mechanisms for the patient, but also for the family. Next slide, please. So some local initiatives that we have gone through and started at UVA, and we're just kind of thinking about what our hospital offers right now. We have a designated pediatric palliative care service that has one attending who is PICU trained and 2 nurse practitioners. And we do have an early consults minded approach where we try to get them involved as early as we can as per our end of life guidelines. But these guidelines can also help in medication management as well as automatic triggers. Next slide, please. We do have an inpatient hospice team that we've used a few times in the NICU, and our inpatient palliative care team will co-manage these patients. Physically, they tend to stay where they are, but there can be some movement within the children's hospital if needed. Patients who are discharged on hospice or palliative care can enter a pediatric palliative care home monitoring program. They can communicate with our palliative care team via the Locus Health app or MyChart. It's pretty useful for us given our catchment area. It's a pretty large catchment area, and sometimes folks have trouble getting back into UVA to see us if their child is experiencing some symptoms or if they just want to check in with us. Next slide, please. Another local initiative that we started was one of our fellows, Angelina June, brought this to my attention, as well as the attention of our bereavement nurse, Naomi Radmeyer, who's on this talk right now, or she's on this call right now. And we together applied for a Little Giraffe Foundation grant for keepsake bears. And what we do is we record the patient's heartbeat, either with our bedside ultrasound or with an iPhone, and we're able to get a recording of the heart rate or of the heartbeat. They'll be uploaded to the bear, and then that becomes a keepsake for the family to take home. And thus far, the feedback we've received from families is that they actually do cherish these sort of little mementos. Next slide, please. What we're working on right now, which I'm really excited about, it is a way to increase our palliative care offerings. So the UVA NICU partnered with the Shally Institute for Palliative Care, and this institute offers online certificate programs in palliative care concepts. And right now we have 17 nurses, 8 attendings, and 4 fellows who are registered to take the pediatric palliative care certificate program. And so we hopefully will get that started pretty soon. And we hope that this endeavor will increase the availability of palliative care services in the NICU and lead to more acceptance of the palliative care tenants. It's asynchronous with synchronous check-ins that we're going to do via Zoom, but I will say that the operationalization of this course took buy-in from both nursing and medical leadership, especially our medical director, John Swanson, who was really helpful in getting this off the ground and really understood its importance. Next slide, please. Oh, I think one more back. Oh, nope. Back. Yep, there you go. Thanks. So some other local initiatives, I think most of us, we all have a social work component, which is instrumental to the support of our families. We also have the Family Stress Clinic, which I find pretty unique and useful, and is run through the Department of Family Medicine. And there are 2 PhD psychologists who are available for our families just to kind of talk through things and talk through the amount of stress that they go through. But we can't also forget ourselves either. We do have some layers of support for healthcare providers, one of which is run through the Ethics Consult service, which I serve on, which is the moral distress consultation service. And with this service, we assist healthcare providers who experience moral distress through facilitated discussion and then the identification of strategies to overcome barriers to taking the appropriate action in a patient's care. We also have FEAP, which stands for the Faculty and Employer Assistance Program, and they have specific programs for healthcare providers to address critical incidents or stress. I think it's important to not get lost in the minutia of some of this, to remember that we have to take care of ourselves as healthcare providers as well. Next slide, please. So just to conclude, palliative care has become both more accepted and common since the inception of neonatology as a specialty. Curative care and palliative care are not mutually exclusive and should therefore complement one another. Most infants who die in the NICU do so as a result of withdrawal of life-sustaining measures, and local initiatives are important as they can be tailored for your unit's specific needs. All right, thank you.
Okay, thank you for having me here today. So I'm the psychologist in the NICU at VCU. Next slide. Thanks. I have no disclosures. Okay, briefly, because NICU psychology might be a little bit new to many of you, I wanted to orient you to that. So in general, my role is really to address parental mental health needs, peripartum, mood disorders, which is especially important, as we know, in NICUs and with families with children with life-limiting diagnoses that mental health concerns are higher. I also work on promoting good coping on the unit. A big area that people don't often think about is really kind of promoting, or think of with a psychologist, is promoting attachment. So the baby is actually considered my patient, and helping with bonding, again, really important for families where Dr. Murray kind of referenced as well, some of that prenatal and postnatal bonding is disrupted by fear and sort of future-oriented anxieties. And then also really supporting the team with secondary stress and with moral distress around some of the decision-making they're having to do. I'm going to focus really today on sort of what I do on the unit, because that's where I spend most of my time. I do a little bit, and I'm hoping to do more with antepartum care for families with life-limiting diagnoses or who anticipate a NICU stay. But as this program is ramping up, I'm primarily on the unit, so we'll focus on that. Next slide, please. Okay, so I'm going to go over just briefly what I do for assessment and then give you an example for intervention, just so you can get a sense of both what a psychologist could do in the unit and also elements that you could pull in whatever sort of medical role you have. So in general, I always want to get a sense of their prenatal functioning, understand if they've had miscarriages before, NICU hospitalizations before, again, looking at that prenatal bonding, which is often disrupted either through preterm birth or towards future related anxieties that maybe started at the 20-week anatomy scan. So getting a sense of that pregnancy course and on what their bond during pregnancy looked like. Of course, looking at mental health history, trauma history, especially birth trauma, any medical trauma, and then any sexual assault traumas, all of those really crop up a lot of the NICU. And working really closely with supportive palliative care and our medical team to really understand what is the family's sense of their baby's health and all the factors that go into that. So that could involve, how well do they understand the medical information? What are the gaps there? What are the factors that are going into their decision-making? What are the family dynamics? Are there sort of polarizing views of what the best course would be? How do their values play into that? And what are their values? What are their hopes for their baby, given the diagnoses that the baby carries? And then what are their biggest concerns with it? How do their religious beliefs play into their medical decision-making? And then really looking at how their relationship is with the medical team here in the NICU, and areas that we could strengthen that even. Of course, looking at mental health. As I mentioned, peripartum mood disorders are high with parents with babies in the NICU, and even higher for parents, as you would imagine, with life-limiting diagnoses. Anticipatory grief is another area that I really try to focus on helping a lot with families with the life-limiting diagnoses. And then just kind of other stressors that they might have. I think a benefit to being on the unit is that a lot of the work, I can intervene early and often while they're still sort of in the crisis. So a lot of the work can be preventative. Looking at their coping, their behaviors, that might be how often they're visiting. It might be how often they're doing self-care. It might be how frequently they're paging nursing with anxieties or concerns. And then sort of their just general coping style, social support, how they communicate best with the medical team, if they need information written, if they like family meetings, if they want to meet one-on-one, and again, kind of working really closely with the medical team here. And then attachment, infant representation. Dr. Murray sort of talked about this as well with the medicalization of their baby. So I work with them on talking to them a lot about aspects of the baby that are not at all medical. So what have you noticed that your baby likes? What character, how would you describe your baby's temperament or personality? What do you see in your baby? Again, to work towards bonding. Helping with OT and PT to provide sensitive caregiving. So helping them understand infant cues. And then memory making, again, Dr. Murray kind of touched on this. So that could involve keepsakes. That could also involve actually just kind of milestones and memories on the unit. And then working with siblings on attachment. Next slide, please. Okay, so I'm going to give a brief example, just so I think it's easier to illustrate sort of what I do with an example. This is a hypothetical patient. It's sort of a hodgepodge of a couple of characteristics. So baby at trisomy 13, born at 37 weeks, long length of stay. So we saw that the pregnancy had been very stressful since 20-week ultrasound. They'd had sort of what they described as kind of combative conversations with healthcare providers, where they felt that they were constantly fighting for baby not being terminated, and it created some difficulties there. And they also had disrupted bonding, as they were fearful and were afraid to be too future oriented, and that a lot of the bonding does come through kind of imagining your baby as he or she is born, and her life and what that life might look like. Family had great medical literacy, were very good questions, very easy understanding. They also, because of their religious beliefs, were not accepting of the diagnosis fully, and believed that the baby would defy all odds. Mom had a traumatic self-extubation which required a staff assist on the unit. Parents had some PTSD related to the extubation, a lot of rumination and worries about the future, and were very religious, had good communication with the medical team, fearful to hold baby after the extubation. Next slide. Okay. So this is, I won't go into great detail with it, just want to give you an overview. So I would do a treatment for PTSD related to the self-extubation. And that would really look at help the parents understand the baby's development, and then also kind of process the trauma, the self-extubation in a way that is safe. So we'd go over a trauma narrative eventually, and triggers, kind of thoughts that are really sticky. That might be like guilt over the baby being here, or what if my baby dies, or helping them kind of really identify what those are, and working through them. This type of treatment is designed to be in the NICU, but it is also a way of introducing parents to active, non-avoidant coping of difficult things, which can translate well to caring for a baby with life-limiting diagnoses, where there are going to be many points at which they're going to need to engage in this kind of active coping. So it's sort of setting a blueprint for that for later as well. Next slide. Thank you. And then also working with them on bonding. With parents, especially with life-limiting medical diagnoses, I work a lot with them on kind of very present-focused coping. So some of that might look like mindfulness, being very engaged with baby. Example exercise might be doing deep breathing while holding the baby, noticing how the baby feels, smells, looking at the toes, and being very present. Teaching them to be receptive to infant cues, providing good stimulation, again, working very closely with our interdisciplinary team here. Memory making, our nurses and medical team are great about this. They have a lot of little crafts and stuff that they do with the families, journaling, and just kind of demedicalizing the NICU as much as possible, and really promoting attachment in that way. Next slide, please. Okay, and then also supporting both the medical team and supporting medical decision making. So that it involves a lot of communication with the medical team on what the parents' understanding of the conditions are, what their concerns are, before big family meetings, typing up a list for the team of the family's primary questions, really kind of orienting the team to sort of where they stand right now. The team, of course, checks in, all the time with them as well. After big medical conversations, sometimes even being there, depending on the family's, comfort with medical information, and then getting their kind of teach back and debriefing what they got out of the conversations. And then also opening the door to sort of what their care goals are periodically, and checking in sort of what they want for their baby, what type of life they want for their baby, how they feel about baby's comfort level, and then working closely with supportive and palliative cares for that. And then finally, last but not least, supporting the medical team with moral distress and secondary stress, which is like a secondary PTSD. Just kind of recognizing that it can be really difficult for the medical team to provide this sort of care. So I check in a lot with the primary nurses for the team, and then also with like primary NPs and team members who are there for staff assists or for things that could be traumatic. Thank you.
Well, thank you to both the other presenters. It's been wonderful to hear. I get the honor of working with Allie, but Peter, great to hear your thoughts as well. And I am going to kind of finish up the presentation a little bit more focused on going home. I am, as Joe mentioned, I am the medical director of Noah's Children, which is a home-based palliative and hospice program that serves patients in kind of the metro Richmond area. We serve a 60-mile radius kind of spoke and wheel out from St. Mary's Hospital. We serve all different hospital systems, any child with a life-limiting, life-threatening diagnosis or with chronic complex medical illness with a downward trajectory are kids who are eligible for our program. So I thought I would take a little time with you guys just to talk about care of the infant with a life-limiting illness and kind of the transition home. So next slide. And I have no disclosures. So, and you can kind of go through to the first bullet point. So the first thing I just wanted to kind of echo that both I think Peter and Allie have referred to is kind of when you think about sending a baby home with a life-limiting or life-threatening illness, one of the first things I really like to drive home is the need for really good compassionate, honest goals of care conversations before that baby leaves that unit. What do the parents understand about their illness? What are they hoping for? Both just kind of big picture, but then also using your resources and your care teams to make sure that the care plan that you have in place matches what their hopes are for the future. Definitely code status is a thing that needs to be discussed before they head out the door. Care plan, and then you can advance one more, please. So specifically talking about, again, what are our goals for care? If the family says, you know, I understand my child's life is limited and I want to just focus on keeping my baby comfortable, I'm not interested in using any artificial means of nutrition and hydration. I want to make sure I have all the medications at home to manage any symptoms. I do not want to come back to the hospital if anything changes. I really want to keep my baby at home. That would be more of a comfort-focused care plan, and very important to know. And your friendly home-based team will be very appreciative if these conversations have happened, and that way they know what to expect when they're going in the home, and can kind of save the family from having this conversation multiple times too. Other families are going to say, hey, you know, I understand my child has a life-limiting illness, but right now my baby's doing really well. And so while maybe I would not want to do CPR if my baby's heart stopped and I stopped breathing, I would want to do some artificial, I would want to do some NG tube feeds, or I would want to have a G-tube placed. I would want to come back to the hospital for illnesses and receive support if the thought was that my child may continue to live on after this viral illness if we give them a little bit of support. So there may be an interest in some limited interventions. And then there will be some families that will say, I hear you, I hear what you're saying, but similar to Allie's case, some families say, I understand that you're telling me my child has life-limiting illness, but either I don't believe you, I'm in denial, or, you know, despite that, I want my child to live as long as they possibly can. And I want full disease-directed interventions, including if his or her heart stops, I would like CPR. So having those conversations before they leave the unit really allows the team, the interdisciplinary team, to set up the safest and most supportive discharge plan in line with the family's goals of care. Second, you can advance the slide one more. So number 2 is just documentation of SAD code status and care plan is always very helpful. So the mechanisms in the state of Virginia currently for documenting code status and care plan. Most of you are probably familiar with a durable do not resuscitate order. So it's essentially the outpatient equivalent of an inpatient do not resuscitate or do not attempt resuscitation order. We do now have the availability of a post form, which is a physician's orders for scope of treatment. The tricky part about a post form is different facilities, I think, have it implemented in different ways. And so it's important to kind of know your area and know what both your EMS providers and your ER providers, kind of what their comfort level is with this document and seeing it. It does allow you to express wishes, such as families that would not want their child intubated, even before a code situation. It allows them to express feelings about artificial nutrition and hydration. So it basically gives a little bit more upstream information for children whose families have kind of made those wishes known. I have really found that for kids who are in facilities, long-term care facilities, as well as our non-English speaking patients, this document has been something that I've used as a tool to help make sure that if they get into scenarios, because most often kids are not separated from their parents, so their parents can be the advocate and say the words when they need to. But in certain circumstances, there may be kids who have medically complex kids who have home nursing whose parents leave. All of those scenarios might be wonderful opportunities to have a post form in place. And usually your friendly palliative care team would be more than happy to help in or facilitate filling out the form if you don't feel comfortable. The third thing I just want to mention is equipment and supplies, and you can go ahead and go to the next slide. I will tell you that this can be very tricky because when you have seen one home-based palliative care and hospice team, you've seen one home-based care and hospice team. In other words, we are all completely different in the way that we function and we provide care. So there are some some home-based programs that are modeled more after the adult hospice model. In other words, where once you invoke the hospice benefit, the hospice takes over and provides all DME, all medications, pretty much anything, any need for a patient that is related to the hospice admitting diagnosis. Now that can be a little trickier with receiving that concurrent care that we all know that children deserve. So every different organization has kind of coped with it and dealt with that in a different way. And so just making sure that your team has a really good dialogue with the home-based team about kind of how they work and how they operate. I can say at Noah's Children, we are extremely lucky and blessed that we do not invoke, we are completely free of charge. We do not invoke any sort of hospice benefit. We do not charge insurance. All of our care is completely free. So it allows us to do concurrent care beautifully because again, the family, you know, as far as insurance is concerned, there's no hospice involved. So we're able to function pretty well, but we also, that means a lot of the equipment and the medications we use, we do go through insurance. So we partner heavily with our NICU and our primary teams when they're leaving the hospital to make sure that the family has everything they need for discharge. So some things to think about on discharge, medications for comfort, especially for your comfort care patients. If they're required in the hospital, just make sure they're going home with them too, and that the family feels comfortable and knowledgeable about using them and when they should use them. Wound care supplies. So I think about our babies with anencephaly. Sometimes there's some wonderful ways to be able to, you know, lovingly respect dignity and you know, doing hats and coverings and those types of things. So just making sure that if the family has been doing that for any sort of wound, that they're sent home with some supplies. Next slide. So feeding supplies. So there, again, there's going to be some families that would like to sustain their child's life through means of artificial nutrition hydration, where they're NG tube or G tube. So just making sure they have supplies for that. One thing we have found is 1 and 3 ml syringes can be really hard to come by, and most NICU babies and smaller babies are going to need those smaller, you know, dosage amounts. And so, especially your home-based partnerships with adult programs, that's probably going to be especially helpful for them because I promise you they probably don't stock those. So, a car seat letter. So in the state of Virginia, it is absolutely permissible and legal for a physician to write a letter exempting a family from placing a child who is in hospice care or going home from needing to ride in the car seat. So if families are very worried that the car ride home, that you know, the child could even pass away on the car ride home, there is the ability to provide a letter so if they were to get pulled over, that the child does not have to ride in the car seat. And then don't forget your normal newborn care items. A lot of times we use just simple things like fold suction to help with comfort, positioning, those types of things. Discussions about, you know, immunizations, kind of your usual newborn care are always wonderful to have with families as far as, you know, will they have a primary care provider when they leave? Will they be going for kind of normal newborn care, setting those things up before they leave? Next, advance one more, please. And then last thing is just your hospice and palliative care referral. Oh, you're fine. You can go to the next slide. So just making sure that as Peter beautifully said, even if this child either wants full disease-directed care and or limited interventions, that your home-based palliative care programs can be really helpful in kind of walking that journey with these families. And so helping making sure those are in place before they leave, if they're available in your area, is a wonderful gift. I wanted to just talk really briefly about our program. I focus mostly on kind of our home-based palliative and hospice program, but we do have a rapidly growing perinatal program. So we do support mamas with babies with life-limiting and life-threatening diagnoses. Again, just as our palliative and hospice program, we support women all around the area. They have to be delivering at a hospital within 60 miles of St. Mary's, but we partner with a lot of different hospitals and just working on birth planning, memory making, a lot of the things that Allison talked about, just bonding, memory making support, sibling support, family support. Very, very happy about the growth of our perinatal program. So for services, we are 24/7, 365 medical services, a physician, a nurse practitioner, and 3 RNs that have a PICU, NICU, and hospice background. So we have, I think, every sub area covered. We're very lucky from that standpoint. And of course, HEMONC for me, because I'm dual trained. We focus on pain and symptom management, goals of care and medical decision making, as well as communication and continuity of care. We also have a wonderful psychosocial spiritual team that includes a licensed clinical social worker, a bereavement counselor, who actually is also an art therapist, so that's wonderful, and a chaplain. You can do the next slide. We have resources for allied health and therapies. So we have a music therapist on staff. So we have music therapy offering for our patients and siblings. And we also have art therapy via our bereavement counselor who does some art therapy programming. For family support specifically, we have a wonderful patient services representative that is a liaison between the families and the team. And then we also have a community liaison and a volunteer support coordinator who, and you can actually advance the next slide, who facilitates all of our programs. And you can just kind of quickly, I just said to go, we have wonderful patient supports, wonderful sibling supports. You can go to the next slide. We have parent support, and then final slide, support for our bereaved families. So we offer bereavement services for 3 years after a child passes away. That involves counseling, the ability to, unfortunately now in our mental health crisis, we're seeing a lot more complicated grief, those types of things. So we've actually also secured funding for families to be able to receive therapy outside of what we provide for grief and bereavement. We are in process of also getting funding to support siblings for counseling. And so a lot of different support within bereavement. We also are working on a respite program. That's one thing that our families have identified, especially after the pandemic, that is greatly in need. So we're having a little difficulty coordinating with one of our home health companies, but we're hopeful to have that up and running very shortly, which will basically be a way for parents to have a nurse come in and provide care for several days for whatever the need is, just so that families can have a break for medically complex kiddos. So, and then next slide, which should be the end. I'm sorry I went through kind of quickly. I did want to leave some time for some questions. Like I said, you know, our program is very different from other programs out there. We're all wonderful and different in many different ways. So I just wanted to give you guys kind of a little bit of an example of kind of how we operate. So I will just leave that to questions now.
Excellent. Thank you very much to the team. I'm going to stop sharing so we can see. So a couple of questions that we have in the chat. Developing perinatal plans for care, so important for families and caregivers. Any confusion at the time of delivery does not help anyone. I think that was more a statement. My apologies. One of the questions, sorry, here's one. Could you work within the foster care system to find respite help? And if so, there's somebody in the chat that would be interested.
That's an interesting thought process. Honestly, our kids typically have such a significant level of complexity that I don't know that the foster care system would have a resource that would allow the families to feel comfortable. But you know, we're always looking to think outside the box and think about different ways to support our families. So I think most of our families that have kids that are either, you know, do not have significant technology dependence or neurotypical, those types of things, they have less trouble finding people to kind of jump in and provide that support. I find the families that really have difficulty are kids that have had medical technology needs and or may have significant delays that make, you know, kind of people's interactions different and makes people more uncomfortable. So that's why we've really kind of pursued the more medical respite route to make sure the families would really feel comfortable actually being able to leave and be gone and know that their child's medical care was in the hands of somebody that felt comfortable. But I appreciate any ideas. So.
Yeah, and a further kind of comment to that was they know several nurses that work in the foster care system and in the ICU. So if you could put your information in the chat, maybe the three of you, or I don't know if that's directed just at you, Kelly, but I think there's an opportunity there to network or to further ask offline.
Absolutely. I will put my email in the chat box. And I just want to say too, and I'm sure Peter and Allie, you feel the same way. We're such a small community, and we are so desperately in need of more people, and it's so hard. The state of Virginia is in so much need still for wonderful palliative care support. So I am here anytime people have questions or need to ask or want to run a case by or want to talk about resources or ideas. You know, we just want to make sure you guys all have the resources that you need. And if you have people who are interested, I mean, Peter's program sounds amazing, just with kind of increasing their interest or palliative care support. I'm more than happy in talking to anybody. Again, I don't know close to everything, but I will happy to share my experiences, my trials, my errors, those types of things, and I'm happy to provide support. So I'll put my email in the chat box.
Excellent.
Yeah.
Thank you. Sorry, Allison, go ahead.
That's okay. Yeah, I was going to say, I definitely echo that. If anybody wants my information for talking about any perinatal mental health resources, especially if your hospital or health system is interested in developing a NICU psychology position. I know that that's a really growing field and difficult to navigate a little bit. So I will put my information in there too.
Same for me. I put my email in there too. Dr. Allendorf said something here about perinatal plans of care, which I like to just address real quick. Which I'm sure Kelly and Allison might see this as well, being kind of large referral centers with the perinatal plan of care. One thing that we do see sometimes is that the plan of care might change, going from a more community-based practice to coming to a larger level 4 NICU institution. So that is one thing that I have had several instances where that's happened, where the plan of care has been a unilateral, or I should say almost an automatic entry into a pure comfort care paradigm, wherein that's not really the standard of care anymore. So I think you have to be very careful if you have a patient with the proposed life-limiting diagnosis that is only life-limiting because of a self-fulfilling prophecy. So we just have to be very careful what we label as life-limiting, and why is it life-limiting? Because a lot of times when if a referral center receives these patients, we might say, well, this is not really life-limiting. It might be life-limiting in the sense that your child's not going to live 3 to 5 years. They may live 6 months to a year, but that's still 6 months to a year that you get to cherish them and be with them. And it's almost as if they have several moments of grief. In narrative ethics, we talk about the tick-tock phenomenon, where you hear a tick-tock of a clock, you hear the tick and you expect to hear the talk, right? So if you have a situation where you are expecting your child to die quickly, and then I say, well, that's actually not the case. They could live 6 to 12 months with only a little bit of help. Now they have to have a whole nother set of grief. They have a whole nother opportunity to grieve, a whole nother opportunity to bond. It's just a very complex and very hard situation to navigate. So I saw that comment. I just wanted to kind of bring that up. That is something that we deal with not infrequently.
Totally echo your sentiments, Peter, of just, I have so enjoyed, in palliative care, we are all about the interdisciplinary team and working with other people. And I think it has been so rewarding to be able to work with our OB colleagues, our NICU colleagues, palliative care, all sitting down at a table together and talking to a family about what we anticipate and expect with this diagnosis. And sometimes there's a lot of gray in there that we admit that, like, this is what we know, this is what we anticipate based on what we know, and really working with the family to decide what their hopes and their goals are based on that information. But there have been many times when what we anticipate is not what happens when that sweet little baby's born. And so I think having the ability to really sit in with all the specialists at the table involved in the care, it really makes a very traumatic and difficult birth process, those types of things, just a little bit easier. And it's been a wonderful experience being able to do that for families. And And I look forward to doing it more in the future.
And I will attest to having seen sort of the downstream impact on families from those conversations. It makes a huge difference, especially in their kind of trust in the NICU team going forward, because there's been, open discussion of different possibilities and eliciting their values and their hopes and sort of demedicalizing their baby, giving opportunities for bonding. And so they come into a traumatic ICU unit potentially with a lot more kind of openness and trust in, if the team's not sure what the answer is, they're going to say that, and they're going to say what the different options are. And it does make a big difference when they've had those conversations.
Excellent. Thank you very much, everybody, for that wonderful panel. And they put their chat in there to the host and panelists. I'm moving it over to everyone. It's okay, minor details. I feel like we've got a theme going on today, and we're just gonna roll with it. So anyways, thank you again. And if you're able to stay on maybe for a couple of minutes, if anybody has any further chats or anything they want to add into the discussion, please go ahead and do that. At this time, we are going to break. I do want to we have two options here. We have a break. If you would like, we have a 15-minute break. If you would like to come back and hear about the Maternal Quality Care Alliance and the direction that we're going with that, and then we are going to have a presentation from Bon Secours as far as their service line and some of the upstream factors that they've been able to do, and really to use that collaborative approach to integrate models of care as we wrap around these services within the system and the community for our families. However, if you would like to take a longer lunch, we are going to break now, and we just ask that you're back at 12:30. Regardless of your choice, it is going to be recorded. So I just wanted to make it very clear with the agenda what we were doing there. So we are going to go ahead and have a break. If you want to be back at 12, we welcome you back. If not, we'll see you back at 12:30. Thank you again, everybody.
Next slide, please. So last year we came out during the BMPC Summit to talk a little bit about our goals to transform community engagement and really look at it from a different perspective at the Virginia Neonatal Perinatal Collaborative. And it was discussed at that time that we would be creating the Maternal Quality Care Alliance, and eventually the extension of that, our Birth Equity Network. And so we're really excited to come out during this year's summit to talk to you all about our work and collaborative efforts to expand the leadership and team at the Maternal Quality Care Alliance. So I'd like you to just briefly meet the individuals who are a part of our team. Myself, Tiffany Carter, with the March of Dimes, Mandolin Restivo with Postpartum Support Virginia, Sultana Kareem with the Postpartum Support Virginia as well, and Jamia Crockett with Families Forward Virginia. Next slide. So you all may already have seen this definition. However, we wanted to kind of go over it again so that you would know the goals of the Maternal Quality Care Alliance and also focus areas. And really the MQCA for short is focused on defining how community influences the health and well-being of birthing individuals through the intersection of healthcare, economic stability, and maternal health. The goal of this group is really to bring together stakeholders, develop engagement efforts through the use of maternal health focus groups, provide evidence-based strategies to improve perinatal outcomes, and drive statewide initiatives focused on improving the well-being and birthing people and their newborns. Next slide. We really want to ensure that we're focusing on reducing poor outcomes for mothers, birthing people, and their children, and using that community lens along with key research helps to inform decisions regarding recommendations for system-level change that directly impact the community at large. Next slide. So we're really excited to talk about our work over the last 6 months and really trying to engage and commune together and talk about initiatives for the MQCA and really what are we looking at and how are we trying to support community-based systems in collaboration with hospital-based systems. And so we have 4 key focus areas that we really want to talk about today. One is communication, data and analytics is next, strengthening community-based systems and partnership. And you'll hear a little bit about some of our key partners and communities and how they are doing just that, and training and education. Next slide. So strengthening communication, there are a couple of levels of communication and how the team really defined that. And one of those things that we really heard often was that there needs to be a gold standard of care related to hospital and provider level communication between community-based organizations, the community at large, and the patient. So just to give some high-level ideas of what that means is really focusing on patient-centered care, helping systems to understand how to implement this process as well. Trauma-informed care is extremely important, informed consent, inclusivity and systemic impacts of that, and implicit bias would be an idea in the area of hospital and provider level work. From a community-based organization using the same trauma-informed lens, also increasing patient engagement and community-based engagement, also promoting safe patient-centered care and levels of help. So how do we ensure that people are getting the help that they need based on what's going on with them at the time? And also how to help communities, community-based organizations to recognize and report unsafe care. From a community lens, what is community-initiated care? You'll hear a little bit about that this afternoon. And how do we empower change? And then lastly, for the patient themselves, just what is the relevance of having a patient bill of rights? What is that? And education and awareness. Next slide. So data and analytics, we know there's a lot of information that's currently out there related to reporting. However, I think as a whole, from a state perspective, but also community-based organizations, hospital systems, we're really trying to define what level of reporting is necessary and needed in order for us to be able to move the needle. So we talked a little bit about patient experience survey. In the last presentation that we made at the summit prior, there were conversations that were discussing how can we evaluate how patients feel about our care and what are some of the needs? And so this really came out of that. And the group as a whole at the BMPC has been working on a QI initiative that really focuses on fourth trimester implementation. And in the previous conversations, and presenters talked a lot about fourth trimester care and the importance, how it intersects with maternal mortality, and how can we do better in that space. And so also looking at just training and adjusting practices to ensure that we have an understanding of what it means to provide fourth trimester care. How do we build collaborative networks and systems that can support individuals during that time? Next slide. So I'm really happy today to really be talking about what it looks like to strengthen community-based systems and partnership. We've really been working over the last several years to do just that. And we feel like it's necessary, however, for the community-based organizations and community to have a forum which exists for themselves and others to be able to commune, to bring stakeholders together, to be able to talk about relevant things that are impacting systems, and then also to develop coordinated plans that address community-based care. We believe that by doing this, it's also going to help increase engagement with the Virginia Neonatal Perinatal Collaborative. We also want to inform. Part of our work tends to kind of live in the hospital-based system, but we want that to also inform the community at large. Community-based organizations play a really crucial part in doing that. And also providing education and support. If you followed us over the past couple of years, we've pulled in training and resources and information. And we want to just continue to expand that, but also to strengthen the continuum of care. I use the example now of discharge from hospital to home, all of the things that are going on with the family's care, being able to bring people together to talk about that, but recognizing and equally recognizing the importance of the clinical practice and that integrated model that also brings in community. Next slide. And last is training and education. We'll continue to do that, really focusing on community-based presentations. As Shannon mentioned, on June the 21st, we'll be bringing DMAS, Virginia Department of Health, and others to come together to talk about the doula implementation project that we have in the state of Virginia, how to get through that process, helping doulas to do that and to connect with the right resources, but also other things as well. We want to make sure that people are very well informed and that they have the latest information to help them make more informed decisions and educate their community members as well. And we hope to be able to do that again through our toolkits as well as webinars. And if you've seen kind of our transition over the past couple of years, we've also started to try to bring in community along with hospital-based systems. And so we're really focusing on trying to build a community-based conference. We don't have what that might look like, but we hope to be able to bring that together as well. Next slide. And so what does that mean for you? And so we really are actively, now that we have a plan in place, recruiting interested parties to join our work groups. This link here will be placed in the chat for you. And we would like to make sure that you go out and you put information out there in regards to your interest in actually attending one of our work groups. And it is an active work group. It probably devotes about 3 to 4 hours of time a month, but I hope is in the next presentation that we make during the summit in October, that we will have some information as well. We also want to encourage you to join our afternoon session focused on community-initiated care. And again, attending our June 21st webinar, Building a Sustainable Workforce. So thank you so much for all that you all are doing and the support that you are giving to community and to community members so that we can have healthy outcomes. And with that being said, Shannon, I know you're going to take down this presentation. I'm going to introduce our next speakers today. And these individuals have been able to implement and integrate successful programs by utilizing community-based partnerships. And in previous conversations that we've had at the VMPC and with hospital systems, a lot of individuals have asked, how do you do this? How should we do this? How do we take this back into our systems and make this work? And so we would like to share 2 individuals who are coming from Bon Secours Health Systems to talk about how to do that. And just give me a moment, and then I'm going to introduce everyone, and then I'll control this presentation here. So we're excited to have 2 individuals from Bon Secours Health System. Blair Bell, she's the Women's and Children's Line Service Director for Bon Secours Richmond. Blair graduated with her undergraduate degree in nursing from Lynchburg College. She went on to complete her master's degree in nursing at the University of Virginia. In 2019, Blair graduated with her doctorate in nursing from James Madison University. Blair's nursing career has had a pediatric focus, ensuring that our most vulnerable patients receive high quality evidence-based care. In her current role, Blair is responsible for the strategic growth and development of Bon Secours Richmond's Women's and Children's Services. Her current projects focus on access to care and collaboration with community partners. Outside of her work, Blair can be found with her husband, Jonathan, on the football, baseball, or softball field, watching their son and daughter play. We're excited to have you, Blair. And also I'd like to introduce Carissa McPherson. She is the manager of prenatal education for Bon Secours Richmond and oversees community partners for the Women's and Children's Service Line. She graduated with a Bachelor in Science and Biology and a Bachelor in Arts and Leadership Studies from the University of Richmond, and then continued her journey as a Richmond Spider by completing her Master of Nonprofit Studies degree in 2018. Carissa is both personally and professionally passionate about justice for all women, working within Bon Secours Richmond to break down silos and with community partner organizations to connect patients to the supports that they need outside of the acute and outpatient settings. She also serves on the board of Urban Baby Beginnings, representing Bon Secours. Outside of her professional endeavors, Carissa enjoys time with her husband and 2 young children, as well as traveling, playing tennis, and singing in a semi-professional chamber choir. Carissa, we appreciate you joining us as well. So I'll turn this presentation over to you.
Great, thanks, Stephanie. We're so excited to be here and to present the great work that we are doing at Bon Secours in really trying to bridge the health system and our community partnerships. Next slide. We started to recognize very early that we needed to make sure that our patients had access to community partners no matter where they were accessing our system, whether that was in a mobile health unit, the caravan, or whether one of our practices or hospitals. We had to have resources for our patients wherever they were, and these had to be wraparound resources. So if they started with us out in the mobile health and then delivered their babies in the hospital, this care needed to continue throughout their journey and really be wraparound once they were discharged home. We also know we needed to meet the patients where they are. We needed to make sure that they had access to healthcare in a place that they felt was safe and comfortable. And that's not the same for every person. So again, making sure that these community resources could meet the patient needs wherever they were. Next slide. Our caravan is one of our points of entry. And for the last 25 years, the caravan, or our mobile health team, has served our most vulnerable patients throughout the Richmond area. Currently, they serve across 5 sites using their mobile van. And we're excited to announce this fall that they will have a location in Manchester, which will be bricks and mortar. This is a team of bilingual Spanish and English physicians, advanced practice nurses, drivers, registrars, medical interpreters that help us provide chronic disease management, pediatric immunizations, and help connect resources for patients who may need care outside of the caravan. Next slide.
So we found that OB care worked best when we offered it within the context of a medical home. So we actually tried offering it in the mobile setting through the caravan first, but we found the logistics of that to be really difficult from a specialty perspective. And we found a lot more success within the medical home model. The medical home model is particularly helpful because moms are able to connect with the medical home long-term, which really matters postnatally. We talk so much about the 4th trimester. But the moms, after they have their baby, are able to return to the medical home for care for themselves after delivery, as well as for their baby. So our medical homes have a family-centered approach, and we focus really as much as we can on building trusting relationships. Next slide, please. So our family practices and our OB practices across Richmond deliver at 4 of our Bon Secours Richmond hospitals. So Bon Secours St. Mary's Hospital is near the city of Richmond on the edge of Henrico. Bon Secours St. Francis Medical Center is in Midlothian, Virginia, a little bit south of Richmond. Southside Medical Center is in Petersburg, about an hour south of Richmond. And Bon Secours Memorial Regional Medical Center is northeast of the city in Hanover. All 4 of these hospitals have birthing centers as well as NICUs. Next slide, please. We are so grateful to be here today presenting to you all about the importance of community partnerships, because Blair and I have seen firsthand the difference that it makes when patients are connected to supports outside of the 4 walls of the hospital. About 5 years ago, Stephanie and I met for the first time to discuss what it could look like to connect Bon Secours patients with the social support resources of Urban Baby Beginnings. We realized in that first conversation that our organizations brought very different skill sets and strengths to the conversation, and that if we worked together, we could support our patients in a much more holistic way. So since that first meeting, we have worked together, Bon Secours and Urban Baby Beginnings, to win hundreds of thousands of dollars in grant funding to provide Urban Baby Beginnings resources to support our Bon Secours patients. So we've gone through multiple iterations of what works best for our partnership and for our patients, and we've learned how to tweak that to a given location or to a given patient population. But what we have found in general, what we're mostly doing these days, is utilizing community health workers and utilizing a universal screening of our self-pay and Medicaid patients that we have found that to help us make the most impact. And in particular, we've learned along the way the importance of providing culturally relevant care and honoring culturally relevant support and community support in the process as well. And thanks to the support of our partnership with Urban Baby Beginnings, we have also been able to collaborate with all sorts of other nonprofits and entities across Richmond. I listed a few on this slide, but this is by no means an exhaustive list. So we know that our patients receive the best possible care when we care for them holistically. And that includes connecting them to all these other supports that they'll need when they leave our four walls. So we've connected with entities as diverse as Baby Buns for Life, which focuses in the NICU, Little Hands Virginia, which is a material-based organization to help our most under-resourced patients connect to things that they may need, like diapers or car seats, Healthy Families Richmond and their wraparound support services, Nurture RVA, particularly their breastfeeding real talk support groups that focus on women of color. And as we all know, the importance of mental health, we've been working on building our partnerships with Postpartum Support Virginia as well. Next slide. Blair and I thought it might be helpful if we walked you through a hypothetical path for one patient. So let's imagine a patient, we call her Jane, that presents at one of our Caravan mobile clinic sites. So let's say maybe she is about 9 weeks pregnant, and based off of her pregnancy, her insurance status, and her residential location, she is referred from the Caravan to our St. Francis Family Medicine practice out on Hull Street. So thanks to having caught her so early in her pregnancy, she is able to be seen for her first OB visit while she is still in her first trimester. And while she's at the clinic, she's able to connect in person with a community health worker from the Urban Baby Beginnings team, maybe even one that speaks Spanish, just like Jane does. So the community health worker can help her with her Medicaid application. It can help her address many of the social determinants of health, connect her with the additional resources that she needs for a successful pregnancy, supporting maybe her other children and any other health needs that she has individually. It may include enrolling her in existing formal programs or home visiting programs, whatever she qualifies for. And then thanks to our collaborations across Bon Secours and with other entities in the community, Jane's also able to connect maybe with nutrition and lactation support and mental health support and all the other social support resources she needs. She has a healthy delivery at one of our hospitals. So this one would probably be St. Francis Medical Center. And then after her delivery, because of that medical home model, she's able to return to St. Francis Family Medicine for her postnatal care. And she can also bring in her new baby for her pediatric care. So Jane feels connected to that medical home, and she also has been able to connect with culturally relevant support in her own community. Next slide.
Thank you, Krista. So that was a great journey, and that was ideal for a patient. However, it took us a long time to get there, and we've learned many lessons along the way. First, we learned about universal screening. So we tried to have providers screen patients, and we realized that they were not the experts in screening for social determinants of health or to connecting resources. This was becoming a burden for them, and we were actually having some patients fall through the cracks because they were getting screened out, where universal screening allows for all of the patients to be seen and for the experts, our community health workers, to really decide what resources are needed. We also know that we really have to have a collaborative care model, and it's important for our staff members to understand what that collaboration looks like. We are all after the same goal, and that's providing support and wraparound care for our patients, and understanding that the support that we're receiving from our community partners allows for our patients to thrive outside of our four walls. We also decided that consistent language was key. This is things such as understanding that not everyone is a social worker and there are different titles such as community health worker. We found that sometimes using the term social worker actually deterred patients from wanting to be seen. They felt like this was a punishment or that they were being referred to social services versus finding someone who could connect them to the resources that they needed. And also having open communication was critical. We had many conversations and some of them were more difficult than others. We've learned a lot. We've learned how to improve processes, and it goes both ways. We've learned different things, Urban Baby has learned, but together when we have that open communication and follow-up plans, we can have a successful relationship. Next slide.
We're really proud of the partnership that we've built with Urban Baby Beginnings, and we're just so grateful to have their expertise benefiting our patients. As I'm sure that many of you who know Stephanie know, Urban Baby Beginnings is really being recognized on a federal level for the work that they're doing here in the women's and children's space in Virginia. And this past fall, we were honored to be able to partner with Urban Baby Beginnings and host Secretary Becerra from the Department of Health and Human Services at our Bon Secours Sarah Garland Jones Community Center. And while he was on site here in Richmond, he actually announced expansions to Medicaid coverage for postpartum people. So it was a really exciting event, and kind of felt full circle for some of the progress and some of the ways that we have seen our partnerships and our community innovations and collaborations grow. So we look forward to being able to continue to advocate with our community partners in pursuit of the best possible outcomes for all of our patients. Next slide.
Yes, and as we continue to work towards the future, we would like to strengthen our community partnerships. This means strengthening our current partnerships, as well as looking to expand the partnerships and the offerings that we have for our patients and the women of the community. We want to connect our patients with the medical home, recognizing that they don't only need prenatal care, but also postpartum care is so important in making sure that their babies are cared for, really looking at the cyclical approach for the mom and child. As Stephanie mentioned earlier, data analytics, we want to make sure that we're measuring our success, whether that's success of our health system or the patient experience, the success of our community partner. Having the numbers to support that is really helpful. And then expansion of our current services. Excited to announce that just a couple weeks ago, we expanded Urban Baby Beginnings down into our Petersburg area, and we look forward to continue to expand services across the Richmond market. And to wrap everything up, final slide, Stephanie. We have recognized that teamwork does make the dream work, and we couldn't do this alone. Community partnerships are so important, and we are very grateful for all the community partners that we have here at Bon Secours.
Thank you so much for that wonderful presentation and really just sharing the success for Bon Secours and kind of where you're going. And I think that you all have a unique system in that being a community-based hospital and also having a mobile system connected to community-based providers and hospital systems is something that you don't often get an opportunity to see. And so we appreciate your leadership at Bon Secours Health Systems, and are just excited to kind of see your growth and where you're going. If there were any last comments or thoughts about how to encourage other systems to make these moves to make more integrated collaborative type partnerships, what are some of the words of wisdom that you all would provide?
I would say it's okay to start small and expand, build those relationships. Don't be afraid to have open communication. Sometimes it's not exactly what you want to hear, but it's what the community is saying. And we have grown so much by just having those open communication and those open conversations with our community partners. That would be my words of advice.
I almost started laughing because that was exactly what I was going to say, Blair, was start small. So, even just having a Zoom chat or a coffee date with that community partner that says, hey, I've got this program, it could be as simple as having that brochure in the offices might be the first step, but then you realize actually we could do a little bit more this way, or we could go after this grant together, or what if you had a community health worker from your organization and they were in our office one day a week, and all of a sudden you built this really robust partnership and you figured it out, you communicated, you learned from each other along the way, and then you can just keep adding to that.
Absolutely. Thank you for sharing that. I see a couple of questions in the chat, and I'm going to just throw them out there as well. And some I'll come. I'm trying to break down some of the questions. I think we have a few minutes of time. I just want to make sure we're on schedule. Does this service include lactation support, especially for ensuring exclusivity during the current formula crisis?
Krista, do you want to answer?
Yeah, so the short answer is yes. We focus on breastfeeding across all of Bon Secours Richmond, but we do have lactation support across the whole spectrum of care. So we have breastfeeding prenatal education classes. We have them available in English that are interactive and in person, but we do have breastfeeding classes that are evidence-based and available online in 14 different languages, including Spanish and Arabic. So we do have pretty robust outside of the hospital lactation support from an education perspective. We also have IBCLCs in all of our inpatient facilities, and we partner with multiple community partners to provide culturally relevant breastfeeding and lactation support out in the community. We also have a breastfeeding warm line that anyone can call for free at any time, as well as an in-person breastfeeding support group that is staffed by an IBCLC, which you can show up with your questions and you can ask them, you can build relationships with other people at the support group. We have that. And then we also have multiple other pathways to the community, trying to partner with CLCs and peer support as well. So we are very supportive of breastfeeding at Bon Secours Richmond, and we'll do everything we can to connect patients to the support that they need wherever they fall in their breastfeeding journey.
And thank you, Carissa, for that. And the last question, how does humility play a role in this work?
I think that just being open and knowing that you can't do this alone is the first thing. We had to have community partners. It's not one person can do all this. How can we take all the different pieces and put it together?
Say one thing really fast on that. I think, there is no way to fully understand every culture that exists in the department, let alone the way that cultural journey impacts all of the nuances of pregnancy and delivery and breastfeeding, let alone the rest of the health experience. So if we can work on having a posture of cultural humility and bringing that to the care that we provide and the way that we partner with culturally relevant community-based organizations and health workers, I think that ends up being a much better experience for our patients than pretending that we understand where each of our patients are coming from in their own journey.
Absolutely. And it definitely is a challenge because we are dealing with so many factors, things that are seen and some things that are unseen. And, the community is definitely an expert in what's going on in their space and that lived experience. I think all of us have tried to make sure that we honor and respect as we're trying to provide appropriate levels of care. So with that being said, again, Carissa and Blair, Bon Secours Health System, again, we thank you for everything that you're doing and want to continue to champion hospital systems who are doing this work. I know a lot of that is happening in this space, and we look forward to hearing stories and success stories just like you all.
Thank you, Stephanie.
You're welcome. So Shannon, I'm going to go ahead and turn it back over to you so that we can resume.
Yes, thank you very much. And thank you very much, Bon Secours. I always learn something new every time you guys are on. So thank you for joining us today. So it looks like most everybody is jumping back from lunch. There are a few comments in the chat. If anybody's able to answer those, that would be great. And I am going to go ahead and jump into, hopefully this works, the presentation for the VNPC. So real quickly, I just wanted to give an opportunity for some updates and full transparency. As much as I think that I have everything included, I am sure, in fact, I'm confident that I am missing some opportunities to highlight here. So as I am working towards better telling our story of the VNPC, that is still a daily struggle that I am still working to improve on. So a couple of quick milestones that we wrapped up. We did wrap up our first AIM OB hemorrhage patient safety bundle. This was our first successful project that we did launch and follow through to completion with actual great data. So we did have 21 of our 52 hospitals that initially reported data, or that reported data throughout the project, that reported it at the end. Of all the data that we collected, we had 94.5% have implemented and continued conducting a hemorrhage risk assessment. 77.4 have a process now in place to measure blood loss, And on average of those 21 hospitals, they are conducting an average of 7 unit drills per quarter per hospital. So I definitely want to, there was some definite outliers there, but 7 was the average. And then while we initially reported 38, I do want to highlight the fact that none of us could have predicted COVID. So I do feel that that's some of where we dropped off. And as many of you guys know, just in the recent times, we are now down to 51 birth hospitals. So I think that that may have had a role in kind of some of our data as we see it. So moving on, I do want to highlight, we are currently undergoing our first strategic planning process. We have hired an outside team to actually conduct this. Our first phase is complete, where they define the problem and the areas of desired impact as it relates to the VNPC. Some of the activities included facilitation of group conversations, and their overall output was the theory of change emerging as far as the framework on how they were going to follow through into the next phase of data gathering. Again, that is done. They used a co-designed stakeholder and family involvement information gathering and environmental scan and data, environmental scan and analysis. Over 170 responses were captured, and I want to say roughly 80 of them were one-on-one interviews. The remainder was a qualitative open survey that anybody could have responded to. And our phase 3 is a joint agreement and plan framework and approval. So we are actually meeting, and that has been done. We're actually meeting on Wednesday to really kind of start this phase 4 of the implement and organizational structure. So we're going to meet as a group. We're going to look over all the comments, kind of where things are at and where things are tending as far as what is our actual strategic plan going to look like. So what are going to be our goals for this plan, and what is actually feasible for us to do within the next 3 years, which this is a 3-year strategic plan, and then really use that to inform what our implementation plan is going to look like. And as I highlight this next slide, what we've previously used is we've used this as our structure, as how we define the VNPC, and what we've recognized with a lot of the comments and a lot of the feedback from the strategic planning process is that this kind of top-down approach is not really where we're at as a whole committee. So look to see an updated and an improved kind of infrastructure and hierarchy chart as we move forward. So we are taking that information, and that will be given back to us in the final phase of the strategic plan. So a couple of successes I want to go ahead and move into, as it's been mentioned previously in this presentation today, is that we have successfully launched our 4th trimester project. We launched it in November, December last year. To say that we haven't had some growing pains would not be true. We have, but we did launch this as a pilot, recognizing that there was going to be some learning hills and valleys as we went along with this project. So we currently have 19 hospitals onboarded and are actively meeting monthly and working with us. That's we have one hospital from every health system in the state represented, except for one health system, which right now is not kind of the time that they chose to participate. And then one of our health systems, we actually have every single one of their hospitals participating, to include one of their hospitals from North Carolina. I do want to highlight that Ballad has actually selected to utilize and implement this in their Nicewanger Children's Hospital, which resides in Tennessee. So this was not an intent of this pilot, but we are going to actually pilot this with 3 states in mind, not just Virginia, but with 3 states. So we have representation from North Carolina, Tennessee, and Virginia. The focus is going to be on care coordination, connection to resources within the community, and adherence to the ACOG's 4th trimester guidance, which we all know or should know by now, committee opinion number 736, which was published in May of 2018. We have collected baseline data. We have done storyboards for all of the hospitals, and what they are currently participating in right now are monthly webinars and technical assistance calls. And most of them are working towards finalizing their projects and their work plans. We are reporting monthly data. However, there's been a pause to that because we are actually in the process of onboarding it's called Life QI data management, which we will now utilize for the VNPC for every one of our quality improvement projects moving forward. The VNPC will cover the cost for individuals at each hospital to actually have the access to this and to put data in. So more to follow on that, but we are currently implementing that right now, and hopefully we'll resume our monthly data collection in June. Our focus areas for the 4th trimester project is reproductive health, perinatal mental health, human milk feeding, maternal health, and then prevention and counseling. So this is not a completely updated work plan at the top. We've actually added in a 6th phase. We realized that was important to actually highlight. So for our phases, we have our early prenatal phase, and that includes our 1st and 2nd trimester. We have our phase 2, which is our late prenatal, which focuses on our 3rd trimester to admission. And we have our 3rd phase, which is where the majority of our hospitals are implementing currently, and that is admission to discharge during that hospital setting. And we put birth in here, recognizing that it's all outcomes. And then we have our phase 4, which is, we do have a couple of hospitals implementing in this phase right now, which is focused on that discharge to 3 weeks postpartum, as we've highlighted in the data numerous times today, that there is that big potential impact that we can have with our early postpartum visits. And then our phase 5, we have our late postpartum, which is 4 weeks to 6 months postpartum. And then phase 6, as I had mentioned, is called our transition phase. And that's really focusing on a decision that's made between the patient and their provider on when the patient is ready to transition back to well women's care. So a couple of other additional successes that we've had since our last time we've been together, and that is that we've created maternal, we're not calling it a maternal disparities dashboard anymore. It's now just a maternal health dashboard in partnership with VHHA. We have paid for membership. So all the hospitals that are currently working on and implementing the 4th trimester patient safety bundle all have access to this dashboard to utilize for themselves or for their hospital settings to really identify where their opportunities are in which they can make some improvement and strides. We've also launched, as Stephanie just mentioned, the Maternal Quality Care Alliance. We've launched our new VNPC website, and we're getting ready to relaunch it again. Some minor hiccups, but if you guys have tried to get to the VNPC website, it's there. It's just not updated, but that will hopefully change this week. So stay tuned or keep checking back. There should be some new information showing up soon. And then we are actually going to go over and we're going to do another revitalization to really enhance and make it a lot more user-friendly. So just continue to watch out for our updates of our ever relaunching VNPC website. In the meantime, we have definitely taken up and really have honed in our messages and our way to reach populations and the media through our social media sites. So we do have a Twitter account, Facebook account, Instagram, and our YouTube account, which has all of our monthly webinars and the summits will be placed on that VNPC YouTube channel in a pretty timely basis. So I know there's been a lot of questions about the shortages with formula right now and the crisis we're in, and about re-lactation, or what are some messages to get across. If you guys have messages that are pertinent to anything maternal infant, please reach out, send it to me. If you have it in a meme or a graphic, share that. We're happy to put it out. But we did late last week, we were reached out and we were able to get that message out all over our social media accounts this weekend. So if you have not seen it, please reach out. We have a contractor who's done excellent work with getting this out in a very timely manner. We've also established, in conjunction with our maternal health dashboard, COVID pregnancies. So now we are able to filter our pregnancy outcomes as it relates to whether a positive or negative COVID outcome or test. And then we've also established a stillbirth dashboard. It has been embedded into the maternal health dashboard. So we are able to recognize if there was a stillbirth that occurred, and then to look at the overall outcomes as it relates. A couple of upcoming things that we are either actively working on or continuing to work towards as we move through the remainder of this year. We will be finalizing the strategic plan and move it to implementation. That we are set and on schedule for that to be done June 30th. So look for more information on that coming into July. We are in the process of working towards completing the locate tool and then submitting it to CDC. Again, there'll be further information, but that we're really looking to do this summer. We're going to continue to brand the VNPC and really work towards finalizing a communication plan, so we know what to expect coming down monthly, and you all can definitely share information back and forth. So please reach out to me, send me an email if there's something you want shared, and or just share our sites with your partners or your organization so we continue to get that message out. We will continue our monthly webinars. We've had great success with this. We are booked through the end of November, which we do not have a webinar in December, but we will have it. We will have our last one will be in November for this year. We do have a fully listed schedule. It will be on the website as soon as it updates this week. And if you're interested in providing information through our VNPC webinars, they will always be the third Tuesday of every month from 12 to 1. I will put that link to register. You only have to register one time. You will then have access to all of those for that year. If you're interested in presenting for us for 2023, please go ahead and reach out. We can go ahead and get you on the schedule. As I mentioned about our maternal health dashboards, we have a very robust, rich amount of data. And I do want to open it up to those that are interested in forming a data work group to potentially look at some of these outcomes and some of this information that we have on the data. I will be sending out a link to everybody that is registered later this week for the data dashboard, or I'm sorry, work group. So if you want to get involved and want to work towards that, there'll be an opportunity to see and work with that data. We're also in the process. We've had several meetings. We're hoping to have a draft work plan done by June for our eliminating bias in the dyad care. And what this will be is it will actually be, previously we've done our substance use disorder with our moms, and then we've done NAS, but we've never done a group fully together with our moms and babies. And so that's going to be the focus of this group of eliminating bias in the dyad care, is really taking that mother-baby dyad as it relates to substance use during pregnancy and afterwards. So stay tuned for that. Again, the draft should be coming out, and then we'll be looking to onboard communities, organizations, or hospitals at the end of this year. We also have a perinatal cannabis work group that is up and working. We have an environmental scan that is currently out right now. And if you want to, I will again put these links. I'll put all these links in the chat and also send out by email. But what we're trying to do is really understand the landscape as it relates to perinatal cannabis use across the Commonwealth. And that will then inform our work group on what direction we want to go as far as education, awareness, fill in the blank. That's what we're waiting to kind of learn or glean from that environmental scan. And then I want to go ahead and put this out there, save the date. I will hopefully have registration out soon. I've got to finalize a couple more things on the back end, but we will be in person for our 6th annual VNPC Summit. The reception will be October 23rd. That'll be Sunday evening. And then the actual summit will be in person all day on October 24th. I can assure everybody, right, it will be at the convention center. I was just there yesterday. There is ample amount of parking, and we will have a room block, and the hotel is a hop, skip, and a jump away from the convention center. So definitely walkable. So we look forward to seeing everybody in person at that summit. And then the exciting thing is that I'm going to be hiring someone to help me, a full-time person. And so hopefully we will have them onboarded within sometime in June. All right, that was a lot of information. So let me check the chat real quick and see if there's any questions. And I think that is it. So thank you very much. I know we are a little ahead of schedule. So let me see real quick where we're at. Oh, and Tiffany, are you ready to present? And Arthur, are you?
What?
Willing to introduce? I don't know if Donald's on.
No, I'm
here. What
Oh, you're there. I didn't see you, Donald. My apologies.
Donald,
what do you mean you don't know if I'm on?
I didn't see you. I didn't see you. I'm sorry.
Should I I'm having some minor computer problems. It's just a little slow for whatever reason. So I don't know, do we want to wait just a couple of minutes, Shannon, since I know there may be some people that may be joining at 1 for Dr. Moore. But I'm, if you want to keep going, just in interest of preserving her time.
I am open to either option.
Tiffany, do you mind if we wait just a couple of minutes? Is that all right?
I don't mind at all. I assumed a 1 o'clock start.
Yeah, and because I know there may be some people, I mean, I can just tell looking at the numbers that a number of people have jumped on just in the last couple, 3 minutes. So let's just, it would be very uncharacteristic for us to be ahead of schedule. So I'm sure people have learned to not be too hurried to get back on.
Do you want me to stop sharing?
Oh, no, that's fine. Yeah, we'll start here in just a couple of minutes.
Okay. And just for confirmation, am I sharing the right thing?
You are, yes.
Looks like it to me. Yeah, if folks want to get up and do a couple of jumping jacks or other your favorite isometric exercise, this would be a good time to do it.
So talking about preventing suicide and maternal mortality and presenting maternal mortality secondary to suicide, we're really talking about addressing perinatal mental health. Let's see. So Dr. Dudley talked about some of my conflicts, which are not honestly so much in the way of conflicts. I just like people to know that I am very much invested in, associated with, and lead both Lifeline for Moms and MCPAP for Moms. MCPAP for Moms is the first in nation perinatal psychiatry access program, and we'll talk a little bit later in this 45 minutes about what that is and what the potential is. Throughout the talk, I'll use the term perinatal, which for this audience, means during pregnancy and the year following pregnancy, and then perinatal mental health, which really, historically we talked about postpartum depression, really only focused on depression, but we now know it's much more than that. So we'll talk about mental health conditions that are affecting individuals in pregnancy in the first year following pregnancy, and then perinatal individuals. We do know the vast majority of persons who experience pregnancy are women and identify as women. However, that is not all. And so we want to be very inclusive. I will say perinatal individuals, I may say women, and I do intend to be inclusive of those that do not identify as women. So perinatal mental health complications are one of the most common complications of pregnancy. The rates are 1 in 5. If you include depression, anxiety, if you're more encompassing than that, it can be even higher. And frankly, this is an average. Right, so there are some populations of persons, especially those marginalized by racism, socioeconomic disadvantage, and our, individuals who are veterans who experience much higher rates, as high as 1 in 3, and in some cases 1 in 2. And teens also fall into the much higher risk category. We know that perinatal mental health affects mothers, children, and family, and that's really across the reproductive lifespan. And so for the early part of care, it's less engagement in medical care, prenatal care, associations with smoking and substance use disorder. For obstetric outcomes, untreated mental health conditions are associated with preterm delivery, low birth weight neonates, NICU admissions, and then after birth, lactation challenges, bonding issues, adverse partner relationships. We shouldn't forget that the partner of a perinatal individual with a mental health complication is also at increased risk themselves. And for the offspring of that pregnancy with untreated illness, there's potential for both short and long-term consequences in the way of cognitive delays, motor and growth issues, behavioral problems, and mental health disorders into the future. In fact, untreated perinatal mental health conditions are actually considered an ACE, or an adverse childhood experience, for the offspring. So when we talk about where does mental health sort of sit in the hierarchy of causes of pregnancy-related deaths, it is one of the top conditions. We see a lot of cardiac conditions here, infection, and it's upwards of almost 10%, depending on what you're measuring. In this case, mental health encompasses both suicide and overdose. For the purposes of this presentation, what I was asked to present, I'm really going to focus not on the substance use disorder component of this, but the mental health non-substance use side and suicide. But when you look at mental health conditions and infection, they lead maternal mortality as being preventable deaths. And when you look at the work of our maternal mortality review committees, really the conclusion is, and there's more information coming out on this all the time, is that 100% of pregnancy-related mental health deaths are determined to be preventable. So perinatal suicide really should be a never event. And we could argue that any suicide should be a never event, but especially in pregnancy and postpartum, where perinatal individuals have so much contact with the medical community, this is something we should be able to pick up and we should be able to prevent. Well, why? Where's the gap in that? And that is, these conditions remain under-detected and under-treated. Colleague and I did a systematic review, and if you looked at depression alone, even for persons in whom the perinatal depression was detected, less than a quarter actually got treated. So under-detected, and even when detected, it's woefully under-treated. So really the healthcare system needs to change to address perinatal mental health so individuals can get the help that they need and very much deserve. And we've made some progress towards this, right? Almost every professional society, governmental organization, anybody who weighs in the delivery of healthcare has come forward and said, we should be screening. Fine. However, screening or detection alone is not associated with improving mental health outcomes. We really need to walk down the entirety of what we refer to as the perinatal mental health care pathway. So screening, detection, first step. Great. But what happens, and this is where it often falls down and where the discomfort lies, is assessment, treatment, and follow-up. So why is that? I'd say many obstetric care clinicians feel inadequately prepared and resourced to address mental health. I would like to say this is, sort of ellipse historically, but we're still here, right? For a lot of us, it was not part of our professional identity. We did not train in this when we were in, residency or NP or midwifery school or what have you. And until somewhat recently, there was really a woeful lack of guidance. It wasn't until, in fact, about 2015-16 that ACOG made a recommendation for screening in pregnancy in the postpartum period for depression, anxiety. That same time, what was the Council on Patient Safety and Women's Healthcare and U.S. Pregnancy Services came forth and said we should be screening. But before that, there was silence. And we all struggle with this lack of resources and referrals. But what's on the plus side of this? Why is the perinatal period really the ideal time for detection and treatment of perinatal health? A couple things, which I already alluded to. we have so many regular opportunities to interact with perinatal individuals, whether it's 12 to 15 prenatal care visits in the hospital, in the postpartum period, outside of, diagnosis of cancer and intensive treatment. This is a time period where there's more contact with the medical community than is really usual, especially for this age range of individuals. Obstetric care clinicians have a pivotal and accepted role in addressing perinatal mental health. When we ask perinatal individuals, they want to be asked. The obstetric care clinicians are a safe place to be asked, and they would prefer it be done in that environment. And for many of our colleagues who provide obstetric care, who will say, I'm an obstetric care provider, I'm not a psychiatrist, we have to remember that 80% of depression or mental health is cared for in the primary care physician's offices outside of pregnancy, as opposed to psychiatrists. There are not enough psychiatrists. There will never be enough psychiatrists to handle the mental health of all the persons experiencing mental health conditions or disorders. And so we are the primary care physicians of obstetrics and postpartum pregnant and postpartum persons. And so we really do have a role here at a rate of 1 in 5 on the low side, 1 in 3 and 1 in 2 in certain populations. This is the most common complication of pregnancy. And so we really need to gain some comfort around this in the same way we do around diabetes and preeclampsia and preterm labor and birth. And fortunately, there is in fact increasing guidance and resources to help providers address this. Sorry, a little over animated here. So we talked about some of the barriers, at least on the clinician side of things. We know there continue to be barriers on the patient side and at a systems level. On the patient side, yes, as much as if there's an environment in which patients want to be asked, it's the obstetric care environment, there are others, but there's still some stigma associated with this. I still hear over and over again from patients, from focus groups in the literature, that concern of, DCF or DSS, depending on what you call it in Virginia, involvement is one of the reasons patients don't want to disclose. And then we all know there are systems level issues in which getting patients into a psychiatrist. Now we're going to hopefully this talk will empower some to provide more care where they weren't and give you access to resources to help provide care. And so part of the systems issues is we have to acknowledge the fact that this mental health is under-resourced. And so how do we increase the capacity of ourselves and our primary obstetric caregivers to address mental health? And we'll talk a little bit about that in the way of access programs. So, in a situation in which patients do not disclose symptoms or seek care, and we have unprepared clinicians with limited resources, there's a low uptake of treatment and there are negative outcomes, but we can change that. And so part of that change has happened through things like patient safety bundles. And so the Council on Patient Safety and Women's Health, which no longer exists, was the first to come out with a patient safety bundle. It was not picked up by AIM at the time, and this bundle first came out in 2016. Like so many of the bundles, right, it's sort of some bullets around what should happen in every clinical care setting for every woman, every time, in every setting. And it gives some general guidelines and bullets, but it doesn't really give the how. I and others are working with AIM currently to update this bundle. And with the new bundles, we know there's implementation efforts, there's implementation resources. And so that's going to be really important. And part of today is to get at the how. So understanding this patient care pathway, how do we integrate obstetrics and mental health care, and how do we address these perinatal mental health conditions is really critical to addressing the maternal mortality that is secondary to suicide, that is secondary to maternal mental health conditions. So there's 4 steps along this pathway. I'm going to use this pathway as the scaffolding on which to provide information over the course of this presentation. And so we'll start first with detection, which is usually kind of the quote unquote the easiest part. So the screening. So how do we detect if a patient has symptoms or is at risk for developing a mental health condition? And then the engagement piece. It's not enough to screen. We need to screen. We need to screen using validated tools. We need to present it in a way that ideally is a strength-based approach, and we maximize participation in care. We screen everybody, right? There's no judgment. This isn't, and I used to hear this, well, I screen people if they look depressed. We have no idea. We have no idea what's happening on the inside, right? And so a systematic approach to screening, in the same way we take a blood pressure on everybody, in the same way we check a DOP tone on everybody, we should be screening everybody for mental health conditions. And we should be introducing the screener, giving the why. I'll tell you, there's a list of resources at the end of this. One is a toolkit that Lifeline for Moms put together through funding through the CDC and the CDC Foundation. It's a one-pager on the why and how it normalizes mental health. It talks about how it's treatable. And it gives, sort of all the screeners for the various conditions in one place that is publicly available. We're happy to share it. And it gives talking points on how to introduce it. Not enough to introduce it and score it and go off in the background. Actually somebody has to come back and talk to the patient on whether it's a positive or a negative score and what that means. It's a great opportunity for education and preventative treatment per se. So there are validated screening instruments. They exist for many of the perinatal mental health conditions, and the ones that I will present are the ones that actually have been validated in perinatal populations. And so we'll touch base on depression, anxiety, PTSD, and bipolar disorder. And I'll pause a little bit on bipolar disorder. It is a severe mental illness, but it also is, if we talk about preventing suicide, we have to talk about bipolar disorder because there is a significant connection there. So there are a lot of screeners for depression. There are a lot of screeners for depression that have been validated in perinatal individuals. I'm going to talk about two in particular. They are the two that have been most studied, are most commonly used, are self-administered, are available in multiple languages. And usually, most people usually use one of these two. The PHQ-9 is 9 questions. Number 9 focuses on self-harm. It screens for depression only, as I said, validated in both general and perinatal population. So if you're providing, say, well woman, annual care, preventative care, then this is something you could, use for both populations. When you look at it, it's, self-administered, the patient can read it, it's in multiple languages or administered through, for an interpreter. If there's reading difficulties, low literacy, and then, they circle the answer, you score it. In the toolkit I talked about, it tells you how to score it. Very similar concept with the EPDS, only it is intended for pregnancy and postpartum only, not the general population. This is 10 instead of 9 questions. Number 10 is self-harm. So when you look at these, you want to look at the total score for these screeners and the self-harm questions specifically. If it's anything other than never, we want to probe that. EPDS also has an anxiety subscale, meaning questions 4 and 5 speak to anxiety. So some will preferentially use the EPDS and consider it both for depression and anxiety. Purists that I work with will say you really should do a separate anxiety screener. I think using this is certainly better than nothing, but something to keep in mind. Both of these are publicly available. This is available in over 40 languages. The most commonly used anxiety specific screener is the GAD-7. So GAD, general anxiety disorder, 7 questions, a score of greater than or equal to 5. It's a positive screen. And this has been validated in general and perinatal populations. And I know that I'm going through this incredibly quickly. I will say all of this is publicly available, and I'm happy to share the slide set along with the toolkits that I'll be talking about. And then PTSD is, there is a validated screener for this, also validated in general and perinatal populations. If you answer yes to 3 or more questions, it's a positive screen. And there are, if you answer this positively, there are sort of more in-depth screeners you could progress to. MDQ stands for Mood Disorder Questionnaire. It is a screen for bipolar disorder. And then, similar yes, no, self-administered. It can, in our practice, we administer the EPDS, the GAD-7, the PSD screener, and the MDQ at the initial OB visit. The MDQ, the other screeners really survey your mood over the past 7 to 14 days, depending on the screener. The mood disorder questionnaire is really meant to be quote unquote a lifetime screener. It only has to be done once over pregnancy and the postpartum period. As first onset of bipolar disorder, correlates pretty closely with sort of the childbearing years. I don't know a sort of a lifetime screener really, when you haven't lived a lifetime yet, is that valid? So we'll do it at the initial OB visit every time you have a new pregnancy. And then if you haven't screened for bipolar disorder at baseline, and you've gotten to a point in the pregnancy or postpartum period where you're looking to initiate pharmacotherapy for mental health condition, you must rule out bipolar disorder at that time, because treating bipolar disorder with an unopposed, monotherapy antidepressant has the potential to put somebody into mania, which comes at significant risk. And so you want to, I advocate for screening everybody for bipolar disorder, but if you haven't done it before you start pharmacotherapy, you should, and that is very clearly outlined in the patient safety bundle. So, I said historically we talked about postpartum depression. We historically talked about postpartum depression because if we asked about depression or screened for depression at all, we did it in the postpartum period. But the work of Kathy Wisner et al., they screened 10,000 women and then went back and said, when was onset specifically? And it's really, the easy way to remember is about a third, is if you screen people at the initial OB visit, you'll pick up people who actually came into pregnancy with a mental health condition, we just didn't know it. If you screen a little later in pregnancy, we advocate for around the 28-week glucola visit, you'll pick up those who developed it over the course of the pregnancy. And if you screen postpartum, you'll pick up those that, developed it in the postpartum period. And so although many of the current recommendations, I do foresee some changes coming here, we'll say in pregnancy or the postpartum period. And if you screen in pregnancy, you should still screen in the postpartum period. Really sort of a more serial approach will give you the greatest likelihood of picking it up. And the earlier you pick it up, the greater likelihood, early you pick it up and treat it, the greater likelihood you have for symptom remission and positive outcomes. So what we advocate for, and like I said, I think you'll see some of this coming out in future work, is doing an initial prenatal visit, get that baseline, identify the people that are coming into pregnancy with a mental health condition, do it again around that glucola visit to pick up the people who sort of picked it up over the first and second trimester pregnancy. And then at least at the 6-week postpartum visit, this is just like routine screening for people have a mental health condition, for people have been struggling, doing it in a monitoring, using your screeners to monitor treatment effectiveness can be very, very helpful. All right, so then we move on to assessment. Assessment is about two major things. One is the differential diagnosis. So is this a mood disorder? Is it some other comorbid condition? Is this a medical condition? And then, for the mental health condition, thinking about what is the severity of the disease, because of course that ties directly into this question around preventing suicide, and what are the risks of things like suicide and infanticide. And this is what makes people incredibly nervous. And I appreciate that. And I think that I have been to many of these talks given by psychiatrists, and people are like, well, you're a psychiatrist, of course you're comfortable with that. And I think I have a little bit more street credit as an OBGYN because I do this, and I can acknowledge that it originally came out of a place of discomfort. So when you think about the differential diagnosis, it's things that are sort of most common: depression, anxiety, OCD, PTSD. OCD, PTSD fall into anxiety-related conditions. Bipolar disorder, which we're going to talk a little bit about more, so that's a mood disorder, and then psychosis, which of course is a mental health emergency. When we're thinking about these mental health conditions, we also want to think about, it's often not one or the other. They're often, like depression, anxiety often are comorbid with each other and they come together. You can also have comorbid substance use disorder. And then there are medical causes, right? Somebody who has severe hypothyroidism may present as the same as depression, and significant anemia with its fatigue. And so there are some labs that you can check. You want to make sure that these are okay, while you're also thinking about your differential for mental health. We talked about the screeners in the last section. Now, the screeners are just that. They are screening tools. They are not diagnostic tools. However, the scores on the screeners do correlate with the severity of disease. So if you look here, these are the various screeners, and it gives you the cutoff for what is likely to correlate with a mild, moderate, or severe severity of disease. And knowing the severity of the disease is really important in thinking about treatment, because as you can imagine, treatment for severe disease is more intense than treatment for mild disease. When we talk about assessment, often people get nervous. To assess really is to ask about symptoms, illness severity, and like your ability to function and do the activities of daily living, to understand people's stressors, how long have the symptoms have occurred, how often are they occurring, are you having feelings of hopelessness or helplessness, are you currently taking any medication or attending therapy, or have you in the past? So what's your past psychiatric treatment? What's your personal and family history of mental health conditions? Because those are, risk factors for having disease. Have there been previous suicide attempts? That, of course, is going to weigh heavy into somebody that you're worried about. Have there been prior psychiatric hospitalizations? This would speak to somebody who's had more severe disease in the past. And what sort of the current experience of suicidal ideation, plan, and intent? For depression, the definition of depression is captured in the symptoms here. So depressed mood, and at least 5 of the following must be present for at least 2 weeks to meet the definition of depression, right? So sleep can be increased or decreased, interest or pleasure can be decreased, experiences of guilt or worthlessness, energy decreased, fatigued, difficulty with concentration or making decisions, appetite or weight changes increase or decrease, psychomotor agitation or retardation, and suicidal ideation. And I, in med school learned the acronym of SIGI-CAPS, and that is how I remember it. And as I'm talking to someone, literally is sort of that acronym is going through my head. With regard to general anxiety disorder, it's restlessness, fatigue, that excessive anxiety and worriness. It can be some increased muscle aches or soreness, sort of that sort of hypervigilance, impaired concentration, irritability, and difficulty sleeping. Anxiety sometimes comes forth as anger, and not always sort of an obvious sort of fearfulness or anxiety. And then I always think it's worthwhile talking about OCD or PTSD to the extent that intrusions or intrusive thoughts can be a very prominent feature of this. And so often perinatal individuals that are talking about sort of these intrusive thoughts about throwing the baby down the stairs or drowning them in the bathtub or taking knives to their bellies, like these like terrible thoughts that really make them anxious and are not like they're fearful to them. And you often as providers will worry about infanticide or worry about suicide when we hear that. We'll talk a little bit about this in a couple of slides, but often if they're anxiety provoking, that's often reassuring to a provider that they don't intend to act on that. So let's pause on bipolar disorder for just a moment. And I said this earlier that it's imperative to rule out bipolar disorder prior to initiating pharmacotherapy. And for those, in the audience that are worried about how do I really know if it's depression or anxiety or PTSD or OCD? In some ways, it's not mandatory that because the treatment is the same, fortunately. This is the one thing you really need to think about differently because the treatment is different. You don't want to give somebody who has or whom you suspect has bipolar disorder an unopposed antidepressant because you can precipitate mania, which can be associated with psychosis and can be associated with infanticide and suicide. And when you look at that sort of same work by Wisner et al., who screened 10,000 people, almost a quarter of those that sort of screened positive for perinatal depression when you dived deeper actually had bipolar disorder. So a quarter of the people who think have depression, whom we might give an unopposed antidepressant to, actually with further evaluation would have bipolar disorder. And so that's why doing a bipolar disorder screen, if it's not just part of your routine baseline for everybody, needs to be part of what you do before prescribing. And that really is a safety thing. So bipolar disorder, it increases the risk of postpartum psychosis, right? This is an emergency. Postpartum psychosis is relatively rare, right? It's only 1 to 2 out of 1,000 women. But of those 1 to 2 out of 1,000 women, 70% will have bipolar disorder, which is why knowing who has bipolar disorder and screening for it can be incredibly important. And psychosis usually shows up in the very early part of the postpartum period. And if you know, for example, somebody with bipolar disorder, one of the ways to prevent psychosis or worsening is to keep them on their bipolar medicines, or to help have safety plans in place around sleep hygiene and how we're sort of going to help mitigate the potential negative consequences of bipolar disorder. When somebody has psychosis, you want to, of course, rule out medical causes of delirium. This is a psychiatric emergency, and these are patients that are increased risk of suicide and infanticide. And so keep in mind that persons with bipolar disorder are at increased risk compared to others. And so if we're talking about mitigating risk of suicide, this is something we really need to think about. Suicide, the thought of it, it really makes everybody nervous. So who's at lower risk of suicide, right? So we did the EPDS, we did the PH29, they answered something other than none in the question around self-harm. When you're doing that assessment and you're talking, if somebody's had no prior attempts, if their prior attempts were really low lethality with high rescue potential, they really have no plan, no intent, there's no substances involved, and they have protective factors like family, friends, support, forward-facing outlook, that's somebody who's lower risk. Not no risk, but lower risk. And if somebody who's high risk, right, it's the opposite of that. Prior history of suicide attempts, high lethality, recent attempts, they have a plan, they have intent, there's substances involved, and they have lack of protective factors or including social support. That's somebody we worry more about. And if you think about sort of suicidal ideation, there's a broad spectrum. Anything other than none on those questions should raise our eyebrows and be a red flag. Again, there is a big difference between, I guess I just find myself thinking a lot about death lately. No plans, no intent, forward thinking, supportive factors, planning, excitement around the baby walking and, a year and what have you, all the way up to, intent. The house is empty. I'm going to hurt myself tonight. I have a plan, right? And of course, a wide range in there. When we think about things like infanticide, which I go back to those intrusive thoughts, when we have patients that say, I imagine myself drowning the baby, I imagine myself throwing the baby down the stairs, like that is alarming. And there is, OCD, anxiety, depression can be associated with those intrusive thoughts. If they're not scary, if there's such a thing, intrusive thoughts are in which the patient has good insight, right? It's alarming to them. They don't want to do it. It's totally freaking them out. And those thoughts are scary to them. They have no psychotic symptoms, and it causes them anxiety. There's a very low risk in those situations that they would act on those thoughts. Compared to postpartum psychosis, in which there is poor insight, there are psychotic symptoms, there are often delusional beliefs or distorted reality. The perinatal individual, postpartum individual who thinks like something is wrong with their baby, and they would be doing a good thing, protecting them and saving them by killing them to prevent a lifetime of suffering, right? That is high risk, right? That is, right, it's a delusional belief, it's a distorted reality, and that's something that needs to be acted on. All right. We're going to get into the third part of the perinatal mental health pathway, and that is treatment. There are evidence-based treatments, and how we discuss these with patients, our knowledge of them, it matters. The options we give around treatment and supports, and this includes therapy, medication, and adjunctive interventions. When I talked about in the assessment part, severity, we talked about how stepping up care is important, right? And so in mild disease, the obstetric care clinician, we should be able to handle this, honestly. With moderate disease, we can handle this often with a little bit support, hand-holding with our psychiatric colleagues. Consultation with a referral psychiatry really is needed in severe disease. So certainly in psychosis, in schizophrenia, in some cases in bipolar disorder. With the help of access programs across the country, we're seeing more and more obstetric providers help care for patients with bipolar disorder and be their prescriber, because there isn't somebody else. And if we're talking about preventing suicide and harm, treatment is needed. So the 3 pillars of treatment include therapy, number 1, especially for depression, anxiety, PTSD, and OCD. Medication. Therapy is not enough in the case of bipolar disorder. Medication is required. And then the adjunctive interventions. So individual therapy is first-line treatment for mild disease, in particular, as I said, depression, anxiety, PTSD, OCD. And there's a variety of types of therapy. I'm going to be honest and say I know some differences between these, but the truth of the matter is you're almost always in a place where if you can get therapy, right, you're lucky. And so the difference between cognitive interpersonal therapy may not be a distinction you need to make. And whether it's individual, couples, group, or family therapy, the evidence base around first-line therapy is really around individual therapy. It's important when you start to think about the role of pharmacotherapy in pregnancy and postpartum. There's 2 points of decision nodes around pharmacotherapy. One is continuing somebody on something they were already on to begin with and maybe entered the pregnancy in, versus discontinuing. And the other is, do I start somebody who's native to this and developed the mental health condition over the course of the pregnancy? It's important to remember that for those that come into pregnancy, having taken antidepressants, their risk of relapse is much higher if you stop it. So it really is a risk-benefit conversation, a sort of patient-centered counseling, shared decision-making, and talking about, in the very first part of this presentation, we talked about what are the risks of untreated disease. So it's not just medication, not medication, it's really treated disease versus untreated disease. And so when is pharmacotherapy indicated? Well, it's indicated usually in moderate to severe disease, if suicidal ideation is present, if they're having difficulty functioning, caring for themselves or baby, certainly if psychotic symptoms are present, and I hope at that point you have the support and help of your psychiatric colleagues. History of prior mental health that required treatment, and whether if you have like more than one condition together, and depression and anxiety really often run together. And then, of course, when you may not need medication, if you have mild disease, able to care for the baby, engaged in therapy, psychotherapy has resulted in improvement in the past, or there's sort of strong reason to think it'll help this time, and the patient prefers not to be on medication and really wants to engage in psychotherapy. I circle anxiety around medications indicated because although depression and anxiety are treated with the same medications, it often requires more and for a longer period of time to treat anxiety in comparison to depression. When you think about sort of FDA categorization around medications and pregnancy, they're honestly it's not that helpful in informing decision-making, right? The FDA pregnancy risk categorization speaks to risks in pregnancy. They don't consider the risks of the illness itself, and it doesn't consider the benefits of the medication. So although we have, sort of the lists of risks in front of us as we're counseling, we also need to really think about what are the risks of not treating and what are the benefits of the medication. So you're really, I said this before and I'll say it again because I think it's a really incredibly important point. You're not asking the patient whether they want medication or not, right? You're having a conversation around the risks and benefits of untreated illness versus treated illness. And so this is in the toolkit, again, happy to share. But so what do we know about antidepressants? They do not appear to be linked with birth outcomes. There's some studies to say preterm birth and low birth weight, and there are some studies to say depression itself is associated with preterm birth and low birth weight. Some antidepressants have been linked with a small but inconsistent risk to birth defects when taken in the first trimester, and that's particularly paroxetine, so we try to stay away from that. However, a lot of our patients will come to us on these medications in the first trimester. The exposure has happened. And so when we talk about exposures, it's like you want to minimize number of exposures. So if somebody comes to you in pregnancy and first trimester on a medication, stopping it may, so they've already had one exposure. Stopping it may expose them to untreated disease, which we know has risk, and then reinitiating it with something else has the potential to be a third exposure. So you want to minimize exposures. There has been a link of neonatal withdrawal symptoms that can last days to weeks. These are transient. They will resolve. Tapering in the third trimester is not recommended. It does not change this, and they will resolve. And then there's some inconsistent but overall reassuring evidence regarding long-term, sort of months to years, neurobehavioral effects on children. That is balanced with what happens if you don't treat and you have an untreated perinatal mental health condition. This has been linked with birth complications. There is an increased risk for severity of postpartum depression. You can make it harder for moms to take care of themselves and their babies. That interferes with bonding. As I said, that is an adverse child experience for that offspring. Already said that around the bonding, can increase risk of mental illness among the offspring, and there have been links to possible long-term neurodevelopmental outcomes. And the fact of the matter is, SSRIs are some of the best studied classes of medications used in pregnancies and these are the ones that are most commonly used. So what are if you're going to prescribe, what are some of the prescribing principles? If there's an indication, and as I've noted, there is indication. So if somebody's used something in past and it's worked, go with that. Use an effective dose. I see a lot of patients who are sort of started on a baby dose of, Zoloft, and that's what they stay at. It's not an effective dose. If you're going to use something that's actually going to work. You may need to titrate up. You want to minimize switching, meaning you go up on the same med and not say, oh, that baby dose of Zoloft didn't work. Let me try something else. Monotherapy is preferable. So you want to maximize a single treatment before you do multiple multiple medications at the same time. And that may be when you bring in somebody else. You may need to adjust the dose, increase it when the pregnancy advances, and you don't want to stop SSRIs prior to delivery. That's not going to change that transient newborn withdrawal syndrome we were talking about. So this is sort of an algorithm around, do I start it and what do I start? So are they taking something? No. Have they taken something in the past? Use that same one. If they haven't, then you can consult the toolkit in our medication chart. Are they taking something currently? Yes. Have they been on a therapeutic dose? The next slide will show you what that is, for at least 4 to 8 weeks and it hasn't helped. If that's the case, then you may need to change medicines. If they're on it and their symptoms are improving but not resolved, and you have room to go up, go up. Okay. So in the toolkits, there's sort of first line, second line, lots of information about various medications. There are lists of SSRIs here. These are starting doses. These are not therapeutic doses. These are the doses you're getting at. So starting somebody on 25 milligrams a day of Zoloft, you would not expect them to be therapeutic or to experience symptom improvement here. So it needs to sort of titrate up. And there is a titrating process because it helps to usually minimize some of the side effects. So some of the side effects include temporary things like nausea, constipation, diarrhea, lightheadedness, or headache. Some of the long-term ones can be increased appetite and weight gain, changes in sexual interest and experience, vivid dreams, and insomnia. So depending on how the patients experience this, whether you take them in the morning or night can be helpful, and taking with food can decrease the side effects. So side effects often improve after 2 weeks, and it typically takes a month or more for a therapeutic effect. And again, so you can take them in the AM or PM depending on the side effects you may or may not be experiencing. Breastfeeding is generally, it should generally not preclude treatment with an antidepressant, and there are many options that are reasonable in breastfeeding. Sertraline, paroxetine, and fluvoxamine have the lowest translactal passage, so passage into breast milk. And then just like a quick 1-2 slides on brexanolone or Zolressa. And so this is for moderate to severe depression with onset in the 3rd trimester, early postpartum. It's a formulation of allopregnanolone. It allosterically modulates the GABA receptors. It has a rapid onset of action. So in the last slide, we talked about SSRIs can take about a month before you experience some symptom improvement. This can be as quick as 1 to 2 days. It's a very sort of defined person who's eligible for this. And it is a 6-hour continuous inpatient infusion. And some hospitals have it, some don't. A lot of the access programs know who and like where it is and is not available. But if you look at the RCTs around this, you sort of have an immediate drop. I think what's interesting here is also placebo has a pretty significant drop. And this was 60 hours in a hospital. It's amazing what caring for somebody and letting them sleep can do. But those that experienced the brexanolone had greater improvement, and those improvements were durable out to 30 days. And that was, you know, that was the study. There's additional studies going on in oral agents. This was the IV infusion one. The most common side effects, which is why it's recommended to deliver in the hospital, is the loss of consciousness, headaches, dry mouth, sedation, and dizziness. Regarding adjunctive therapies, they fall into 3 categories. One is social engagement. So it's identifying sources of support, which can come in a lot of ways for, you know, in different ways for different people. What's called personal engagement, which is, you know, values congruent activities around self-care, identifying what are pleasurable activities, acts of self-kindness, meaningful activities, and then physical engagement. So body positive approaches like nutrition, nourishing movement, and it doesn't need to be quote unquote exercise, right? You don't need to be in the gym. It's me going out for a walk, avoiding substances, managing medical concerns, right? Like it's not just about the pregnancy. It's not just about the baby. It is about you or the, you know, the perinatal individual, and helping them get to their therapy, for example, or helping them to sleep. And so within the toolkit, there are these self-care plans that help to make sort of concrete, actionable sort of small goals around this adjunctive therapy. Adjunctive therapy is just that. It is not therapy alone. You really need, you know, sort of psychotherapy and or pharmacotherapy, and this is in addition to that. And last but not least is follow-up. So this is the last step on the perinatal mental health pathway. And so follow-up and monitoring, how to follow up with patients, monitor their symptoms, adjust treatment into full remission of symptoms in a proactive manner. So those screeners, when you don't yet have a mental health diagnosis, are just that, they're screeners. But once you have a mental health diagnosis, especially those for depression, anxiety, you can use those to monitor whether or not your treatment is effective, right? So if you start with an EPDS of 23 and you're starting to titrate up the Zoloft and you're attending therapy and it goes down to 16, that's great. You've made improvement, but you still, you know, you have a ways to go. And so you can use that to help titrate your treatment. You know, do you continue treatment, or when in some cases can you stop pharmacotherapy, for example? And so some guidance around that, and then we'll talk about the resources. So I've touched on this a couple of times here, and I know we're getting short on time here. So really, once you've identified a condition, once you've initiated treatment, it's regular check-ins around seeing, you know, are we going in the right direction around symptoms, and are you experiencing side effects, and letting that help titrate the approach to treatment. And then if you are not the provider that is going to continue treatment, then really thinking about what is the warm handoff and who is. Here it says contact a perinatal psychiatry access program. We're going to talk about what that is in just a minute, because now we've hit resources. So there are 4 major resources that I want to make sure everybody is aware of. One is toolkits, another is e-modules. One is implementation guide to how to integrate obstetric care and mental health care, and the other is access programs. So I said this, our team was funded through the CDC and CDC Foundation to make a perinatal mental health care toolkit, and it was very specifically in a call to addressing maternal mortality related to severe mental illness. So this toolkit covers depression, anxiety, bipolar disorder, and PTSD. It covers suicide, it covers treatment, it covers counseling. It provides the screeners that we talked about and how to introduce and talk about the screeners. And it's all very algorithmic. This has been licensed to ACOG and is currently available on the website. Some of the work we did early on specific to depression is available for free through the app stores, the Lifeline for Moms app, which has a lot of what's in that toolkit in electronic form. When we did this, it was focused on depression only, as opposed to more broadly, more severe mental illness. So it's limited in that way. And I know we didn't talk about substance uses very specifically, but I just wanted you to make you aware that the MCPAP for Moms program has a great toolkit specifically around substance use disorder, if that is of interest. And then we received funding through NIMH to create e-modules. So it's a more in-depth version of this talk at your own pace, as opposed to my rapid pace, that will soon be available. And again, will be licensed to ACOG and available through their e-module system on their website. And then also in collaboration with ACOG, our team was funded through the CDC to do a study on how to integrate obstetric and mental health care in Massachusetts. And we did that in a very resource intense way with a lot of technical assistance to our practices. And ACOG charged us with trying to sort of pare that down in creating resources so people could do it in sort of a self-help way. And so that is complete. They're kind of going through it, and it will be soon available again and up on the ACOG website. The other thing I want to talk about is perinatal psychiatry access programs. There are 20 states or healthcare-based programs and one national consult line. Virginia does not have a mother's access program. It has a child's access program. And I've been told by Shannon that there is, lots of energy and eagerness to have a mother's program. So I don't put this out there as like a tantalizing thing you can't have. What I really want you to know is that PSI, so Postpartum Support International, has a national program. And so every obstetric care clinician in Virginia has access to this. So what is an access program? It was really designed as a way to increase the capacity of obstetric care clinicians to address mental health. So if I have somebody in my office who I'm worried about, who I don't know what to do with, and I will say, 10 years ago, that was just they screened positive on EPDS and I didn't know what to do. I could pick up the phone and I could talk to a perinatal psychiatrist who would walk me through in a way that is meant to be sort of educational, teach me what to do. Every program has sort of 4 general components to it. There's this consultation piece, resource and referral. In our state, we keep a live active inventory of all behavioral health resources. So when obstetric care clinician calls, we can say, here's your patient who speaks Spanish and who lives in this zip code, and this is the insurance, and here are the 3 therapists that are available to them. There's training, so we'll come out and do trainings, and then there's technical assistance. These access programs are clinician-facing warm lines. It is not the patient that calls. It is the doc or the midwife or the nurse practitioner, the PA, or somebody from the office. And these are Monday through Friday business hours. With the national one, there's often you can leave a message and they'll get back to you within about 24 hours. Where you find what states have these and the numbers, including the national line, is available through the Lifeline for Moms website. And then a new resource that is available as of Mother's Day, which is really exciting, is the National Maternal Mental Health Hotline that is funded through HRSA, and PSI is orchestrating it. This is a patient-facing hotline. And so 24/7, a patient in crisis can call this number, and they are well-trained therapists, individuals, licensed clinical social workers, a whole cadre of people that have trained to do this, are specific to and passionate about perinatal mental health, and they are also directly connected into things like suicide hotlines and other hotlines. So this is a very new resource that is open to everybody in the country. And then I mentioned, this is the patient safety bundle. This still exists and it's up online. There are a number of different educational opportunities and modules that have been recorded that are there. And I did mention that AIM is sort of re-upping this bundle now. So I think you'll see much more coming out. And then of course, ACOG has a number of different guidelines and recommendations around mental health. I will say that these are currently under review and future guidance will soon be published. So I hope, I know this is not a crowd that needs to be convinced, but really integrating mental health care into obstetric practices really can be transformative for the perinatal individuals and families we serve, and it will prevent suicide and maternal mortality, because how to prevent those is by addressing this up front. So I just want to thank you for the opportunity to talk today. And I don't know if there's time for questions, but I'm happy to entertain them either in the moment or through emails or chats or what have you.
Well, thank you so much. I really appreciate that. Time is a little short, but I had one quick, brief question. It may not be brief. I don't know if the answer will be brief. But in setting up one of these access programs, what are the most common obstacles that states and other programs encounter as they go about doing this? Because this is something that's been near and dear to my heart since I first heard you talk and several years ago, and would love to be able to get something like this going on here. And Arthur may be able to tell us a little bit about what's been going on in North Carolina since he just came from there. But so Tiffany, from your experience, what are some of the big obstacles that people have to deal with?
I think the biggest obstacle, honestly, is funding, right? And the sustainability. So we've worked with North Carolina on theirs. They have one of the HRSA grants. And so it's a 5-year HRSA grant, and right, the 5 years is coming to an end. So what's next? There's currently legislation called Into the Light, which is looking to expand funding to existing programs and increase the total number of programs.
And is this HRSA funding that you're talking about?
Into the Light is federal legislation, right? So it's not written into law.
Yeah, but it would go through HRSA.
Presumably, since the existing programs do go through HRSA, but some of the states are not funded with these federal dollars. They are, like, for example, Massachusetts, it's a line item in our state budget. That took a lot of time and advocacy. And we had the child program first, which now you have a child program, which is great because you can sort of build off of the success of that. And there's some opportunities for sort of some efficiencies of using some of that infrastructure, even if a lot of the states that have both the child and the mom program, some of them really use common infrastructure and others are really separate programs. So there's different ways to do it, and no way is right or wrong. But I think like getting the momentum and enough support and advocacy to get the funding, I think, is usually the biggest rate limiting step. Once you can do that and like fund it, then building it is the easier part. And I would say the other challenge, honestly, is getting people to know about it. It doesn't matter if it exists, if nobody knows about it and nobody uses it.
Yeah. What about finding psychiatric providers to participate? Has anybody, have that been relatively easy for states?
So I know in our state, like this is like our perinatal psychiatrists love working with this program, right? It's not like 15-minute med checks, right? Like you really feel like you're making a difference. This is a program in which it's, sort of teach a man to fish as opposed to give him a fish, right? And so every time you interact with the provider, you have the potential of not just treating one patient, but many as you've increased their capacity to address it. Most of the perinatal psychiatrists that are involved in these programs like really love it. We have, I know in Massachusetts, like we don't have enough positions for the number of people that want to do it.
They can come down here.
Yeah. Well, and honestly, right, with the national program, we have talked about, can you cross state lines? And with telemedicine and telepsychiatry, the answer is yes. And right, and the national program has done it because it's depending on how the model is set up, there isn't perinatal psychiatrist to patient interaction, right? There's not a medical legal responsibility between them. It's the perinatal psychiatrist to the obstetrician and its education on a theoretical patient. Some programs like ours actually do face-to-face consults, but not all do.
Okay, all right. Thanks very much. What do you think, Shannon? Should we move on?
Yes.
All right, Tiffany, thanks so much. We really appreciate your time and speaking with us. I think it was a great talk and I learned a lot like usual from you. So
thank you. And I know it's rapid fire. So if there's ever anything you want to deep dive on, let me know.
Well, we can always slow it down on the YouTube video. So, or at least stop it so we can catch up. All right. No, thanks so much.
Thank you.
All right, bye-bye.
Thank you for that informative presentation. We're getting ready to pivot into our community-based presentations for the afternoon. We appreciate everyone's patience. We're going to try and catch up on our time a little bit just so that we can make sure that we stay on time and we're respectful of your time as well. Today, we're going to be talking about community-initiated care, and it's empowering communities to make change. And just to give you a little bit of background in that story, a year ago, I was at a presentation with I can't even remember where it was, but we were talking about similar aspects of community-based care. So basically saying that institutions, community communities at large, individuals, that we were overburdened and overwhelmed with not having enough clinical providers to address some of the things that we were talking about. One of those things was mental health. And I came across a wonderful person with the Wellbeing Trust that was saying the same thing I was, but more so in the mental health space. And I was talking about maternal mental health. And so I want to just bring back, I think one of the things that we tend to neglect in the community-based space, which is that community-initiated care is really not dependent upon a licensed professional providing the care, but it engages communities in health promotion, prevention, and low-intensity interventions that are delivered by non-specialized but trained lay workers. So the reason why it was so important today to get on the Zoom and to have DMAS and BDH really talk about the landscape of community doulas is because this integration is very similar in that space. And really what we're looking at is when we initiate community care, we empower individuals to learn how to respond to community-based issues such as maternal health, maternal mental health, and substance use, and to take a helpful action at the moment in real time. And the goal is really that we use collective integrated strategies that help build resiliency in communities and offer training, support, and education, which focuses on skill development, caring connections, and also digital supports like telehealth supports. So with that being said, I'm going to bring forward a couple of people that I really feel are very passionate about the maternal health landscape, and to talk about 3 specific issues that are extremely important. One being cardiomyopathy, one being preeclampsia, chronic hypertension, and the other being maternal mental health, and how the intersection of all of these things utilizing community-initiated care can also help to change outcomes. So with that being said, I am going to turn this over to 2 of my friends over with the Institute of Public Health Innovation and a community-based organization that really are focused on cardiomyopathy. One being Valerie McAllister, and she is an author and entrepreneur and the co-owner of Generational Words LLC and Eyes of Your Heart Entertainment, where she co-owns with her 2 daughters, Kaya and Talia. Her family and herself are expression artists, and their mission is to support positive expression as a vehicle to uplift, promote, and encourage and motivate people to be their most creative self. She is an author of a couple of different books, The Book Club, Carol's Return, The Book Club 2, and she's co-wrote her first anthology entitled Make Pain Pay. And she actually is one of the directors of the movie that we are actually going to be showing to you today. Also, I want to introduce Dr. Myaja Gilliam L., and she's a 3-time best-selling author, international speaker, and advocate against domestic violence and childhood molestation. She's the co-pastor of Transitional Minds International Ministry, executive producer of the upcoming short film that we're going to show, Miracles of Life. Dr. Gilliam L. shares her testimony of how she survived domestic violence and childhood molestation, and how she was given a second chance at life after having her heart stopped for over 10 minutes in February of 2012 due to peripartum cardiomyopathy. Dr. Gilliam L. teaches the importance of changing your thoughts and the impact it has on changing your life. So with that being said, I'm going to turn it over to Valerie and Dr. Gilliam L. And when you all are ready, I'll be ready to play this short film.
Thank you so much, Stephanie Spencer. We appreciate it. We want to thank VNPC and the Summit organizations for allowing us to show our film in this space. I have really enjoyed this presentation because one of the things that you talk about is community health workers, and at the Institute of Public Health Innovation, where I wear my second hat, I am really leading efforts for community health workers within Virginia under a program that we call SHWs for a Healthy Virginia. regarding this particular film that you're going to see, just a little background. In 2011, my daughter, my youngest daughter, gave birth to her first child. And after she gave birth, she started experiencing, she was swelling up a lot, and she kept saying that when she laid down, she felt like she was drowning. And I thought, okay, this is part of, pregnancy. You just had a baby. I would lift her head up on pillows and tell her it was going to be fine. And then one night she couldn't breathe. And so we took her to the emergency room, and the doctor said, oh, she has cardiomyopathy. And I had never heard of cardiomyopathy before. I didn't know what I was supposed to do about it. I did a little Google search, and I saw that it disproportionately impacted women of color, and a lot of them lost their lives. So I was in panic mode trying to figure out what to do. Years later, they told her not to have another child. That's all they said was don't have another child within the first year. But 5 years later, she did have another child, and through that began to hemorrhage. So my ignorance about cardiomyopathy and not knowing during pregnancy, because we didn't hear anything about this, caused me to do more research. A couple years back, I met Maisha Gilliam L., who told a powerful story about how her heart had stopped for several minutes as a result of cardiomyopathy. And so it was just really sort of everything coming together that we were able to put this film together that speaks to a lot of things that folks have talked about today, including strengthening community-based partnerships and honoring cultural traditions. So I'm going to stop there, give Maisha an opportunity to introduce herself, and hope that you enjoy our short film.
Thank you so much, Valerie, and thank you all for having us. It is an honor to be here. I'm CEO and founder also of PPCM Healthy Hearts Incorporated, which I just started, and it was formulated to bring awareness to peri and postpartum cardiomyopathy, which, as Valerie stated, I survived in 2012. As you know, in the African-American community, we are very spiritually based. So it is important that it's addressed during patient interaction and care, as well as allowing the patient to be heard. That is one of the things that I had an issue with in 2012. The expectation of being strong as an African-American woman is damaging in many ways, one of which is contributing to negative health outcomes due to not advocating for ourselves. During the postpartum period, African-American women are 3 to 4 times more likely, as you know, to die. And that's not just from cardiac death. My goal through this film is that we assist in educating various communities on the disparities we face as African-American women, and to decrease the mortality rate among African-American women due to peri and postpartum cardiomyopathy. To say the least, this is something that I am very passionate about. So thank you guys again, and enjoy our film.
Thank you so much. And I'm going to go ahead and press play, and hopefully we'll have a little time after for questions. If not, we'll save them to the end.
It's a family here. My husband's in the waiting room. He's in our Praise the Lord, everybody. Praise the Lord, everybody. Come on, stand to your feet. Come on, let's give the Lord glory. Let's give him praise and honor. Hallelujah, for he is worthy to be praised. He is worthy to be worshiped. Hallelujah, for this is the day that the Lord has made, and we shall rejoice. Can anybody rejoice with us today? Hallelujah. Today, amen. A prophet in the house. Hallelujah. Prophet Blandon, hallelujah, he's going to bring forth a message for you today. Hear ye, Prophet Blandon, hallelujah. Amen, 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 hallelujah. Hallelujah. The presence said to your sister, God is speaking to you. Your son will be called Isaiah. For you are carrying a prophet that will do great works for the Lord. But a great test is coming. The enemy means to take your life. But God says, be of great courage and of faith. For faith will sustain you. Hallelujah, God. God, bless the Lord as he blesses the word of God. God. Bless you, beloved. See you again. See you again. Amen. Bless you. Amen. Bless you, beloved. God bless you, beloved. See you again. Amen. Right. Amen. All right. I understand that. Yo, the killer males.
I'm hungry. I can't wait for dinner.
Oh. Wow. Apostle, man, hey, you sure preached a mighty powerful message today. Oh, bless you, Gilla Mills.
I know that sermon really stirred my spirit today.
Yeah, the Holy Spirit was truly up in this place today.
Yes.
Amen. Yo, but listen, there's something big is about to happen in concerning you guys. So y'all pay attention to what the Lord is up to. I believe a powerful miracle is about to take place concerning you guys. Amen. So we love you guys. We're gonna be praying for you and the baby. Hallelujah. And we love you, man. Yes. Yes, sir. Thank you. We love you guys too. All right. Amen. So bless you. Shalom. Amen.
Hey, it's time for y'all to go ahead upstairs so you can get ready for school tomorrow and go to bed. I don't want to go to bed. I'm not tired. Me neither.
Hey, look, you may not be tired, but it sure is your bedtime. You heard what your mother said. Good night.
I can't wait till the baby gets here.
So, Mimi, your doctor's appointment is this week, right?
Yeah, it's on Friday.
So how you been feeling?
Okay, I guess. Other than these swollen feet. You know, I never had that before.
Well, since you are going to a high-risk clinic, I believe you're going to be in good hands. There shouldn't be anything to worry about, right?
I guess not. You know, they're trained in these high-risk pregnancies.
You're going to be okay. He's a good doctor. I'm going to go upstairs and finish getting the children ready for school. Get them in bed. But remember, don't worry. How if you need me?
Okay. Good night. Sister Lori, can I talk to you? Sure, precious. Come sit with me in the car. I know this is gonna sound strange, Sister Lori, but please don't think I'm crazy. I keep having these strange dreams. I see myself in a hospital room hovering above myself. My husband is there, he's crying, he's praying. I have oxygen, I have tubes everywhere, and I don't seem to know what's happening. I keep asking, where is my baby? But nobody can hear me. Even the visiting prophet that came yesterday to the service told me, he warned me that something was gonna happen, but he just didn't tell me what. When I took it to the Lord in prayer last night, he showed me that something was gonna happen. It was just so blurry. But he told me to keep the faith, to remain trusting in him. He promised me that everything was gonna be all right. I had the same dream. I dreamed about a black bassinet and I couldn't see the child inside, but I had a bad feeling about it. I feel so bad. I have not told my husband anything yet. I rebuke you, Satan, in the name of Jesus. You will not have that child. That child will live and not die.
Good morning, Mrs. Gilliam L.
Good morning.
How are you and your baby doing today?
We're doing okay.
That's good. Woo, you're getting big.
I know, right?
Could you sign in right here for me?
Sure. How you been doing?
I've been good, and you?
I've been okay.
Do you have any concerns of any sort?
No, I'll take it up with the doctor when we get in the vet.
All right, looks good. The doctor will be with you shortly.
Thank you.
You're welcome.
Maisha Gilliam L. Right this way. So I see from your exam that both you and your son are doing just fine.
I don't think so.
What's wrong?
Something is not right. I've been feeling dizzy. I keep having a strange feeling that something is wrong. My feet are swollen.
You know, Miss Gilliam L., swelling is typically normal, especially during the last trimester of pregnancy. All your tests have come back fine.
That may be so, but I'm telling you, something's not right.
You know, sometimes us in the medical field are our own worst patients. Calm down. I assure you, if something was wrong with either you or your baby, we would have found it. Try resting, propping your feet up while sitting down, or even soaking them in Epsom salt. But if you notice anything strange going on, such as blood in your urine, come straight to labor and delivery.
I hear what you're saying. I understand, but I'm telling you, you really need to do some retests. And right now, you really need to recheck my blood pressure.
Okay, Miss Gilliam L. Miss Gilliam, your blood pressure is elevated. I'm gonna go ahead and send you over to labor delivery, okay? Fine. Congratulations, Miss Gilliam. It's a girl.
Good morning, Mary.
Good morning.
Hey, look, I know you're still feeling a little out of it, so I already got the kids up and ready for school. I'm gonna drop them off at the bus stop and probably run a few errands afterwards, okay?
Okay.
You okay?
Yeah, I'm good. Just a little bit of indigestion.
Okay. Well, I won't be gone long. I'll see you soon.
Okay.
God, please, don't let me die like this. If I can just get to the door, I know that somebody can help me. All I have to do is make it across the street. They'll help me. Lord, please help me to make it to the other side.
Oh my God, Raisha, what in the world? What happened to you?
I can't breathe.
Honey, call 911. Maisha's in trouble.
Baby, go get the baby.
Is the baby in the house? Oh my God.
Come on, Maisha, stay with us.
In the hell is an ambulance?
Someone call an ambulance? Someone's not doing well over here?
What took y'all so long? She can't breathe. Please help her.
Is there any family members around so we can find out what's going on with her?
Her husband left early. I don't know where he went. Please, just help her.
Can you please tell me the patient's name?
Her name is Maisha.
Maisha, can you please tell us what's going on with you?
I can't breathe.
Okay, you know what? Let's take it to the ambulance. Let's go.
Are y'all not even gonna put her on the gurney? Her husband's in the waiting room.
Who's in her?
Are we gonna call a doctor?
Yeah. All right. Okay. Yeah. Go ahead and call it. We've lost her. We've lost her. Let's go. We've done everything. We've done everything. And she's not with us. We've done everything. We did everything, and she fought over it. Yeah. Go be with her.
have a heartbeat. I don't want to get your hopes up. It is very touch and go. We will let you know when you can come back and see her. Oh my goodness. Oh my goodness. Oh my God, we just thank you for your healing power. We know, Lord God, that you are a healer. Hallelujah. Come on, let's spread this prayer shawl over her. Amen. Hallelujah. Glory be to God. We trust you, Lord. Oh, hallelujah. We bless your name. Well, let's pray. Heavenly Father, we just bless your name and we thank you, oh God. We thank you, Lord God, that you are a healer. We thank you, Lord God, that you are a miracle worker. Lord God, we trust the process, Lord God. Lord God, although it's scary, although, Lord God, we are afraid, although we may be hurting, although, Lord God, we don't know the full outcome, Lord, we know who you are. We know what you stand for. We know the power, Lord God, that you work, Father. And Lord God, we trust you, Lord God. You shall trust, Lord God, that you will touch that body to the body. From the top of our head to the sole of her feet. We know, Lord God, that you, Lord God, can pull her out of this, Lord God. Oh my goodness. I saw it. Oh my God. Ever, she's opening her eyes. Hallelujah. Look at God. Look what God doing. Oh my goodness. Look. Hallelujah. Miracles still happen. Yes. Yes. Glory be to God. God was holding my hand. I guess you never know what life will bring. Although we face many trials and obstacles, I have hope in the miracle working power of God, knowing that there is nothing that can overtake us when we trust in Him. Not even death. God is going to show that He is still in the business of miracles. All right. When my time is up, will I measure up? When they talk about me, will they say that I was special? Will they say that I made a change, that I was helpful? Will they say that I was wrong, never right to sing a song? Whatever they say, I
So thank you so much, Maisha and Valerie, for taking the opportunity to share your story and how this just impacted your family, your community, and what information you wish to share with communities. And so we do have a few minutes before it's time for our next presenter. And obviously at the end, we will give opportunity for people to ask questions. So really, I think right now, what I'd like to do is to try and have you share with the audience today, what are some of the things that you would have wished to have either seen, or at least what you wish to gain, for people to gain out of seeing your film today?
Wow, so for me, just knowledge. It was so critical that we were only able to really give you a vision of 30 minutes, but so much happened to Maisha in that time. You know, the ambulance took forever to get there to her. She couldn't breathe. She wasn't put on oxygen. She knew that something was wrong, but people didn't really listen to her. And the same thing happened to my daughter. And when she had her last child, I was all the way in Boston, and she just hemorrhaged so much that she had to have 3 blood transfusions. And oftentimes, you know, when you're vulnerable and you're sick, it's hard to talk about what's going on with you. And if you don't have an advocate there to say, hey, let's look at something, you know, if we had information before, like I said, I'd never heard of cardiomyopathy before. I just want women to be able to be aware, especially when women of color, to ask the questions. And also, it was so important to have that spiritual foundation for both myself and for Maisha. So if you take anything away, I'd say, you know, really listen to women and let's provide information. We need more research about it. I haven't seen a lot of research about it. If there's a way to do a test prior to, you know, while you're pregnant, I'd love for that to be, you know, part of the process as well.
Thank you, Valerie. Maisha.
Yes, for myself, I would like for people to take away from this film, just listening to the patient and allowing family members to learn how to advocate for you. I had my husband there advocating for me. I did have the benefit of having spiritual people in my life that would advocate for me as well. So just having that component of having your loved ones to actually be able to advocate for you, and also to spread the awareness of different tests that may be able to be done through my research, looking into BNP testing being done while you're pregnant, you know, right before you deliver, and maybe postpartum, that can show signs of this, you know, you having damage to your heart. Because this happened 2 days after I had my baby. So, you know, it just really caught everybody off guard. And I'm a nurse, and I didn't learn this in nursing school about cardiomyopathy. I learned about preeclampsia and all of those things, but not specifically cardiomyopathy. So I just want to bring awareness and be able to educate our community and stop these deaths from happening.
Yeah. Thank you again, because I know that it's such a heart-wrenching story, and to go back to it, it has a positive ending, but also too was just a lot on your family and your community. And so we thank you for just trusting us with sharing your story and uplifting your message. And if anything, that I know when Valerie and I sat and talked about this, and it was us connecting in this space to be able to share, the one thing we really wanted to come out of this with is also letting people know that sometimes presentation isn't going to show in the numbers. And that, Maisha, was your story, in that you were telling people that you had something going on and you knew it was going on over a period of time, but it couldn't be reproduced clinically. So when we say to listen to women, listen to Black women, trust them, we also have to take that pause. And thankfully, in your instance, there was a provider that took a pause and was willing to do more to get you to the next level, to get the support that you needed, so that not only you had a healthy baby, but a healthy outcome. So again, thank you so much. We really appreciate both of you. We hope that you're able to stay on at the end. If there are any questions, please put those in the chat for Maisha and Valerie as well. So with that being said, we're going to go ahead and move on. We have Eleni on. Wonderful. So Eleni Sigas, and I apologize if I pronounce your name incorrectly at the end. She is the executive director of the Preeclampsia Foundation, the North American Patient Advocacy Organization for Hypertensive Disorders of Pregnancy. She leads the organization in providing patient education and support, advancing innovation in clinical practices, catalyzing science, and building partnerships to improve pregnancy outcomes. She serves on numerous advisory councils and task forces, and is frequently engaged as an expert representing the consumer perspective on preeclampsia at the national and international meetings for academia, industry, and professional societies. She is the principal investigator for the Preeclampsia Registry, an active research database of over 7,500 participants contributing to numerous research studies. She survived severe preeclampsia twice, though her firstborn daughter did not. Thank you so much for joining us and presenting your story and how this has led you into your work at the Preeclampsia Foundation.
Thank you, Stephanie, and all the amazing people on this call. I have to say, I'm watching that story, and Maisha's story right up until the end could very well have been mine and so many other preeclampsia mom stories. And I'm watching it and realizing that my talk is really almost incidental to what you learned by listening to a real patient experience, because every one of my dry and boring slides are brought to fruition in the lived experience. And so I just really want to thank Maisha for sharing that. Not coincidentally, preeclampsia and PPCM, peripartum cardiomyopathy, are very much linked. There's a much higher prevalence of PPCM amongst preeclampsia survivors. So I would just caution all those watching that everything I'm about to share with you around preeclampsia could very well apply to the PPCM community as well. Let's get my screen shared here. Wow, I gotta say, I mean, thank you for giving me a few minutes to wipe my eyes, because that was just really powerful. You guys can see my screen, I'm assuming.
Yes, ma'am.
Yes. All righty. Okay, so I am going to be focusing on preeclampsia and the broader category of hypertensive disorders of pregnancy. And through that lens, really, I know this is somewhat of a repeat for this audience, but I'm going to touch a little bit for any case anybody's watching that doesn't know what preeclampsia is, mainly because some of this basic biology around it really very much links to what we need to know and understand and convey to our moms about preeclampsia, because it is easy to sort of overly generalize or simplify it to high blood pressure in pregnancy, and it is so much more than that. We know that the placenta, which of course is the organ that is created in pregnancy for that pregnancy, is the organ that links mom and baby. And in fact, many people consider preeclampsia a placental disorder of pregnancy, because there are toxins, if you will, that are a number of biochemical factors that are out of balance early in pregnancy, and that start basically a cascade of events leading to a less than stellar placenta. And so the degree to which this dysfunctional placenta affects mom and baby varies, but it is the bridge between these two humans, and therefore there's a lot that can affect both mom and baby. So when we talk about high blood pressure, it is one of the signals that something is going wrong, and it is one of the outcomes of preeclampsia. But there are others. There is organ dysfunction that includes the kidneys and liver and lungs and brain, and we know that it can also lead to death and serious morbidities in mom, can also lead to long-term cardiovascular disease and a much higher risk for that. And in the baby, you can have growth restriction, you can have preterm birth, death of the baby, as I unfortunately had to experience, and as well as long-term cardiovascular risk in the offspring as well.
Can I interrupt just a second? Can you go to presenter mode? We're seeing both slides.
Oh, absolutely. Let's see.
Sorry about
Why
that.
is that? Yeah, no, that shouldn't be happening. Let's fix that. Thank you for interrupting for that.
Perfect. That's good.
Does that work?
That works. Thank you.
Great. Thank you. Thanks for interrupting. So a couple of just bullet points to sort of reground us in some of the basics of preeclampsia. We know that it is preeclampsia is one of the hypertensive disorders of pregnancy. It can present either with or without severe features. There is also the advanced stage of it, which results in seizures, called eclampsia. HELP syndrome is a variant, a very severe variant, although much more rare. And then you can also have gestational hypertension, which is just the blood pressure presenting just in pregnancy. It typically occurs after 20 weeks of pregnancy and up to 6 weeks postpartum. It can happen to any woman in any pregnancy. And I emphasize that because there are risk factors. We're going to talk about those. But even if you have none of the risk factors, it can happen. We know it's happening in about 2 to 8% of pregnancies, and even up to 10% when you include just all versions of hypertension. And unfortunately, the incidence of preeclampsia is rising in the US. And we know that African American and Native American women are 3 times more likely to die from preeclampsia. This is a chart that unpacks the race and ethnicity piece a little bit more. And I use it really to underscore the fact that everything I'm going to talk about really should get even in a heightened level of attention and sensitivity for our Black and Native American moms, because they're more likely to develop it and have increased rates of stroke, renal failure, pulmonary edema, and heart failure. One of the things that's potentially complicated it is that we have had evolving definitions and treatment recommendations over the past many years. I had really the honor of serving on the task force of ACOG on hypertension and pregnancy back in 2013. And since then, there have been a number of committee opinions and practice bulletins that have come out, either even further refining what we know and understand and should be practicing around this issue. I think the main point that I would say is if you learned about preeclampsia more than 5 years ago, you may very well be working with outdated information. So in my talk today, I'm really going to focus on sort of this cascade of opportunities for communities to pay more attention and improve patient outcomes. The first one being a focus on signs and symptoms education. We heard this, Maisha even just talked about this with her PPCM diagnosis, and the importance of empowering patients with information. I mean, we've all heard the expression knowledge is power, and I can't emphasize that more than I do with preeclampsia because of what we know and understand about the diagnosis of preeclampsia. So it needs a blood pressure reading of 140/90, 2 readings 4 hours apart, plus protein in the urine. But now the definition, of course, has adjusted where you don't have to have protein in the urine. You could have an association or a new onset of thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, and new headache that's unresponsive to over-the-counter treatment or visual disturbances. And I put in parentheses all the organs that those medical or biological features really affect, and that those in combination are what we refer to as the severe features of preeclampsia. And why those matter is because they directly correlate to the symptoms that we should be educating mom and her partner and her loved ones about, because she may not be the first one to recognize these symptoms in herself. So things like seeing spots or auras or having upper right quadrant pain, which by the way, often for moms doesn't conveniently manifest right in the upper right quadrant. Sometimes it refers to neck pain or back pain, having a sudden weight gain of 5 or more pounds in a week, swelling in the upper extremities, not so much the fat ankle syndrome that we all have in pregnancy, but in the facial region or in the hands. And then the last one that will barely ever show up in a pregnancy book or on a website, but this idea of just not feeling right and having an unexplained sense of anxiety or impending doom. I can't emphasize enough the 6th sense that we as moms have, and often others will squelch it in us, or we will even deny that 6th sense. It's super important to listen to moms, as we've heard over and over again. So these signs and symptoms are what we advocate for at the Preeclampsia Foundation to really be taught at every prenatal appointment. And we have a variety of educational tools to support that strategy, including tear pads to give out to mom during prenatal visits and postpartum and at discharge, clinic posters. There are additional brochures. There's a video that can be played using a lot of the patient education channels that are used, and direct mom to our website and to our YouTube channels. Excuse me, at this point, we've distributed over 2.5 million patient education materials, and they're often even integrated into EMR systems, which we make that available through digital licensing. So the other thing is not just to give this material out, but to use effective patient communications. And some of the things that have been proven over and over again to work, of course, using plain language, not medical language, but also using methods like chunk and check, where you take a lot of information and organize it into 2 or 3 components. Using teach back. So after you've communicated what are the symptoms she should look for, teach back would be saying things like, tell me what some symptoms are that you might experience that would cause you to call us. And using teach back is far more effective than just asking a question like, do you understand what I just taught you? Because most of us are going to say yes. We're too embarrassed to admit we don't understand something. So teach back gives you an opportunity to correct if she doesn't have something quite right, and to reinforce in her own mind what it is that she needs to know. The other thing, of course, is repeating messages. And this is why we say it needs to be done during every prenatal visit. We need to hear messages over and over and over again to be remembered. We're also different kinds of learners. Some people are visual learners. Some people learn by listening. Some people need to watch a video or see something on paper. And so using multiple teaching strategies is an important strategy to ensure she understands and is going to remember this material. So a second thing that is often overlooked, but has been shown over and over again in maternal mortality review committees, is the taking of accurate and timely blood pressure measurement. And that means proper positioning is essential. And I can't tell you the number of times that a nurse or other healthcare aide will take a blood pressure reading, not like it, which means it's too high, and assume that the problem is that the patient needs to be in a better position. If you've got her positioned in the proper positioning, then believe a bad reading and pay attention to it is the important message there. The other thing that we've done as a result of the importance of blood pressure as a very important signal to preeclampsia is started distributing the cuff kit. This is a blood pressure, a validated in pregnancy blood pressure device that is accompanied by materials that we've specifically put together to ensure that mom knows how to take her blood pressure accurately at home, log the results, and then share them with her healthcare provider. Throughout my presentation, you're going to see these QR codes. You can just point your telephone's camera at the QR code, and it's going to pull up a web page of additional information that you might find helpful. One of the things that we emphasize with the cuff kit is the opportunity to give this at discharge, even if she hasn't had it throughout her prenatal time period, which we highly encourage. Giving it to her at discharge for postpartum surveillance, as we just heard in that video, is super important. We often find hospitals across the country now are putting a rubber bracelet, and you can see a picture of it kind of draped over the blood pressure device in the picture, that says still at risk. And that means it's a reminder for mom and any healthcare providers that she may be seeing in the next several weeks after delivery that she is still at risk because of her pregnancy. So there's more information, of course, about the cuff kit program. Now, just a couple of data points. We have now distributed over 12,000 of these cuff kits across the country. And the data that I'm just going to show you a couple of quick snapshots on is from almost 3,000 patients who have received the cuff kits. They're going primarily, we ask providers to prioritize those at highest risk for some kind of hypertensive disorder. And so they've primarily gone to Black women, second white women, Hispanics, Native Americans, and then there's a whole host of other risk factors that we've asked them to prioritize, including things like having had a previous history of preeclampsia or coming into that pregnancy with chronic hypertension, all of which are also risk factors. Now, the exciting thing about this study that we've done is that we also wanted to know what has been the provider's perception of how that cuff kit has influenced their care of their patients. And what we're finding is that 47%, the blue part of the pie, is 47% have said that it significantly influenced their patient care. The orange part of the pie, 36% said it somewhat influenced their patient care, and only a very small portion either didn't answer the question, and an even smaller portion felt like it didn't influence their care. Now, this was at a point in time during collecting this data, because this process, this whole project is actually still ongoing, and we're continuing to get requests for the cuff kit on a daily basis. So let's move on very briefly. I just want to touch on the implementing of the hypertension safety bundle. Again, I don't need to tell this audience how important it is to be following protocols, to have checklists, to have data metrics that you're consistently collecting. But there is a hypertension patient safety bundle that has been adopted now by almost every state in the union and has been shown to improve outcomes. The goals of this bundle include have to date included the 4 R's. The 5th R is getting ready to be added, which has to do with respectful care. But the 4 R's have been improving readiness to severe hypertension in pregnancy by identifying standard protocols in every unit, improving recognition by prompt response to early maternal warning signs, improving response by facility-wide standards for management and treatment, and improving reporting and systems learning by establishing a culture of huddles and debriefs. And of course, my 2 cents worth is make sure that that debrief process includes talking to the mom and or her family about the experience. So in this bundle, there are a lot of elements to it, but I've sort of, I'm not the only one who's done this, kind of up-leveled the 5 most important things that are present in these, in the protocols. One is recognizing symptoms and diagnosing as quickly as possible. And that has a 2-part component, because the providers need to really listen to the patient, take accurate blood pressure, and do the blood work, the labs, to speed up time to diagnosis. And patients need to know what to recognize and to report, because they may not be in a healthcare setting. They may need to get themselves to a healthcare setting. Controlling severe range blood pressures within 1 hour with antihypertensive medications. And I've put that in as obvious as that should be, because magnesium sulfate is not an antihypertensive. It is to prevent seizures. And so that's the 3rd item. The 4th item is, of course, the timing of the delivery. And there's a lot of nuance associated with delivering immediately versus expectant management versus outpatient monitoring, all of which are dependent on gestational age and maternal and fetal conditions. And then the 5th area of focus for this bundle is postpartum surveillance and blood pressure follow-up. That means mom is going home with discharge instructions that include all the maternal warning signs and an appointment to have her blood pressure checked within 4 to 7 days after delivery. I've posted on the right-hand side some information that we have on our website that just explains some of the preeclampsia tests that mom may experience to help her understand what those are, what they mean. The other thing that we've done that may be useful is we've taken the entire bundle and reimagined it through the lens of the patient. And we call this Preeclampsia in the Hospital, the Patient Bill of Rights. And we explain what a bundle is, and we explain what I can expect from hospital staff who are trained and utilizing the severe hypertension bundle. Because some things are invisible to us and they should be happening in the background, but a lot of things are visible to us, and we can be part of that solution, and we certainly can witness and be an advocate for our own care when we understand what we should expect. So again, you can scan this document with that QR code, but I wanted to offer that as an additional resource. So the next area that we can do something about improving patient outcomes is to address postpartum health. For so long, we have believed that delivery is the cure for preeclampsia. It is not. It is a treatment, and it is, to this date, probably our best treatment to start to arrest the process that's happening in preeclampsia. It starts to resolve the process, but it is not the cure. And in fact, we need even more diligence and more observation of mom postpartum. There may be residual hypertension that has not immediately reversed itself after delivery, or there may be de novo or new onset hypertension and even organ dysfunction. There is some evidence that delayed onset postpartum preeclampsia is associated with that increased risk of progression to chronic hypertension. So that means that those who have postpartum preeclampsia may in fact be the moms who go on to develop chronic hypertension. Otherwise, the risk factors are the same. And the most important thing is we're sending mom home, hopefully with baby, and the focus is often only on the baby at that point. And we really do need to pay attention to mom, as that video so powerfully demonstrated to us. Some of the data that supports this is just one of many studies that came out of California that found that hypertensive disorders of pregnancy, 63% of the moms who died within 6 days of delivery. 28% died from days 7 to 42. This postpartum period is a very vulnerable time for mom. And unfortunately, we have found that a lot of our preventable maternal deaths are happening in this postpartum period. Beyond the postpartum period, one of the things that we've learned now is that pregnancy is really being seen now as a window into a woman's future health. Gestational diabetes often going on to herald type 1 diabetes, or the piece that I'm focusing on here is that preeclampsia in pregnancy often heralds a higher risk for cardiovascular disease later in life. So much so that 2 out of 3 of us who had preeclampsia are going to die from some form of heart disease. That's 2.5 million women in the US today walking around who had preeclampsia who are going to die from heart disease. So it is important that we recognize this risk and not consider it a death sentence, but in fact, an opportunity to do something about that risk. And so as a result of that, amongst the many, many tools that we have and information articles that we have that we push out on our website and via social media, we developed this piece with the International Society for the Study of Hypertension and Pregnancy last year for Preeclampsia Awareness Month. By the way, we're in the middle of Preeclampsia Awareness Month right now. May is that month. But this Beyond Pregnancy tool is an opportunity to empower mom to take charge of her health for that long-term cardiovascular risk. And I would say it's empowering for 2 reasons. One is it's a way for her to document some of the basic things that happened in her pregnancy that she should know and understand and remember and take forward to any doctor's appointments that she has in the future. Beyond that, the tool itself can serve as a conversation starter with her healthcare provider to help her understand her pregnancy history and its implications, and set her on a path now to start taking specific actions that can modify her cardiovascular risk. The other piece that is often underappreciated in the effects of having had preeclampsia is the emotional recovery. We often feel guilty. We feel like failures. We feel like the one thing our body was designed to do, bring life into this world, has left us feeling guilty and just utterly angry, oftentimes depressed. Sometimes it can even fracture our families. It has been known to cause much higher rates of post-traumatic stress disorder, particularly after severe adverse pregnancy outcomes. And so this is just a glimpse at this issue. My talk is too short today to go into this component in too much detail, but I've included a few citations on this page that I'd encourage you to track. But the takeaway message for you as healthcare providers is, 1, be aware of it. Help mom be aware that she may in fact have some different kinds of emotional after effects from her adverse pregnancy outcome, and that there are resources. And I've included a URL on our website where we offer some birth trauma resources, but I'd really encourage you to identify some local resources, whether they be perinatal grief counselors or support groups, where she can go and get some additional information and support. So the next thing I want to talk about is acting upon risk factors. One of the things that is often overlooked is the fact that there are a set of known risk factors for those of us who are at higher risk or at least moderate risk for developing preeclampsia. And of course, this has been largely documented in all the work that's now been done around aspirin prophylaxis. Who should be getting aspirin in the first trimester of pregnancy? And it's all those folks who are at high risk. And that's in that first column that you see there: history of preeclampsia, of course, chronic hypertension, type 1 or 2 diabetes, any kind of kidney disease, and a whole host of autoimmune disorders. Those folks absolutely should be getting aspirin in the first trimester of pregnancy. But there's also a bunch of us who have moderate risk factors. And if we have 2 or more of those, those are also patients who should be considered for low dose aspirin. And of course, we now also know, because of the CHAPS trial that I have not even added to the slide deck because it only came out a couple weeks ago, but this idea that if you come into pregnancy with chronic hypertension or you develop hypertension early in pregnancy, it absolutely needs to be controlled, not wait for it to get to those severe levels of 160/110 before controlling for it. And we do have some RAC cards that encourage people to ask about aspirin if they have some of these risk factors, to talk to their healthcare provider about taking what we're terming prenatal aspirin, because we've also understood that sometimes there are barriers. You know, we've been told as moms to keep our bodies clean throughout pregnancy. And the whole idea of taking aspirin is something we've traditionally been told don't do, that it could harm our babies. And now we're being told we should take it. So the conversation does need to change. And one of the things that may need to change is starting to call it prenatal aspirin. So the last thing I want to talk about, and then I'm going to wrap up here real quickly, is this idea of empowering patient voices. And you heard this over and over again from the stories that you heard. And it's that idea of listening to mom. Well, listening to mom absolutely is incumbent upon healthcare providers to do that listening. But it's also an opportunity to teach patients how to effectively communicate their concerns. And there are some really cool acronyms that we've used that we're starting to use more and more in our teaching about how to be effectively heard. And one of them is the acronym BRAIN, which stands for benefits, risks, alternatives, intuition, and nothing. And it's a formula for using your brain to make informed pregnancy healthcare choices, where you're asking, when you're being told something by a healthcare provider, ask, what are the benefits of this? What are the risks? What are my alternatives? And then listening to your own gut. What does my intuition tell me about this? And asking even, well, what would happen if I did nothing? And so that BRAIN acronym guides our discussion, our thinking, our communicating, because we're not effective communicators as patients. Oftentimes we are overwhelmed. We are in a disempowered state because there's a real power differential between medical professionals and patients. And we need some guiding principles, and this BRAIN acronym can help. The other one, which I love, is teaching our patients to cuss. And that's being able to say the words, I'm concerned, I'm uncomfortable, or I don't feel safe. Those are trigger words that nurses are often taught when they also are often in a power differential and feel like they're not being heard. And we say, got it. Guess what? Patients also often don't feel heard. Let's teach patients how to cuss also. And then the last thing often is just asking for your concerns to be recorded in your medical record if you feel like the healthcare provider is not taking you seriously. The CDC has come out with a wonderful campaign, which we helped them develop, called the Hear Her campaign. And there is just a load of information on their website. I'd encourage you to go check it out at cdc.gov/hearher. There are posters that you can put up in your various facilities. There are videos that you can watch and share. And there is a beautiful urgent maternal warning signs poster that's available in many, many languages, and not only includes the critical symptoms of preeclampsia that mom needs to be aware of, but all of those urgent maternal warning signs that we should be educated about in the certainly during the prenatal period, but also in the postpartum period. We've also developed a landing page specifically for nurses and one specifically for doulas, because as we've heard earlier in this session, doulas are becoming a more and more valuable asset to addressing excuse me, adverse pregnancy outcomes and disparities that we're seeing. So we have dedicated landing pages at preeclampsia.org/nurses and /doula. And I'd encourage you to go check out both of those landing pages for ways that we've tried to make this easier for those very important healthcare providers. So that's sort of the constellation of areas that we think many members of the community can get involved in to help improve patient outcomes. And I'll just close with this slide. It's kind of our comprehensive call to action, if you will, where hospitals as well as outpatient centers need to continue to change, where we really encourage there to be areas of focus to address the preeclampsia disparities that we're seeing in vulnerable populations, excuse me, which often means treating blood pressure correctly and consistently. Do not fall victim to the idea that we are normalizing deviant blood pressure. There is a healthy blood pressure and everybody needs to be treated to that level. Incorporating more telehealth and mHealth to accommodate patient realities and empower them as partners in their healthcare. This really is an opportunity to set women on a lifelong path to understand the importance of their blood pressure and monitoring it for life course events. Addressing mental health and the long-term risks from severe preeclampsia, treating hypertension earlier before it reaches critical levels. Eliminating the deadly Ds. I didn't have a chance to talk about that today, but when we talk about the deadly Ds, that's delay, denial, and dismissal. These are the doom, I would say. It's the deadly Ds of doom, because when we delay, deny, or dismiss, this is when the accidents and the preventable injuries occur. And finally, ensuring that all patients receive and understand information about signs and symptoms of preeclampsia. So I'm going to ask for the poll to be put up. That's really the end of my prepared comments. I'm more than happy to stick around for the Q&A session a little bit later, but I'm just going to ask everybody to take literally 3 seconds to answer this poll about how quickly, if at all, you could use this information.
And real quick, Elena, why they are answering the poll, we do have a question, and it says, can you talk about the differences in dosages for low dose aspirin? Some healthcare providers are saying 81 milligrams and others are saying 162 milligrams. And this individual was unable to find any evidence-based research regarding the 162 versus 81 milligrams for efficacy.
Sure. So, well, the reason you probably can't find literature on the 162 is because it hasn't been tested at 162. It's been tested at 150. I suspect that the reason the 162 was prescribed is because here in this country, low dose aspirin is dosed at 81 milligrams per tablet. And the easiest thing to do is just to say, take 2 tablets. There is evidence that 150 is more effective. The ASPRI trial certainly has shown that some of the details of how we administer low dose aspirin, like mom should be taking it at night. She should be starting it no later than the end of her first trimester. And that 150 milligrams is actually more effective than just the 81. So I suspect that anybody who was prescribed the 162 was done that way because of the way aspirin is dosed here in the US.
Wonderful. Thank you so much, Eleni, for such an informative presentation. We really appreciate the work that Preeclampsia Foundation, your team, and others are doing to help heighten awareness and provide support to clinicians, hospital-based systems, and community at large. We want to encourage hospital systems and community-based providers, doulas, and the like to become involved in this work to understand what drives preeclampsia, how to help people navigate in this space to get to clinical providers. This is why we know that integrated models of care are so important. And I'll keep putting this bug back in your ear about us building that workforce for community doulas, for community health workers, and others who are in this space, because you also need to connect with people in the prenatal period as well as in the postpartum period when we talk about preeclampsia, postpartum preeclampsia, and the like. So hopefully, Eleni, you'll be able to stay to the end, as maybe there'll be some questions that will pop up. But again, thank you so much. We're going to go ahead and pivot to our last presenter today. And her name is Laura Blanke. And she's the Policy and Partnerships Manager with Wellbeing Trust. Prior to joining the Wellbeing Trust team in May of 2020, Laura served as the Public Health Policy Lead in the Texas Department of State Health Services Center for Health Policy and Performance, where her work focused on research and analysis of national and state policy impacting the public health system and providing insight on best practices and service delivery models with the potential to system improvement efforts. Laura has also worked in both Medicaid policy and eligibility divisions within the Texas Health and Human Services Commission, and spent many years advocating for programs and policies that promote children's health through her work with the Texas chapter of the American Academy of Pediatrics. Her background is in public health, and with nearly 15 years of experience in health policy analysis, advocacy, and implementation, Laura is committed to seeking policy solutions to enhance lives, strengthen communities, and transform systems and social structures to better support health needs and improve outcomes. So thank you so much, Laura, for attending and presenting today, and I'll turn the floor over to you.
Well, thank you so much, Stephanie, and thank you for inviting me to be here and including me on this incredible panel. I feel honored and humbled to be alongside such incredible women, and want to extend my gratitude for the work that you all do in lifting up these critically important stories. I think, the video that we all just watched stirs up a lot of emotions for many of us. Stephanie didn't tell me I would have to follow such a tough act, and the power and the beauty that would come from that. But I'm going to do my best to try to provide a little bit of information today. Stephanie gave my background, and in addition to that, just want to let you all know that Wellbeing Trust is a not-for-profit impact philanthropy. We were established by the Providence Hospital System in 2016. And although Providence operates primarily in 7 Western states, our activities at Wellbeing Trust extend across the US, and our goal is really improving the mental, social, and spiritual health of the nation. I am a middle-aged, at least I hope I have another 45 years, white woman with shoulder-length brown hair, and I use she, her pronouns. Next slide, please, Shannon. So I'm thrilled to be here today. I'm going to talk a little bit about a community-based approach to addressing mental health needs. And per Shannon's guidance, just want to let you all know that I have nothing to disclose. In addition to being Preeclampsia Awareness Month, May is also Mental Health Awareness Month. So as Eleni outlined, there are a lot of intersections here that I look forward to talking about as we get to the question answer discussion session a little bit later. I do want to disclose that I am based in the Pacific Northwest, where the rain has everything in full bloom, and my allergies are a little brutal this time of year. So apologies for coughing, sneezing, drinking water so that my voice holds up throughout the presentation. But as we all say these days, don't worry, it's not COVID. So I know there have been great presentations today on perinatal mental health that likely outlined a lot of the data and science around the seriousness of what we're facing. I'm not going to belabor this, but I just wanted to underscore a couple of key points to help orient our discussion. Maternal mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 women. It's about 800,000 women annually in the US. Similar to mental health and substance use needs that the general population experiences, most of these go untreated. And you can see some statistics here that really outline that our specialty mental health workforce is in short supply and oftentimes maldistributed. There are many people who don't have access for a variety of reasons. And when there is access, it's oftentimes onerous to travel to get to an appointment, or more expensive than you would experience with a non-mental health office visit. So as a result, suicide and overdose are the leading causes of death in the first year postpartum. Next slide, please. As with other postpartum outcomes, we know that maternal mental health conditions also disproportionately impact women of color, as well as low-income women. Women living in poverty and women of color are more likely to experience mental health conditions and less likely to get help for a variety of reasons. That includes lack of access to healthcare, including culturally appropriate mental health care. Our current mental health workforce seriously lacks diversity. Approximately 86% of US psychologists are white, 70% of social workers and 88% of counselors are white. Upwards of 90% of psychiatrists are white, and only about 38% of practicing psychiatrists are women. Cultural and racial biases exist across our healthcare system. This extends from training to treatment. There are more barriers to care for low-income women, such as lack of transportation and childcare. And for many, there is a fear that child protective services or immigration agencies will become involved if they seek the care that they need. Next slide, please. As Stephanie mentioned, my background is in public health, and after grad school, I spent 8 years working with the Texas chapter of the American Academy of Pediatrics, working with the state legislature in Texas to promote policy efforts designed to improve the health of children and families. I then worked in the state agency setting where within Medicaid and at the Department of State Health Services, I got to see the other side of implementing the policies that were passed in the legislative setting. And many of the policy solutions that were promoted for improving mental health have been focused on enhancing our current system. This includes efforts like expanding coverage, including for telehealth, improving standards for screening and treatment, care integration into primary care settings, and increasing the workforce. Before I go into the rest of the presentation, I just want to say I deeply believe in our need to address these deficiencies within our system. I have dedicated my career to it and want to underscore that these are all important, absolutely things we should be focusing on. But I think they're not the only things we should be focused on. And as I go through here, I just want to challenge everyone to embrace the possibilities of transformation and changing trajectories for women if we think a little bit more creatively about ways to address perinatal mental health. Next slide, please. So particularly around workforce, how do we get more is often answering the wrong question. A more accurate question sometimes is, how do we do better with what we have? Next slide, please. So I am going to dive into an example. I'm very transparent with regard to my mental health and postpartum struggles, but I don't particularly enjoy public speaking. So this is probably the largest audience I've shared my story with, so bear with me. In October of 2014, I gave birth to the precious little child you see here. After struggling with infertility issues for many years, my path to pregnancy was long and difficult, but my pregnancy itself was incredibly healthy. I think it's also important to mention that I have dealt with a general anxiety disorder since my early 20s, results in periodic panic attacks. I have learned to manage that fairly well, and I didn't have any anxiety episodes throughout my entire pregnancy. At 10 days past my due date, I was induced and I ended up having a C-section after 17 hours of labor. About a week postpartum and only having been home from the hospital for a couple of days, I became very sick. My physical pain was so intense and unusual that I didn't recognize what was happening as a panic attack. And I was sure I had ruptured my C-section stitches and was bleeding internally. So I went to the hospital. They confirmed I didn't have physical complications from the C-section. I went home, and after a few days, I realized I was in a debilitating panic attack that I could not get out of. I couldn't sleep. My heart was constantly racing. I had trouble breathing. Getting out of bed was difficult. There were probably 2 hours a day where I felt semi-functional around 4 p.m. And that was the only time of day I could eat anything. I was breastfeeding and I didn't want to take the alprazolam that typically treats my anxiety. I saw my OBGYN and she said, take the medicine. Unfortunately, at doses 4 times what I normally would use, it didn't touch what I was dealing with. She prescribed an SSRI and that made things worse. I was losing weight rapidly, and several weeks postpartum, my weight dropped lower than my pre-pregnancy weight levels. I called several psychologists specializing in maternal depression, but none of them took my insurance or any insurance. However, I was fortunate enough to have the resources to pay out of pocket, and I would have gladly done so, but they didn't have any appointments for new patients for 6 to 8 weeks, and I didn't think I had that long. The day after I watched all of the color drain from my husband's face when I told him that he and my daughter might be better off without me, we reached out to my insurance company for help finding care. With a new baby at home, I was terrified of being institutionalized. And of course, they didn't want me to do that either. It's expensive. So they were able to locate a child and adolescent psychiatrist who said he would see me and had an appointment in 2 weeks. So I waited. And I can say without the support of my mother, my sister-in-law, and some of the other amazing moms in my life, I don't know how I would have gotten through it. I also got in to see a therapist who was incredible. When I finally got to the psychiatrist, I was starting to feel better. He wanted to put me on a medication that would not allow me to continue breastfeeding. And working at that time for the Texas chapter of the AAP, breast is best was the mantra. And it's important to encourage breastfeeding. So I was crushed. Along with the stigma of a mental health condition, I thought that I was shortchanging my child if I put my mental health above giving her breast milk. Luckily, everyone around me said, your child needs you more than she needs breast milk. So I did what I had to do to get well. For a long time, I felt like the healthcare system had failed me at multiple turns. But as I've worked in mental health for a longer period of time, I realized that the system did exactly what it was designed to do. I was of advanced maternal age and was monitored closely throughout my pregnancy. I was incredibly physically healthy. I had superior care throughout my pregnancy and delivery process. I had an incredible OBGYN who performed an impeccable C-section. And by that, I mean, I have paper cuts that have left bigger scars than my C-section did. She delivered a perfectly healthy baby. The postpartum nurses at the hospital were so kind and helpful. They seemed more like angels than healthcare providers to me. Next slide, please, Shannon. So 7.5 years later, here we are. This is my daughter. We both made it. She did just fine with formula. And I am now able to manage my anxiety without medication for the most part. But I was lucky. I had so much more than so many women have: resources, a background in public health, access to information, good insurance. And yet those weren't enough to address the needs that I had. Access to the mental health care I needed was difficult to navigate, but it came eventually. However, in my experience, that wasn't the difference maker. My brother is a trauma surgeon here in Portland, where we live, and if I were in an accident, I would hope to be transported to his hospital. But there wasn't much that he could do for my situation. However, his librarian wife, mother of 2 with no medical training, was a huge part of the support system that saved my life. Next slide, please. So all this to say that social connectedness is an important predictor of health outcomes and plays a large role in the physical and mental health of not just an individual, but the entire community. Most of the research related to social connectedness and social isolation has been focused on older adults, But the pandemic has also illuminated how relationships impact teens in a significant way. I think the same principles can be applied to postpartum women whose daily experiences and connection to others can dramatically change in the perinatal period. Unfortunately, because of the postpartum reality of healing from birth, caring for a new baby, lack of sleep, feeding schedules, and transition back to the workplace, healthcare providers are some of the people that new moms see the most. Outside of screening, though, many providers aren't resourced or well equipped to address the mental health needs that present. Next slide, please. So we do have some wonderful community-based models which attempt to provide more holistic care, and these include things like nurse home visiting programs, community health workers, or as in Texas, we often call promotores, and certified peer support specialists. Unfortunately, many of these services are connected to an already overextended and underfunded public health system or healthcare system. They're often restricted by income eligibility or diagnosis criteria, so they may not be widely accessible. Payment rates are often inadequate, so recruiting a sufficient number of providers is also often problematic. I know that we have some midwives and doulas here today, and while I think that coverage for those critical services is improving, there are still limitations to access there as well. Expanding provider types and payment methodologies to be more inclusive of services that women need is critical, but I'm going to focus for a little bit here on a no wrong door approach that helps support women by making information more widely available to people in the places where need often first presents. Next slide, please. So the rising mental health needs that we're experiencing outweigh the ability of traditional care systems to meet those needs. Barriers to accessing formal care are numerous and varied, and while medical approaches often help define the problems and treat specific illnesses, the solutions to the problems that we have many times are rooted in social, relational, and community-based places. Who do we turn to first when we're sad? Who's around when we're struggling, but maybe haven't yet acknowledged that we have a mental health need? So to comprehensively meet these needs, our feeling is that we have to develop the capacity to equip community residents and organizations with skills and resources to better support those around them. There is a need to go a layer deeper in the support systems that are available to care for people wherever their need exists. Next slide, please. So knowing that our current mental health workforce is limited, we have to ensure that those services are properly distributed and available to those with the highest acuity needs. As mentioned, we need to think about the future workforce and make sure that we're creating a pipeline of providers that is more diverse and inclusive of provider types that support what women want and need. And we need to create capacity and capability in a new community workforce, those who are well positioned to provide support, but may need some basic training to develop the knowledge and skills necessary to create confidence to engage in discussions around some of these sensitive issues. Next slide. So recognizing the need to reimagine mental health support and service delivery to meet people where they are, Wellbeing Trust initiated a partnership with Harvard Medical School in 2021 to develop a model of care that seeks to enable and empower individuals within communities to identify and respond to mental health and addiction needs. And this is rooting care in existing assets. What we have called community or initiated care or CIC is based on the concept of task sharing, a model of intervention that is not dependent on licensed clinicians and has been successfully used internationally to provide care through community members who don't have specialized training in mental health. Next slide. There's a link here, and I won't go into too much detail, but as described, task sharing or task shifting is a common practice in other countries where the health systems are constructed very differently, and oftentimes mental health specialists are not available at all. By training community members to address basic mental health needs through evidence-informed practices, we can begin to shift services that might typically be reserved for the clinical setting back into a community setting. Next slide. I just want to provide one example of this that's linked specifically to perinatal mental health. It's called the Thinking Healthy program. This was initially implemented in Pakistan and trained community health workers to help reduce the prevalence of maternal depression in this low resource setting using cognitive behavioral therapy and child education interventions. So what this program did was use technology assisted training, and that allowed for training and supervision to be standardized as well as remote. So 80 community health workers, along with 4 community health supervisors, screened 12,000 women in Pakistan for maternal depression by going door to door, doing a survey and brief intervention. The digital tools allowed the training and brief intervention to occur without hands-on specialist supervision. A study of this indicated that participants who received the Thinking Healthy intervention had lower symptom severity and recurrence, and a cost evaluation showed a 37% reduction in training costs when using the digital technology as opposed to training by a specialist. So though this was successful, one of the barriers to scale was identifying peers who could provide ongoing support for mothers who were depressed. This program was so successful that it was adapted by the WHO, and multiple countries have begun using it now, including places in Vietnam and Peru. As the program has scaled, the peer support training element has been better integrated to help address the barriers that were identified and provide more comprehensive support. Next slide. So the core hypothesis behind community-initiated care is that by equipping trusted community agents with skills to help, we have the opportunity to change the trajectory of a person's mental health journey. This includes more immediately addressing mental health needs, reducing overall demand for clinical services, and complementing traditional care that may be necessary. I'm sure that I don't have to tell you all the old saying, it takes a village to raise a child, and I think that's absolutely true. But I also think that sometimes that support is hard to find for mothers. Next slide. So there are a few really great examples of community-initiated care happening in the US. The Confess Project, if anybody's heard of that, is a fantastic program that trains barbers in Black communities to support the mental health needs of men who come into their shops. But Strengthen Us, as you'll see here, is the particular brand of community-initiated care that Wellbeing Trust is developing alongside our friends at Harvard. And Shannon, there's a brief video on the next slide, and if we're able to play it, great. If not, it's on our website and people can always get it that way too.
Shannon, unmute yourself and let's see if that fixes this.
Yeah, sorry, Shannon, that's okay. You can stop it. It's not coming through for me at all, and that's okay. It's just a short video. Yeah. It's at the end of the presentation, there's a QR code that will take you to our website, and it's the first thing you'll see when you go there. So for anybody who's interested, you can take a look after the presentation. But it just, it provides a little bit of background on the things that I've described. So Shannon, if you go to the next slide, please.
Hang on, sorry, I'm stuck on the slide.
No worries. It might have to run its course. Good.
Let me exit out and then I will of the full screen.
Sure. And while she does that, I'll just say, our feeling is that Strengthen Us is a bold response that augments our current system's inability to fully respond to the demand for services by infusing support in a community setting where needs often first present. And by viewing our daily interactions as an opportunity to recognize and provide support to those in need, we all have the ability to tap into sometimes what is an unused resource. And so through a locally tailored approach to caring for those around us, we feel like we can reduce the incidence of mental health and addiction concerns, prevent their escalation, and reduce the unmet need for care. In doing so, hopefully this also helps to address associated inequities. Just want to be sure that I underscore this is not meant to replace our current systems of care, but complement them. We know that there is a very important place for clinical care, and not everything can be resolved amongst relationships with friends, neighbors, family. However, by equipping people in the community with knowledge and skills necessary to respond to the needs around them, we feel that that support can be helpful in bridging some of those barriers that we experience when we look for more formal sources of care. So next slide, please, Shannon. So this is the QR code that I mentioned. It will take you to our website, which outlines a little bit more about the Strengthen Us initiative. And you can see the video there as well. Currently, we're working on 2 parallel paths to deploying Strengthen Us into community settings. We're going to be releasing some overview videos outlining basic steps that someone can take to provide support at the end of June. This is going to correspond with a PBS release of a Ken Burns documentary called Hiding in Plain Sight, which explores the mental health needs through firsthand accounts of more than 20 young people. However, we want to make sure that people understand that this is not a prescriptive one-size-fits-all approach. We're very sensitive to the fact that needs and assets will vary based on geography, setting, focused population, and we don't have all the answers, and want to work closely with those who are most knowledgeable about the needs within their community to tailor training that is useful and relevant. So the president of our organization, who I know Stephanie has had the chance to meet, Ben Miller, couldn't be here today. He was sorry that he wasn't able to join, but he's in Pittsburgh discussing possibilities for a deeper community engagement, which is the second parallel path that we're working on, to really work within the community setting to listen and develop training unique to that community. And we are also beginning to work with a partner in California to think about how we can adapt the information and skills necessary for youth to help support each other. I know, there's so much expertise in the audience here around perinatal health and the distinct needs of postpartum women. And as we continue to think through how we can empower community members to better support each other, we would love to hear more from you all on the needs and gaps you see and how we can better use our existing resources in community and the relationships there to improve outcomes. So I'll just leave you with this last slide. There are a few resources here. I think Shannon will share slides with everyone afterwards. But just want to reiterate, I would welcome the opportunity to hear from you all and your thoughts that you have related to the community initiated care approach. And I think we have some time for questions. So just want to end by thanking you all again for having me here, and I'll turn it back over to Stephanie.
Thank you, Laura, for just taking the opportunity to share your story. It takes bravery in that space to just come and talk about what's going on in your own personal life and to be able to apply it to your passion. And it's very obvious and evident that through all of this, that helps you to be a better advocate in this space for maternal mental health and moms across the nation. So we appreciate you and all of your work. With that being said, I know I put in the chat that if you guys have any questions, to please make sure that you put those in the chat. I see a lot of just confirmations of just being thankful for people sharing the story. Thank you. This was great information. Over and over. There's statements about midwives doing the work as well. We need to make sure that we honor that space as well, because we do have clinical providers that are midwives and also OBGYN. So thank you for that. The statements about just being very powerful, beautiful stories. I mean, I could just say this over and over, and it's just so wonderful to just hear you all share and be so vulnerable in that space. I think that collectively our goal was to come together to share with you all how important community is, and how we can engage people and share information, whether it be in a non-clinical fashion and or clinical fashion. And we all share that responsibility to do that. And so part of what we want you all to walk away with today is, in our call to action, is empowering communities to make change through providing support, resources, knowledge, and access to the tools that are needed in order for people to have better outcomes, and to recognize that in that community, that it's not a segmentation of one or the other, but how do we integrate the care to ensure that all are best supported as well. I see another statement appreciative of the concept of placing and cultivating support within the community. Are there any questions that anyone has? Oh, here's a statement about loving that the fact that, Laura, you included the promotoras and the CHW as they've been underutilized and reaching a vast amount of mom and baby dyads. I think it's without saying on all of our advocacy that these public health initiatives are definitely underfunded. And most of the time we're looking at grant funds to be able to help us, but those are short-lived. And we need to strengthen that public health structure so that we can all do better in this space, so that when something clinically needs to happen, we have that structure. When someone doesn't have insurance or is underinsured, because that's also a prevalent population that needs help too. And then also at the ground level, what do we do there? But we hope that you all walk away, like I said, with just having a knowledge of all of the aspects of care, and that it's not just on the clinical provider, but all of us. So here's another emphasis of sharing the importance of community, collaboration between patients, community, and clinicians. So we hope that you walk away with that today. So I'm going to pause for a moment because I see some folks coming off camera, wondering if there are statements or questions from the panel as well, and then we'll tie up for the day. All right, Shannon, while I'm pulling up the closeout from, I can't remember who's doing this. Do you want to make any closing statements?
Yes, first of all, thank you everybody for all the presentations. Wonderful today. This summit would not have been a success without everybody's presentation and vulnerability and sharing their stories today. So I want to definitely say a thank you from the VNPC. As far as all the links that were shared and the recordings and the presentations, just check your emails. I will send them out throughout the rest of this week. I will be sending an evaluation tomorrow. Please be honest with your responses. This is the only way we know how to actually improve and make each of these summits better. So I want to turn it over to either Donald, our outgoing co-chair, or Arthur, our incoming OB chair, if you have anything you would like to add.
I'd just like to say thank you. I thought this was a spectacularly great day. I really enjoyed all the presentations and learned a great deal. And so I'm grateful for everyone's presentation and for their participation, and also for the participation of the audience. I think we had a really fabulous interaction, as best as you can, at least on Zoom. So hopefully we'll see everyone in October and at the live meeting. Arthur, did you want to add anything?
No, I just like to thank everyone, just like you did. And also this afternoon is just really helpful. I mean, I think all the traditional PQCs are struggling with how to get out of the hospital space, because that's actually not where the work, we saw the data, women are having struggles, not so much in the hospital, but also outside the hospital. So I think we're all looking at, how to get away from that. And, the question is, how does VNPC not be the traditional PQC, that we actually meet people where they are and do the work where it's needed? And that's the community. It's clearly obvious from data, from stories, from everything else. Now we just have to figure out how to do it. Not if we should do it, how do we best do it? We have, I'm still learning a lot coming from North Carolina, but there's clearly a lot of great partnerships and a lot of great people we can learn from and lead us rather than the other way around, which is the traditional way it's been dealt with. It's great to see how that's going to look and turn out.
And Shannon, what's the date of that's question in the chat box. The date of the October live meeting is October
23rd will be the reception in the evening. So relatively between 5:30 and 7:30 probably. And then October 24th will be in person.
which is a Monday, as I recall.
Correct.
We
Yep,
usually
our
have our
traditional Sunday,
in-person meetings on Mondays. So, all right.
All right, I'm gonna play our closing. Oops, just one moment. Issues.
Good afternoon, everyone. For those who don't know me, my name is Joseph Puri. I'm one of the neonatologists at the Children's Hospital of Richmond at VCU. I'm also the neonatal co-chair of the steering committee of the VNPC. I would like to thank everybody for coming today and for being present in our yearly Maternal and Infant Mortality Summit. I would also like to thank all our presenters who took time off their day today to come to present to us and to discuss with us their expertise. We learned a lot from them regarding infant and maternal mortality and how their different approaches are and the different data we have from the state. Our initial agenda had dedicated 2 hours this afternoon for our OBs and neonatologists to discuss infant and maternal mortality specific to their fields. We were also going to discuss the resurrection of femur. We know there's a lot of interest from across the state about resurrecting femur. However, we did not have enough data or any information to discuss this, so we put this session on hold. We are in the process of fact-finding and coming up with a plan as to how to proceed with this resurrection. If any of you would like to join us in this effort, please let us know and we will contact you and include you in further discussions that we have. Finally, I would like to bid farewell to Dr. Dudley. It's been a great 5 years working with you. You'll be missed. And I would like to welcome Dr. Allendorf as the new OB chair of the VNPC. I'm looking forward to working with you over the next year. I say only the next year because as per the VNPC bylaws, we will be also looking for a replacement for myself and a new neonatal co-chair for the VNPC starting next year. So more to come with that. With that, I conclude our summit for today. Thank you everyone for coming and have a great rest of the day and rest of the week. Bye-bye.
Thanks so much.
Thank you all. Good seeing you.
Thanks, everybody.
Bye-bye.
Thank you.